progressive respiratory disorder characterized by persistent airflow limitation and systemic inflammation. While traditionally it is viewed as a disease confined to the lungs, COPD is now recognized as a systemic illness with significant extrapulmonary manifestation, including cardiovascular disease, osteoporosis, and skeletal muscle dysfunction. Sarcopenia is defined by the European Working Group on Sarcopenia in older people as low muscle strength with low muscle mass and a low physical performance has emerged as a key systemic complication of COPD. The pathophysiology involves a complex interplay of chronic systemic inflammation, oxidative stress, hypoxemia, hormonal imbalance, nutritional deficiencies, and physical inactivity. Sarcopenia negatively impacts exercise tolerance, quality of life, and prognosis, and is associated with increased exacerbation rates, hospitalization, and mortality. Global studies have reported sarcopenia prevalence in COPD patients ranging from 20 to 40%, with higher rates in advanced disease stages. However, data from India remain limited and heterogeneous despite the country's high COPD burden driven by smoking, biomass fuel exposure, and environmental pollution. For early identification and targeted interventions such as pulmonary rehabilitation and nutritional support. Method and materials. This observational cross-sectional study was done in MMSR Mulana after obtaining approval from Ethical Committee of the institution. 100 patients of COPD were taken from indoor and outdoor wards of the MMSR hospital. All subjects were subject to detailed history and systemic examination for COPD, and severity of COPD was used using Gold's criteria, and sarcopenia was defined as per EWGSOP2 2019 criteria, using skeletal mass using BIA, muscle strength using handheld dynamometer, and gait speed by 6-minute walk test. In inclusion criteria, they were on all diagnosed cases of COPD. In exclusion criteria, patients admitted with pneumonia, septicemia, COPD acute exacerbation with other comorbidities, hypertension, type 2 diabetes, CKD, CLD, and malignancy were eliminated. Methodology. All selected subjects were detailed about their present, past, family, and personal history, especially about smoking, drug intake, and history of falls. Subjects were assessed for severity of COPD by undergoing pulmonary function test (PFT), and all subjects were subjected to EWGSOP2 criteria. Patients were first subjected to gait speed. In gait speed, first we have checked if the speed is more than 0.8 meter per second or less than equal to 0.8 meter per second. For that, in less than 0.8 meter per second, they were subjected to muscle mass. In case if they have low gait speed and low muscle mass, sarcopenia was present. If muscle mass was normal, then there is no sarcopenia. In gait speed, if it is more than 0.8 meter per second, they were subjected to grip strength. If it is normal, then it was no sarcopenia. In case of low grip strength, they were subjected to muscle mass, and again they were subjected to, if they have low muscle mass, they had sarcopenia. Otherwise, no sarcopenia was present. In my study, severity was divided according to Gold's classification: mild, moderate, severe, and very severe. In mild case, there were no cases of sarcopenia present, and 3 patients were present. In moderate case, there were 5 patients with sarcopenia, and 9 patients didn't have sarcopenia. Total 14 patients. Combining severe and very severe, there were 26 patients, 31.3%, and 57 patients did not have sarcopenia. Total sarcopenia was present in 31 patients, and 69 patients did not have. In case of muscle mass criteria, it was less than 7 kg and more than 7 kg. 67 males were there. Out of that, 27 males had sarcopenia and 40 did not. In female, less than 6 and more than 6. 4 female patients had low muscle mass and 29 had more muscle mass. Gait speed less than equal to 0.8 and more than 0.8. Less than equal to 0.8, there were 32 male and 35 male were in more than 0.8. In female, less than equal to 0.8 were 9 female and more than 0.8 was 24. Grip strength for males, it was less than 27 kgs and more than 27 kgs. So less than 27 kgs there were 30 males, and more than 27 kgs there were 37 males. In females, the criteria was less than 16 kgs, where we had 4 females, and in more than 16 kgs we had 29 females. Sarcopenia was present in 31% of COPD patients. Prevalence was significantly higher in males, 40.3% compared to females, 12.2%, and it was statistically significant. Most cases were clustered in the age of 50 to 69 age group. Low muscle mass was observed in 31 patients, reduced grip strength in 34 patients, and impaired gait speed in 41 patients. By gold grading, sarcopenia prevalence was 0% in mild, 35.7% in moderate grade, and 31% in severe and very severe COPD. The association between COPD severity and sarcopenia was statistically significant. Conclusion: the present study demonstrates the sarcopenia is a significant comorbidity among patients with chronic obstructive pulmonary disease with an overall prevalence of 31%. The burden was disproportionately higher in males compared to females, and sarcopenia was strongly associated with advanced stages of COPD as per Globe classification. Importantly, affected patients exhibited reductions in muscle mass, grip strength, and gait speed, reflecting impairment across all dimensions of sarcopenia as defined by contemporary diagnostic criteria. These findings indicate that sarcopenia is not merely an age-related complication but is closely linked to the severity and systemic nature of COPD. Our observations are consistent with global evidence suggesting that sarcopenia adversely influences pulmonary function, exercise capacity, and quality of life. Mechanistically, systemic inflammation, oxidative stress, hypoxia, corticosteroid exposure, nutritional deficiency, and inactivity like convergence to accelerate muscle dysfunction in COPD. The clinical implications are profound as sarcopenia identifies a high risk subgroup prone to exacerbations, comorbidities such as osteoporosis, and potentially increased mortality. Early recognition through routine assessment of muscle mass, strength, and physical performance is therefore essential. Incorporating pulmonary rehabilitation, nutritional support, and resistance training into comprehensive COPD care may mitigate sarcopenia, improve functional outcomes, and enhance long-term prognosis. Future multicentric longitudinal studies are warranted to further clarify causal pathways and evaluate the impact of targeted intervention. Thank you. Yes, sir. Sir, yes, sir. I agree. Sarcopenia can affect.
सर का क्वेश्चन ये है कि हैव यू एक्सक्लूडेड द अदर कॉजेज ऑफ सार्कोपीनिया?
Ma'am, other diseases associated which can lead to sarcopenia, like in chronic kidney disease, other comorbidities I have excluded, ma'am. Chronic kidney disease.
The age is important cause of sarcopenia. Geriatric patient they have more
Yes, ma'am.
sarcopenia. So you didn't mention the age of the patient.
Ma'am, my age group consisted of from 30 years to 76 years of patients, ma'am. All were subject.
So is there any division कि if the patient age is more, the more sarcopenia
Yes,
is there?
ma'am. In advanced ages, ma'am, from 50 to 69 years, which I have done in my study, significant amount of sarcopenia was present in that age group only, ma'am.
But you didn't show me in this your presentation. There is no correlation of age with
Age,
prevalence
ma'am,
of
age,
sarcopenia.
in my study, ma'am, age did not statistically correlated with sarcopenia,
Okay.
but it was observed that in advanced ages,
Okay.
ma'am, prevalence of sarcopenia was more noted, ma'am.
Okay. How you measure the muscle mass?
Ma'am, skeletal muscle mass we can use BIA, ma'am, or DEXA scan, ma'am.
Or
DEXA scan, ma'am. DXA, DEXA.
okay.
ma'am.
Suppose in COPD patients, most of the patients they have core pulmonary, so
Yes,
they
ma'am.
have edema all over the body. Then in such condition, there may be the false
Yes, ma'am.
result may come.
Yes, ma'am. In
So
that
you
case-
exclude all the core pulmonary patient, or you include
Ma'am, I have excluded, ma'am. Corporate.
excluded?
Yes, ma'am.
Because in your study there is no investigation like echocardiography and ECG. So how you exclude the core pulmonary?
ECG, ma'am, which I have seen, ma'am, if when all PVs are present and echo also in some patients it was done, ma'am.
Okay.
So where it was mentioned, ma'am, I have selectively excluded that patients, ma'am.
Okay. ठीक है Okay, so you got 31% of.
Yes, ma'am. Out of 100 patients, ma'am,
Out
31
of 100.
patients, ma'am.
Okay.
27 male and 4 were female, ma'am.
And what is the cause of COPD? Most common cause of COPD in your patient?
Ma'am, smoking was most important risk factor.
Smoking.
Yes, ma'am.
So, how many smokers they develop COPD in later stage?
Ma'am, it is a gradually progressive, ma'am. COPD, in my studies, ma'am, maximum patients were chronic
Okay,
smokers.
apart from your study,
Yes, ma'am.
suppose there are 100 patients of chronic smoking, how many of them they will develop COPD in later stage?
I mean, later stages, ma'am, if they continue to smoke, ma'am, then, ma'am,
It is mentioned in books.
more, ma'am, it will chance of getting COPD is more, ma'am.
More, that means how many percentage of them they develop COPD?
Percentage.
You did thesis in COPD, so
Yes,
you
ma'am.
must know how many percentage of smokers they develop COPD in later stage. It is near about.
My case was already, ma'am, diagnosed cases of COPD, ma'am.
Okay, okay. But
So I have already taken, ma'am, a diagnosed case only by doing PFT.
okay. Okay, sir.
Thank you. Sorry. Thank you, Dr.
Welcome.
Aditya. Thank you. Next is Dr. Akansha Gupta, please.
Good morning, everyone. I'm Dr. Akanksha. Today, my topic for the presentation is clinical profile and outcome in severe dengue patients in a tertiary care center. Dengue fever is a mosquito-borne viral infection caused by dengue virus, flavivirus, with 4 distinct serotypes. It is transmitted primarily by the Aedes aegypti mosquito and is a major cause of morbidity in tropical and subtropical regions, including India. The clinical presentation ranges from mild febrile illness to severe presentation characterized by plasma leakage, severe bleeding, and multi-organ dysfunction. Although many studies have been done regarding this thesis topic, like clinical profile and biochemical alterations in dengue, but very few studies have been focusing on the mortality part. SOFA and Apache-2 scores are commonly employed to assess the severity and forecast outcomes in critical care settings, but they may not adequately reflect the unique pathophysiological changes associated with dengue. This highlights the need for periodic epidemiological and clinical studies to better understand the prevailing patterns of severe dengue and identify the reliable predictors of mortality. With this background, our study was undertaken to assess the clinical profile and evaluate the outcome of patients with severe dengue admitted to MMI MSR Hospital, a tertiary care center in Mulana. Aims and objectives of this study was to examine the clinico-biochemical profile of patients admitted with severe dengue and to identify the key predictors of clinical outcome in severe dengue cases. The inclusion criteria was the patient's dengue NS1 antigen positive or IgM antibody positive. Patients meeting the WHO criteria for severe dengue were included in this study, such as severe plasma leakage leading to shock, fluid accumulation, like pleural effusion or ascites leading to respiratory distress were included. Severe bleeding in the form of hemoptysis or melena or gum bleeding were included. Severe organ impairment in the form of hepatitis, that is deranged LFTs, patients were included. Impaired level of consciousness or cardiac involvement or dysfunction of other organs like renal dysfunction were included. Patients not meeting the WHO criteria for severe dengue were excluded from this study, or the patients who didn't give the informed consent were excluded. Material and methods. This was a descriptive cross-sectional study conducted at MMISR Mulana Hospital. After obtaining the ethical committee approval, the patients were recruited from emergency department and ICU. Inclusion was based on WHO criteria. After admitting the patient, a detailed clinical history and examination was done. Or within 24 hours, patient's ABG, CBC, liver and renal function tests were done. PTINR, APTT, and serum ferritin were sent immediately. SOFA and Apache 2 scores were calculated within first 24 hours of admission. We also documented the requirement of non-invasive or invasive ventilation, requirement of single donor platelet transfusion, requirement of FFP, albumin transfusion, or inotropic support. Each patient was followed until mortality or discharge. Comparison of clinical and laboratory parameters was done between non-survivors and survivor group. It was noted that the mean age was around 51 in non-survivor. The patients which were expired included low mean BP, they have a higher pulse rate. The patients were in sepsis. The patients which not survived have higher INR, that is they have higher coagulopathy, and patients have higher deranged liver function test, they have higher OTPT, that indicated the patients were in organ dysfunction. And other parameters, the patients, most noted feature was clinical fluid accumulation in the form of ascites and pleural effusion. That was the most common feature that was noted. Second most common was bleeding manifestations in the form of hemoptysis, melena. The other was impaired consciousness level. Other features were less commonly noted. Then we noted the requirement of inotropic support and ventilatory support in survivor and non-survivor group. The patients who required inotropic support for shock management were better as compared to the patients who required ventilatory support for respiratory distress. This study was compared according to SOFA and Apache 2 scores. There was high correlation. The SOFA score was around 12 in non-survivor group and Apache around 26 with a p-value of less than 0.001 in both of them. In this study, total 56 patients were included. Majority were male, around 61%. The overall mortality was 21%. More than half have a platelet count less than 50,000, signifying higher, severe thrombocytopenia. The clinical leading features were fluid accumulation, noted in 64%, bleeding in 41%, and impaired consciousness in 30% of patients. Significant complications were acute kidney injury, noted in 26% patients, hepatitis in 25%, while MODS, encephalitis, ARDS were less commonly noted. Patients requiring clinical interventions such as IV fluids and inotropic management for shock management have relatively better outcomes than those who required respiratory assistance with mechanical ventilation were associated with significantly poor outcomes. Non-survivors have significantly higher pulse rate, leukocyte count, along with lower blood pressure, arterial pH, sodium and albumin levels. Severity assessment score showed clear prognostic value. The SOFA score among non-survivors was nearly 13 compared to 5 in survivors. Apache score was 26 versus 10 respectively, with both have p-value less than 0.01. This confirms that higher organ dysfunction and physiological derangement strongly correlate with mortality in severe dengue. Although ferritin and APTT levels tended to be higher in non-survivors, prothrombin time was significantly prolonged in expired group, reflecting the impact of coagulopathy. In summary, mortality in severe dengue was closely linked to hemodynamic instability, metabolic acidosis, liver dysfunction, and coagulopathy, with SOFA and Apache 2 scores emerging as strong predictors of outcome. Severe dengue continues to pose a major challenge in critical care with a mortality of 21% in our cohort. Adverse outcomes were related to shock, metabolic acidosis, coagulopathy. Non-survivors have higher leukocyte counts, hyperbilirubinemia, and multi-organ dysfunction. Prognostic scoring systems such as SOFA and Apache demonstrated strong discriminatory power in predicting mortality. APTT and ferritin showed less significant trends, but prolonged prothrombin time was noted. This signifies the identification of high-risk patients and aggressive supportive management in improving the survival in severe dengue patients. Thank you.
So in dengue patient, you admit all the patient?
Yes, ma'am. We have admitted all the patients. Ma'am, but patients which having only severe dengue were included according to WHO criteria. All other patients were excluded from this study.
Okay. Usually the complication come in dengue fever in which week? In what the duration of the complication?
Ma'am, around 21 days, around second to third week, most the complications in dengue fever were noted.
But you include both the test, NS1 and IgM.
Hanji ma'am, both.
So most of the patients, usually the NS1 become negative after 5 days.
Yes, ma'am.
So most of the patients, they come with you with either positive NS1 or IgM positive.
Yes, ma'am, but I have included the patients according to severity based on the clinical profile.
Okay.
Ma'am, like patients having severe bleeding in the form of melena, impaired consciousness level, or ma'am, patients having hepatitis, patients with acute kidney injury, or ma'am, like any cardiac manifestations, these patients were included. Ma'am, other patients having like NS1 antigen positive or antibody positive, but they didn't have these features, they were excluded from the study.
Okay. So there's no mandatory of the NS1
No,
and
no,
IgM
no, ma'am.
positive.
No, ma'am. No, ma'am.
Okay. Then all the complicated patients you
Yes,
include.
ma'am. Only complicated patients were included. The patients in shock or requiring inotropic support, impaired consciousness level, that patients were included only.
Okay. How you exclude the other causes of complication? This same complication.
Um,
There are many causes in which the patient have the bleeding tendency, the patient have the shock. How you exclude the
Ma'am,
malaria?
patients that have I included, ma'am, that must have the NS1 antigen positive patients were only included. But after that, patients, like there were other patients also which having NS1 antigen positive, but the patients were stable. The patients were admitted in ward. Ma'am, I have included patients only that were admitted in ICU or emergency department.
So you just focus on the NS1. NS1 become negative after 5 days. The complication usually occur in the second week.
Yes, ma'am.
At that time, NS1 become negative. So how you confirm your case that patient had the complication due to the dengue?
This was the only way to confirm according with antibody or antigen positivity.
Okay.
Ma'am, other than that, I have matlab seen the clinical profile, like patients having fever, warning signs were seen, patients having fever, rashes, bleeding manifestations, body ache, that patients were included for the like provisional diagnosis of dengue were kept. But after that, dengue profile serology was sent, and when patients in WHO criteria was applied only to patients having positivity of dengue NS1 or antibody. Other than that, ma'am, patients was difficult to be included.
So prevalence of the dengue is more in particular this region?
Yes, ma'am. Dengue prevalence is more, ma'am. My study is still going on. I have to include accordingly 100 patients. Ma'am, I have started study last year.
Okay.
Still, ma'am, dengue, this season's dengue patients are still coming in next month, or after that I'll be including more patients.
Is this seasonal variation? Most of the patients
Yes, ma'am.
come in?
Seasonal variation. In monsoon season, the most patients are observed. Ma'am, like in UP and Saharanpur belt, the patients are more coming in our area.
Okay. My last question. Patient, how many times the patient can have dengue?
Ma'am, patient can have dengue like multiple times. This may be possible.
No. You in the first line you told me there are 4 type of the dengue.
Hanji.
So a patient have only 4 times dengue.
Yes, ma'am. Okay.
Thank you, thank you.
History. Yes, yes, yes. Yes, yes.
You have a comorbid condition.
सर का point बिल्कुल
Mitigating a vast population at risk. Dyslipidemia in diabetes is typically characterized by elevated triglycerides, decreased high-density lipoprotein cholesterol, and increased small, dense, low-density lipoproteins cholesterol. This specific lipid profile, known as diabetic dyslipidemia, is a major contributor to the development of atherosclerosis. Advanced glycation end products formed due to chronic hypoglycemia further exacerbate vascular damage by inducing oxidative stress and endothelial dysfunction, both of which promote atherogenesis. Additionally, the atherogenic lipid profile often exists even in pre-diabetic individuals, suggesting that lipid disturbances begin early in the disease course. The study was conducted to assess the prevalence of dyslipidemia among patients with type 2 diabetes mellitus and to explore the correlation between glycemic control and lipid profiles. The goal was to determine whether patients with good glycemic control exhibited more favorable lipid profiles compared to those with the poor control. Establishing such a correlation can guide clinicians in early identification and management of dyslipidemia in diabetic patients. Prompt intervention, including lifestyle changes and pharmacotherapy, can help prevent the onset of diabetes-related complications, ultimately improving the quality of life and reducing overall burden of the disease. The aim of this study is to investigate dyslipidemia associated with type 2 diabetes mellitus and to examine the correlation between HbA1c and the lipid profile in individuals with type 2 diabetes mellitus. Materials and methods. This prospective observational study was conducted at the Department of General Medicine, Institute of Medical Sciences and Research, Malwa, from August 2023 to December 2024. Ethical approach has been obtained from the Ethical Approval Committee of Institute of Medical Sciences and Research, Malwa. The study population. This cross-sectional study included 100 patients diagnosed with type 2 diabetes mellitus based on the American Diabetes Association criteria. Patients were selected according to the specific inclusion criteria. The patient was selected according to specific inclusion and exclusion criteria and provided written informed consent. A detailed history was recorded, including symptom duration, complications, family history, and lifestyle habits. Clinical examination focused on signs of anemia, insulin resistance, and hyperlipidemia. All participants underwent laboratory testing for fasting blood sugar, postprandial blood sugar, HbA1c, and lipid profile. Lipid profile testing included total cholesterol, HDL cholesterol, and triglycerides, while LDL cholesterol was calculated using the formula HDL, total cholesterol minus triglycerides by 5 minus HDL. Patients was categorized into two groups based on HbA1c level, Group A with HbA1c less than 8 and Group B with HbA1c more than 8%. The lipid profiles of both groups were compared and the correlation between HbA1c and lipid levels was statistically analyzed using the t-test to determine significance. In this study involving 100 patients with type 2 diabetes mellitus, the distribution of subjects by sex was equal in both groups based on HbA1c levels, with each group consisting of 25 males, 25 females, indicating a balanced sex ratio. Age-wise, both groups had a fairly even distribution, though a higher proportion of older individuals was seen in the group with HbA1c more than 8%. In Group A, the most common age ranges were 41 to 50 and 61 to 70 years, while in Group B, 30% were in the 61 to 70 age group. Regarding dyslipidemia, it was significantly more prevalent in Group B, where 82% had combined dyslipidemia and only 4% had normal lipid profiles compared to Group A, where 54% had combined dyslipidemia and 18% had normal lipid levels. Overall, 89% of the total diabetic population exhibited dyslipidemia, highlighting a strong link between poor glycemic control and lipid abnormalities. In this comparison, glycemic control, several severe statistically significant differences were observed. Mean HDL cholesterols were higher in the poorly controlled group than in the other group, with a significant difference and a strong positive correlation with HbA1c. Furthermore, 70% of patients in Group B had elevated LDL levels compared to 48% in Group A. Triglyceride levels also showed a significant increase in poorly controlled group compared to the Group A, with a moderate correlation to HbA1c, and 92% of Group B had elevated triglycerides versus Group A. Additionally, the total cholesterol by HDL ratio was significantly higher in Group B compared to Group A, with a very strong correlation with HbA1c. Overall, these findings indicate a consistent and statistically significant relationship between poor glycemic control and an unfavorable lipid profile, including elevated LDL, triglycerides, total cholesterol by HDL ratio, which are the key contributors to cardiovascular risk in diabetic patients. The cross-sectional study was conducted to assess the prevalence and pattern of dyslipidemia in patients with type 2 diabetes mellitus. and to evaluate the association between hyperglycemia as indicated by HbA1c and lipid abnormalities. A total of 100 patients with type 2 diabetes included in two groups. Group A, HbA1c less than 8% and Group B, HbA1c more than 8%. Various lipid parameters including total cholesterol, HDL, LDL, triglycerides and total cholesterol by HDL ratio and non-HDL cholesterol were analyzed and compared between the two groups. Out of the total sample, 89% of the patients demonstrated dyslipidemia defined by at least one abnormal lipid parameter, consistent with the previous studies showing a high prevalence of dyslipidemia in diabetic populations. Group B, where the HbA1c was more than 8%, had a higher prevalence of combined dyslipidemia than Group A. Triglycerides were the most commonly elevated parameter, followed by non-HDL cholesterol, HDL, total cholesterol by HDL ratio, total cholesterol and HDL cholesterol. Total cholesterol levels were significantly higher in Group B than in the Group A. A strong positive correlation was observed between HbA1c and total cholesterol. The LDL cholesterol was also significantly higher in Group B versus Group A, with a positive correlation to HbA1c. The study reveals that dyslipidemia is a highly prevalent among patients with type 2 diabetes mellitus, particularly in the patients with the poor glycemic control. HbA1c correlates strongly with the total cholesterol, LDL, triglycerides and non-HDL, while showing an inverse correlation with the HDL cholesterol. These findings highlight the importance of monitoring lipid profiles alongside glycemic control to prevent long-term cardiovascular complications in diabetic patients. Early intervention targeting both glucose and lipid levels could substantially improve clinical outcomes and reduce the disease burden. My conclusion is that this is a cross-sectional study of 100 type 2 diabetes mellitus patients, which revealed that 89% had dyslipidemia, with 68% exhibiting combined lipid abnormalities. According to NCEP ATP3 guidelines, elevated triglycerides, non-HDL cholesterol, LDL cholesterol and total cholesterol by HDL ratio, total cholesterol and low HDL cholesterol were commonly observed. Patients with HbA1c above 8% showed significantly worse lipid profiles compared to those with lower HbA1c levels. HbA1c demonstrated strong positive correlation with most lipid parameters and a negative correlation with HDL cholesterol, suggesting its potential role as a useful marker for identifying dyslipidemia in diabetic patients. Thank you.
You are doing comparison of the
HbA1c and the
with
lipid.
give the pharmacological therapy.
Ma'am, if it is
According
more
to the
than
recent
80,
guideline.
if it is more than 80,
Hmm.
then we start with the pharmacological therapy. And if it is less than 80, we prefer for a lifestyle or for dietary modifications.
Do you know about Lipid Association guidelines? Or Indian Lipid Association exists or not?
Sir, I'm not quite sure about it.
That is very bad. Because we are in India, we cannot go for Western guidelines. And if doing PG, you are unaware of Lipid Association of India guidelines for dyslipidemia in every aspect, for acute coronary syndrome, diabetes, etc. And what are the targets for Indians? You are treating Indians, not Americans.
So total cholesterol, if we take according
No,
to...
no, cholesterol doesn't matter. What does most important parameter for lipid out of all the lipids?
Less HDL and more of the triglycerides.
Once you say less HDL, I will not pass you for next 10 years. I am specific for that. It is LDL which matters.
LDL which matters.
And now you won't believe, I think you must not be aware that what are the LDL targets in very high risk case category C? What are the targets? Less than 30. And optimum is 10 to 15 milligram per deciliter of LDL.
And I can
Yes, sir.
add one thing, you see, you try your best in your word, you see, you will not be able to achieve it.
नहीं सर वो हो जाता है
नहीं होता, ये कभी
मेरा
नहीं
भी है
होता।
जी मेरा भी है सर
Just suppose you reduced the lipid profile so much, in very minimum level, what complication may occur?
Ma'am, generally in Less of the lipid profile, generally it is seen in cirrhotic patients, whereas the triglycerides, the total cholesterol and everything is less. Uh, Cirrhotic patients, ma'am, it can have an impact on the liver if we reduce it too.
The only advice next time, so you study your lipid profile set of India's guidelines.
Yes, sir.
That will be better for you.
Yes.
Thank you.
Thank you.
Next is Dr. Atridev Mishra. Hopefully I have pronounced it right.
Good morning, sir. Good morning, ma'am. I am going to present, this is a presentation based on my thesis topic, Evolving Trends in Altered Sensorium, an observational cross-sectional study in a tertiary healthcare center in northern India. Altered sensorium is a frequent and critical clinical presentation in the emergency department and inpatient practice, encompassing a spectrum from mild confusion to deep coma. It reflects disturbances in the fundamental components of consciousness, arousal, and awareness. This condition poses a diagnostic challenge as varied etiologies can present with similar clinical features, leading to potential delays in management and increased morbidity and mortality. Evaluation involves clinical assessment using tools like Glasgow Coma Scales and along with laboratory and neuroimaging investigations to identify reversible causes. This study aims to analyze the etiological profile, clinical and biochemical parameters, and prognostic indicators of altered sensorium in patients presenting to MMIMSR Mulana, which is a tertiary healthcare center in northern India. This study, observational cross-sectional study, was done from April 2024 to June 2025 after obtaining approval from the ethical committee of the institution. Patients were taken from the emergency department and medical intensive care unit. After obtaining written consent, all the participants underwent history and physical examination and biochemical and relevant radiological investigations as per the pro forma of my thesis. Inclusion criteria was all the patients who presented with GCS less than 15 and were above the age of 18 years and admitted to our hospital, and those who consented to participate in the study. The patients who had less than 15 GCS but were having trauma like head injury and post-operative patients and patients with known neurological conditions and psychiatric illness were excluded from the study. The sample size total of the study was 250 patients. As usual, proper written and informed consent was taken from all the patients. Clinical history and examination, all relevant investigations were done. Scoring systems like SOFA and Apache 2 were used to calculate the risk and prognosis at the time of admission. And patients were followed up till the hospital stay, and prognosis were determined based on the duration of the hospital stay and the mortality of the patients. Data was collected on predefined pro forma and statistically analyzed. Among those patients that consented, 109 patients had to be excluded due to different reasons, like 24 patients had head injury and trauma, 11 patients were of age less than 18 years, 46 patients were diagnosed with chronic psychiatric illnesses and known neurological conditions, and 28 patients left against medical advice. All the other patients, that were 250, were followed up during the time of their hospital stay. This is the comprehensive result that I gathered during the study. Patients with etiology of sepsis, that is infectious causes, had the highest case fatality rate, and those with respiratory infections especially had the highest fatality rate, which is around 69.2% for the overall infection or sepsis category. Patients that presented with metabolic causes had the best outcome, and around 87.5% of the patients who presented had a uneventful recovery. Patients with neurological disorders had a good recovery rate, had less mortality relatively, but they had a prolonged hospital stay, which may be due to the prolonged need for rehabilitation and physiotherapy to return them to their usual lifestyle. Various clinical and laboratory parameters were assessed during the hospital stay of the patients, and among them, among the clinical parameters, mean arterial pressure, SpO2 and GCS had significant correlation with the outcome. Low MAP, low SpO2 and low GCS had a poor outcome. Among the biochemical and biochemical parameters, high TLC, low platelet count, low albumin, high urea and high creatinine levels, low pH, low PO2, low bicarbonate and high lactate levels had a significant correlation with poor prognosis. In the severity scoring systems, SOFA and Apache 2 were estimated, and the SOFA of the surviving patients were 14, while the mean SOFA in the patients who did not survive was 24.9. And also Apache was 14 and 24.9. SOFA was in the mean survived patients was 4.33, while in the patient who did not survive was almost double, that is 8.61. ROC analysis was done among the parameters that showed significant variations, statistically significant variations, and among them it was seen that Apache 2 had a highest area under the curve, signifying that it has a highest correlation with the outcome of the patient. It has also a high sensitivity of 71% and a specificity of 87.4%. 87%. SOFA and Apache had shown excellent performance in predicting the outcome and also lactate. And other parameters like mean arterial pressure, albumin, TLC and creatinine and GCS were not that much up to the mark in predicting the prognosis of the patients. Conclusion. In our study, sepsis emerged as the leading cause of altered sensorium and was also associated with highest mortality, particularly when linked to respiratory infections. Patients with neurological disorders needed a longer hospital stay, but with the necessary care and rehabilitation, they showed potential for recovery. These findings emphasize the importance of early recognition of the underlying etiology in guiding prompt treatment and improving survival. When comparing prognostic tools, integrated scoring systems proved more reliable than individual clinical or laboratory parameters. Both Apache 2 and SOFA scores showed strong predictive ability and outperformed single measures. Therefore, combining structured severity scores with simple bedside parameters can serve as an efficient and evidence-based framework for early risk stratification and timely intervention in patients presenting with altered sensorium. Along with this, I also noted that in similar previous studies, the leading cause of altered sensorium was mainly neurological involvement, and however, in my study, the leading cause was sepsis. This is a recently changing trend that has been noted, that may be probably due to that in initial stages of infection, patients usually take over-the-counter medications, and even antibiotics are freely available. So often they get less than required treatment, and only present in the emergency department, especially of tertiary healthcare centers when they have significant organ dysfunction, and which often presents as altered sensorium. Thank you.
Suppose any patient come to you with altered sensorium, what you will do first?
Ma'am, for any patient that presents in emergency, I will do a detailed clinical examination and also take the history
No.
like.
Before detailed clinical examination, before taking the history in details, what you will do first?
Ma'am, I will obviously rule out the immediately reversible causes, like I will check for RBS of the patient.
Yes, blood sugar.
Blood
This is
sugar.
the must. This is the first and most important thing you have to do.
Yes, ma'am.
You just check the blood sugar, and meanwhile you take the history and the examination.
I think the important part again is, so you must exclude all the chronic debilitating disease before you see anybody present you with altered sensorium.
Yes, sir.
Because even you see a young person with pneumonia, probably even with sepsis, have a better prognosis than somebody who's already having chronic obstructive airway disease and presenting to you with septicemia.
Yes,
So
sir.
I think that part is more important. You see, whenever you see in clinic exam, as you said, the blood sugar, the second part is the most important thing is the time is important. First, you must maintain the respiratory, the airway sort of a thing.
Yes,
see,
sir.
before doing any investigation. That is more important.
Yes, sir. Yes, sir.
Okay, just in one slide you mentioned that mean arterial pressure have the poor prognosis.
Yes,
It
sir.
is well known.
Yes, ma'am.
How you calculate the mean arterial pressure?
Ma'am, we measure the systolic and diastolic blood pressure, and the difference between systolic and diastolic blood pressure, that is the pulse pressure. I have to divide the pulse pressure with 3 and add it to the diastolic pressure. That gives the mean arterial pressure.
Okay, so if the mean arterial pressure is less than 60, poor prognosis,
Yes, ma'am.
right? Okay. How many of your patients they have the focal neurological deficit with altered sensorium?
Ma'am, they were relatively less, mostly in the patients that were later diagnosed as with CNS involvement had that around 23%, I think.
Focal neurological deficit.
Yes,
And rest of them, they have no focal neurological deficit.
Ma'am, they presented mostly with generalized low GCS, less response.
Okay.
Not
Because
less.
the protocol, the altered sensorium with focal neurological deficit, the protocol is different.
Yes, ma'am.
The altered sensorium without focal neurological deficit, the evaluation is different.
Yes, ma'am. Yes, ma'am.
So you are getting less patient of focal neurological
Yes, ma'am.
deficit. And most of the patient, they have no focal neurological
Yes, ma'am.
deficit. Okay. Then how you proceed? If the patient have altered sensorium, no focal neurological deficit, what will be your approach?
Ma'am, in patients with altered sensorium but no focal neurological deficit, I will suspect a systemic cause. First, obviously, I will rule out hypoglycemia. Also, I will rule out complicated hyperglycemia and electrolyte abnormalities. And I will take history if the patient has had fever, if the patient has a chance of having sepsis.
The other thing is you add one line when you say the consent. And the consent is probably most of the times from the relatives, not from the patient.
Not
because
from
he's
the patient,
already,
yes, sir.
he's not
Yes,
in a
sir.
position to give you a consent.
Yes, sir. Yes, sir.
So you can add that into your paper, you see. But you
Yes.
didn't mention about the consent. You just said the consent is by the relatives.
Consent by the relatives only, yes, sir.
Thank you.
Thank you, sir. Thank you very much.
वो कह रहे थे पौने 12 में कब पौने 11 डॉक्टर चारू लेखी प्लीज ये तो आपका है
Good morning, everyone. So I am here to present the paper on the topic of association of anthropometric measurements in lipid profile in hypertensive adults. Introduction and objectives. Hypertension affects 1.28 billion adults worldwide, mostly in developing countries. Obesity and dyslipidemia are the key modifiable risk factors. Anthropometric indices like BMI, waist to hip, and skin fold thickness reflect adiposity distribution. Objectives: to assess the relationship between anthropometric indices and lipid profile in hypertensive adults. Methods. This was a case control study. My total sample size was 200, out of which 100 patients were of hypertension and 100 were normotensive people. Measurements. Anthropometry. In anthropometry indices, BMI was measured along with waist circumference, height, waist to hip ratio, and skin fold thickness, which included biceps, triceps, subscapular, and suprailiac skin fold thicknesses. Lipid profile was measured, and it was all done after getting the ethical approval from the ethics committee. So about the results, about the lipid profile, in hypertensive patients, the triglyceride value was 200 versus 172 in the normotensive patients, and triglycerides were around 147 in hypertensives and 111 in normotensive patients. LDL was 131 versus 96 in the normotensive patients, and as per the HDL, it was 39 in hypertensives and 54 in normotensives. All were clinically significant. All had the p-value of less than 0.0001. Results in anthropometric and correlation. Hypertensives had higher BMI, which was around 27 versus 25.4 in normotensives. Waist circumference was 102 in hypertensives versus 92.6 centimeter in normotensives. Coming to skin fold thickness, all triceps, subscapular, and suprailiac thicknesses were significantly correlated, but biceps skin fold thickness was not clinically significant and was not correlated to the hypertension criteria. And discussion. Central obesity markers, waist circumference, waist to hip ratio, truncal skin fold thickness are stronger predictors than BMI. And my findings align with an prior study which was done by Kumar Ray and Chaudhary et al. The mechanism behind it is visceral fat. It will lead to increased inflammatory cytokines, increased insulin resistance, and it will lead to atherogenic lipid profile. Waist-based indices are more reliable than BMI in predicting the risk. The conclusion of the study was hypertensives show higher central adiposity and atherogenic lipid profile. Strong association was noted among subscapular and suprailiac skin fold thicknesses and waist indices. Implications: simple anthropometric measures are cost-effective screening tools. Thank you.
How you measure the skin fold thickness?
I used Harpenden calipers. So I measured tricep thickness, bicep skin fold thickness, suprailiac and suprascapular skin fold thicknesses.
Okay. How can you exclude the other causes of the dyslipidemia in hypertensive patient?
My exclusion criteria was people aged less than 18 years of age, pregnant women,
Okay.
and people who have secondary hypertension. So this was my exclusion criteria.
No, dyslipidemia is a common finding. It is
Yes, yes.
associated with many diseases. Okay. Check. Thank you.
Thank you.
Thank you.
So good morning, friends. So now we are starting the real scientific session after the very important paper presentations. I think that is the foundation of what you will become in the future. So seeing Dr. Preetham Singh or Dr. Gursaran Kaur, you will know that this is the foundation. If you are presenting the papers now, keep the academic, what you can say, fire burning. So in our times, there was no paper presentations. I am talking about 1990. So then my friend, who was a great academician, and you will meet him today, Dr. Gurpreet Singh Wander, asked me what you are doing. I told him I am posted in a PHC nearby in Gunyana. How many ECGs you do in a day? At that time, we were doing 25 to 30 ECGs in a day. So he sent me a protocol for standardization of ECG in females. So I did about 2000 ECGs, analyzed them, and sent him the data. So that was my first paper presentation in API in 1991. And after that, there was no stopping. But one thing, कितने paper presentations आप बैठे हो? But you must inculcate reading the guidelines and submitting the papers accordingly. This I am going to tell each and every paper session, because I did not receive even a single paper which is fitting the guidelines. That is abstract, less than 250 words in Word document, and PPT slides. PPT slides were okay, but coming. So I'll invite him to present his lecture on antimicrobial stewardship. So this is real important. Day before yesterday, there was a big article in Times of India as well as editorial about antimicrobial resistance being increasingly prevalent in India. And that is why Punjab government is contemplating that we should go in for strict prescription controlled antibiotic sale. So I invite Dr. Preetham Singh, please. We are really honored to have you here, sir. Thank you.
A very good morning to you all. I can see the legends of the region, some contemporary colleagues and younger friends. And I would like to thank Dr. Vittal for inviting me for this lecture. I'm truly honored, sir. Beginning with my lecture, antibiotic stewardship. Anybody, what is the literal meaning of stewardship? From PGs and all, so residents. What does stewardship mean? Stewardship actually means, literal meaning is taking care of something. Like when we are sick or critically ill patients, what do? We prescribe them antimicrobial agent, antibiotics to take care of them. But in the reverse manner, we also have to take care of antibiotics so that we are already facing that problem of widespread antimicrobial resistance. So often we see the report, this so-and-so bacteria isolated, it is resistant to all of them. And then we are stuck up what to give. So antimicrobial stewardship is nothing but a bundle of interventions that are aimed to counter the emergence of antimicrobial resistance. But why does this bacteria develop resistance? Yes, why do they have the bacteria? Come on, yes, give me some reasons. Anybody? It's not that difficult game. How do or why do bacteria or any microbial agent develops resistance against antimicrobial agents? Come on, yes, very good. I like interactive sessions, yes. Mutations. Okay, that is something that is not in your hand, something happens by the law of nature, you can't help it. Okay, that is one of the mechanisms. What else? What contributes to development of, one is, I take your point. Exactly. Both underusage and overusage of antibiotics leads to this problem. And it's not like that this thing is happening at PhD level or something. Even tertiary care institutes have irrational prescription of antibiotic, least to say. Here we see fever for 3 days, and the resident has prescribed Typhiloc, which is a combination of antibiotics, suspecting it to be enteric fever. Too early to suspect with a fever of 3 days. This one shows diagnosis of old roadside accident, acute viral hepatitis, and lepto-IgM positive. I presume the patient was given treatment for both viral hepatitis and leptospira. But is it common a person to have both at the same time? Again, some irrational prescription is there. Diagnosis labeled as tubercular meningitis. The first IV agent I see is ceftriaxone. These are very common practices. We try to cover with everything. पता नहीं report में क्या आएगा क्या नहीं आएगा. Let's give the best shot, and the best choice is combination cocktail of everything. But this is not the best approach. And that, I would say, irrational or indiscriminate use of antibiotic is most common setting is in the settings of not ICUs, because the patients are already critically sick. We don't have that much of time to wait for investigation. We have to protect them, but it shouldn't be there at least in OPDs. Now let's see. We have a 45-year-old male, has fever for 3 to 5 days, which is high grade, not responding to conservative treatment, antipyretics, has body aches, myalgia, pretty much similar to a viral prodrome. On the top of that, patient has certain skin rashes. What do you make out of it? Diagnosis? See, all the dermatological diagnoses are usually the spot diagnosis. It has chicken pox because it has dew drops on rose petal appearance. It is with a clear fluid-filled vesicle on the base of on an erythematous base. I'll skip that one. Yes. The skin of the face is red, thickened, tender. Slapped cheek appearance. Diagnosis: erysipelas. On a younger child, the quality of picture is not that good, but the rash is of measles. Everybody must be knowing this thing. Usually find it on feet. Meningococcemia. Another patient with same history, but a different type of rash. Diagnosis is: it is a black thing that has gone dead. We call it eschar, seen in scrub typhus. Diffuse erythematous rash, which is blanchable, lower limb, dengue, very good. So what I'm trying to say, there are very many possibilities for a patient with fever with skin rash. Some of them happen to be viral, some of them happen to be rickettsial in origin, some are bacterial, pyogenic in origin. So making a right diagnosis will lead to the right prescription. You can't prescribe antibiotics for dengue. Scarlet fever. So there are so many things. Some of them are all it. What is this diagnosis? Yes? Herpes. No. Herpes has a dermatomal distribution. The lesions are quite discrete and not that red. On the chest, commonly seen acne vulgaris. What is it? I would appreciate if other members of the audience can also contribute or be interactive enough. Sty? What is the treatment for it? Yes, louder. And? Epilation. You take out that infected thing and you don't need to prescribe antibiotic, not even topical ones for it. So coming back to antimicrobial resistance, why does it happen? Someone said mutations, which can be either primary or secondary. Primary means the infective agent at the time of entry into the host was itself resistant. And second is, during the course of infection, it develops resistance. The reason could be over or underutilization of antibiotics or antimicrobial agents. Shortage of diagnostic tools. At times, you're not sure whether it is of bacterial origin, viral, fungal, we tend to prescribe things. If the patient is critically sick, we have no way out, we have to cover for majority of them. But yes, if the patient is hemodynamically stable, is not that critically sick, we should preferably wait for the investigations. Maybe like a patient, suppose a patient who is on case of rheumatoid arthritis and on steroids for quite some time and develops pneumonia, which is not getting cured with routine antibiotics, what will you suspect? Is there a possibility of maybe fungal pneumonia in those patients? What test will we perform to diagnose it? Heard of procalcitonin, heard of beta-D-glucan? A negative procalcitonin and a high beta-D-glucan is highly suggestive of fungal infection. But the problem is we may be short of diagnostic. Beta-D-glucan is not readily available even in my institute, and if the patient gets it done from outside, it costs around 7,000 to 8,000 at least. So sometimes we are short of diagnostic tools. Hand hygiene, quite obviously, so that we do not cross-transmit infection from one infected patient to other non-infected patients. Farming industry has been blamed for indiscriminate use of antibiotics in their cattle feed and poultry feed, just to make sure that their poultry is alive and kicking and they don't suffer an economic loss because of loss of bulk of those cattle or poultry. So what they do, they mix heavy dose of antibiotics in their feed and feed them so that they don't fall sick and they're able to sell them. Like we discussed, the OPD syndromic approach to fever with skin rash. Likewise, patients with respiratory illness can also be, on clinical basis, easily we distinguish into URI and LRI, but upper respiratory tract infection and lower respiratory tract infection. Do the patients of upper respiratory tract infection deserve a course of antibiotics? Never? If so, in which conditions will you give? Again, it is a common practice. Patient 2-3 दिन के साथ भी आता है तो everybody does give him some cefixime and give or levoflox, give some azithromycin. That's not the case. Only in patients who have persistent or worsening symptoms beyond 5 days, they may be put on antibiotics. Patients with non-responding fever, patients who have immunocompromised status for whatever reason, whether it is primary immune deficiency, HIV infection, patients on steroid or chemotherapeutic agents, then only. Even for lower respiratory tract infection, if the patient is not requiring oxygen supplementation, hemodynamics are stable, and chest X-ray is normal, even those lower respiratory tract infection can be managed conservatively with antipyretics and nebulization. Only those who are oxygen requiring, have some hemodynamic alteration, or have some definite patch on X-ray are the candidates who will be prescribed antibiotics. Urinary tract infection, everybody sees those patients. What do you think? A patient comes through you with complaints which are highly suggestive of urinary tract infection. What will you advise in the prescription part? Will you give antibiotic at the outset or not? Depends, there's some catch. If the patient has upper urinary tract infection, that is beyond urinary bladder, higher up comes pyelonephritis, pyelonephritis. Those conditions are organ threatening, definitely they will need antibiotic. Or if the patient has underlying immunocompromised status, whether irrespective of whether it is upper or lower UTI, upper or lower urinary tract infection, he or she will need antibiotics. But patients who are otherwise healthy and have lower urinary tract infection, be it cystitis or urethritis, should wait for culture report. We are not preventing anything devastating by prescribing antibiotics 2 days earlier in a case of simple UTI. You can give symptomatic management, you can give antipyretics, and you can give antispasmodics, but wait for culture report within next 2 days. Another clinical syndrome frequently patient visits is acute febrile illness with jaundice. There are multiple diagnoses to it, ranging from acute viral hepatitis, cholangitis, liver abscess, leptospirosis, scrub typhus, all of them, complicated malaria, expanded dengue syndrome. All of them can count derangement of liver function test with visible jaundice. Out of these, which one are the ones that will not require routine use of antimicrobial agents or antibiotics? Sir knows everything, but the residents should come up with the replies. Acute viral hepatitis is one of them. Okay, yes or no? AVH antibiotics, yes or no? No. Cholangitis? Liver abscess? If it is a solitary liver abscess? Yes, but which one? Metronidazole, because a solitary liver abscess is likely to be amoebic in origin. Don't give piptaz, don't give ceftriaxone, don't give monosef, all those drugs. Leptospirosis, yes or no? Yes. Scrub typhus? Yes. Which one? Doxycycline. Man, the exercise is for the residents. Complicated malaria, although it will require antimicrobial agent, but it is not the usual antibiotic, it's anti-malarial agents. Drug of choice? Complicated malaria? Artemisinin based therapy, क्या देते हैं injectable? Felsigo? Artesunate, yes. And expanded dengue syndrome, again, it is symptomatic management, no antimicrobial agent. So with the same clinical presentation, you have to hit the diagnosis sometimes solely on basis of your clinical knowledge, at times with the help of investigations, like we saw in case of urine culture. However, there are certain situations when the presentation is severe enough or it is life-threatening, like meningitis, patient with sepsis or multi-organ dysfunction, severe pneumonia, infective disease. All these patients will require empiric antibiotic therapy. You are justified there to give antibiotics without any available culture report, just solely on the basis of clinical diagnosis, local epidemiology, and local antibiotic resistance pattern that you observe in your workplace. So for what it was, antimicrobial stewardship is not solely the job of the clinician. It is a multidisciplinary approach. You have to involve microbiologists also. There has to be one pharmacist also. So there is a group of people who take care of these things. What microbiology people tell, and the clinician should also have some basic knowledge about performing the right test with the right sample at the right time with right transportation. What does it actually mean, right test? Can you give me an example? Because most of the times, the tests to diagnose a particular disease, they are standardized. कि आपको TB diagnose करना है तो आप जो भी sample लेंगे उसमें CB net भिजवा रहे हैं, ग्राम्स AFB ट्रेनिंग कराएंगे, आपको infective endocarditis देखना है तो blood culture कराएंगे and echocardiography कराएंगे. So what do you mean actually by then right test, if everything is so well specified? We all had gone through Anant Narayan in our UG days, microbiology, enteric fever. The sequence of test was BASU. First week is, second week is, third is, and fourth week is. So that is the right test. Which week, which test to go for? Right test. Like a patient with the fever of 3 days shows thrombocytopenia for dengue. We all know there are 2 tests available. Which one? And dengue serology. Which one will you perform? Before 1 week, NS1. After that, serology for IgM. So there are certain scenarios where we have multiple choice of investigation or tests that you can perform, but you have to judge which one is the right for that type of patient with that presentation. The right sample. We also must know what sample is to be sent for, like take a case of pneumonia. How do we diagnose pneumonia? On etiological basis. Clinical diagnosis is okay, patient has fever, some chest, shortness of breath, cough, you perform an X-ray, there is a pad, beautiful pad sitting in there. Clinical diagnosis of pneumonia is made, but how do we make etiological diagnosis of pneumonia? कि किस वजह से है, कौन सा एजेंट है, क्या सैंपल भेजोगे? स्प्यूटम, कलर ऑफ स्प्यूटम से आपको बैक्टीरिया आइसोलेट हो जाएगा? कल्चर सेंसिटिविटी भेजोगे, लेकिन सैंपल क्या होगा? Who said blood? Who said blood? Excellent choice. The definitive diagnosis, if you read Harrison, the diagnosis of pneumonia is based on blood culture, not on sputum culture. Why so? If it is a respiratory tract infection, why not to get sputum culture and straight away have a diagnosis? Why do we need blood culture? Anybody? Because the upper or lower respiratory tract is not a sterile tract. We breathe in air, we inhale microbes with that. So the sputum has higher chances of getting contamination with normal commensals, whatever we are inhaling with the air. So that's why we do not go for sputum culture rather than blood culture is the gold standard for diagnosing pneumonia. Likewise, catheter associated urinary tract infection. What sample will you send? Of course, the sample would be urine, but from where? Patient urinary tract is connected with a Foley's catheter, which is connected to a urobag. Where will you take the sample out from? Yes? Suprapubic. Patient is already having in ICU, has multiple lines. One more invasive intervention would you like to do to diagnose UTI? You will call your surgery friend for suprapubic and he will come? No. Otherwise, even otherwise, it is not indicated. Something, you need to take urine out, but from where? Will you open the urine bag and put it into the catheter or tubing? Because the urobag also has tubing, there is some urine in it. Will you puncture the tubing part or the catheter part? Why so? Because the site of collection has to be as proximal to the urethra as possible. And secondly, the Foley's catheter is made up of rubber, so it closes the gap, seals it off after the puncture. So this is the importance of recognizing which sample from where. And nowadays, even when we send blood cultures, we don't send it single. We send it send it pair. In pair, because pair, when I say pair, it means two things. From two different venipuncture sites, and both samples will go for both aerobic and anaerobic cultures. Same goes for what we frequently in ICU, we do ET aspirate and sanit culture. But again, as I told you, the respiratory tract is not a sterile tract. It has high chances of getting contamination, isolating commensals and all that. So we always prefer to take multiple samples. Yield of the same infective organism from multiple samples is much more significant than getting one report from one sample. Foley's catheter, we already discussed that. Whether you take earlier there was a trend of getting you, whenever suspecting catheter-associated urinary tract infection, we'll take out the Foley's, cut the tip, send in a specimen for culture. Do we practice it now? No? You people do it? Not recommended nowadays, because any foreign material you place in human body has a tendency to develop something called as biofilm on its surface. That biofilm on the surface of Foley's will also transmigrate to the tip of the Foley's region. And if you isolate that is not the actual causative agent, but you are isolating the organisms which are already sitting harmlessly on the biofilm of any foreign material. So we don't do those tip cultures, be it Foley's catheter or endotracheal tube. Transport. Just a word of caution. We receive patients in emergency at night time, some meningitis patient, infective endocarditis patient, pneumonia patient, and we take the sample because those culture facilities at times are not available round the clock. What we do, we take the sample and put it in the fridge, which is not to be done again. All the sterile, supposedly sterile specimens like CSF, blood, in an otherwise healthy person will not be infected, will not have commensals in it, will not have resident flora, nothing. So all those samples should not be refrigerated because refrigeration overnight promotes growth of fastidious organisms. So what will you grow next day is not what was actually the infective agent, but something that could sustain that low temperature for 12 hours and that will grow. So naturally sterile samples are not to be refrigerated. They are to be kept at room temperature only. And a word about how do the microbiologists perform antimicrobial testing. Earlier days, we all have seen in our microbiology labs the disk diffusion method. Whichever area does not have that pale yellow color means the bacteria is not growing in the vicinity of that drug, and the bacteria is supposedly sensitive to that drug because it is not able to grow in its close vicinity. Nowadays, we have moved on to automated equipments. They keep on churning the sample and keep them warm so that we can have a growth much earlier. The conventional disk diffusion method and culture sensitivity will take 48 to 72 hours. These automated equipments can give you culture report within 12 hours. This is what we are using at GMCH. And whenever you have a growth, you have to decide whether it is a contaminant or actual pathogen. And that contaminant could be a normal commensal residing in that place peacefully, or colonizer, which is usually not there, and it is isolated from that sample, but is not the cause for disease. Anybody can give me an example of isolating a commensal from clinical samples? ब्लड कल्चर रिपोर्ट देखिए आपने कभी जिसमें लिखा होता है coagulase negative staphylococcus isolated.
Dr. Preetham, your time is, please.
All right, sir, just 2 minutes maybe more. Skin contaminant, when you're taking blood culture, if you don't disinfect it properly, you will grow commensals. Colonizers like aspergilloma in tubercular cavity. It is not causing the cavity. The cavity was because of tuberculosis, but aspergillosis is quietly sitting there. Finally, what report you get, it says sensitive, intermediate, resistant, but it is a qualitative kind of reporting. It doesn't tell me the quantitative aspect of the report. That means how much good one sensitive drug as compared to other sensitive drug. Number one into something is sensitive both peptides and say meropenem. Which one should I choose? From that simple reporting, we have moved to something called as BMQ, breakpoint cluster minimum inhibitory concentration quotient. In nutshell, higher the BMQ, better is the drug. Take this example, urine culture shows growth of Klebsiella, imipenem minimum inhibitory concentration. I hope everybody understand minimum inhibitory concentration is 24 for cefoperazone, MIC is 16. Which one drug will you give? The one with lesser or more MIC? Lesser. That means you require lesser quantity of the drug to be effective. But then you get clinical breakpoint of 50 for imipenem and cefoperazone 24. Which one will you choose now? BMQ, breakpoint divided by MIC. For imipenem it is more than 50 divided by 24, more than 2. For cefoperazone 24 divided by 16, less than 2 at least. Which one will you choose? Imipenem. Just remember those higher antibiotics, clindamycin, linezolid, macrolides, and tigecycline are actually bacteriostatic in nature. Don't be confused that these are higher antibiotics that will cure the patient better. They are bacteriostatic in nature and not bactericidal. To conclude my talk, yes, any takeaway home message? Anybody? What you gained from this talk? Give me 2. I'll be happy. 2 learning points from this talk. Oh, that's a very broad thing, ideal thing. But actually, in practice, what you will change in your practice? Okay, you will think about which test to be performed out of, if you have choice of many. 1, second. Okay, read it out for me from this bench. Read this out for me, point-wise. Sensitivity? So any patient with fever, do not give monosef. Pass it on to next. Next.
Take care of antibiotics so that they can take care of you.
Will you?
Yes, sir.
All right.
Wash your hands when you eat and treat.
When you treat the patients.
Diagnostic workup is not a test fest.
क्या मतलब निकला इसका?
Sir, over diagnosis.
सब कुछ नहीं भेज देना, जैसे वो देखा था acute viral hepatitis भी positive आ गया, leptospira भी positive आ गया. These are not culture tests, these are serological tests, can be false positive. So send what you suspect. ऐसा नहीं कि सब कुछ भेज दो, जो आएगा वो ट्रीट कर देंगे. ये सब कुछ ट्रीट कर देंगे, तो फिर बाद में जो रिपोर्ट आएगी उसको देख लेंगे. So send the test that you actually suspect for.
See through the BMQ.
क्या है BMQ?
BMQ is MIC CMB divided by MIC.
Higher the BMQ,
Higher the BMQ, we
better is the
better the
drug.
antibiotic.
Lastly,
Adopt a grass rooter and not a parachute.
what is that? If the patient is not critically sick, don't start from wide spectrum antibiotic. It will cover gram positive भी कर लेगा, gram negative भी कर लेगा. Start from focused what your differential is. Narrow spectrum से शुरू करो. But provided the patient is not critically ill. तो grassroots से चलना है. अगर वो काम नहीं करेगी, then you go higher levels. Thank you.
Thank you, sir, for great talk and first talk and most important in Indian scenario. We are really thankful to you for coming to Bathinda and giving such a good talk, which is a burning topic in especially the world and focusing on India. I generally routinely tell when I have to take class or something that don't consider antibiotics as a prasad. Whenever you go to a temple, what does they do? वो पहले टिक्का लगाते हैं, फिर चावल लगाते हैं और फिर आपको प्रसाद देते हैं. So if you see the prescription in emergency, I generally see Pentop is given as a tikka and antibiotic is given as a chawal. And all the other things, cocktails, steroids, etc. are given as a prasad. So desist from this thing, and especially antibiotics. You will find the heading of viral fever and third generation antibiotic below. And that is why I called qualified quacks, especially with prescription of antibiotics. Any other comments?
So I think the most important part is it is very easy said than done, you see. But we are facing this problem day in and day out, you see. And most of the time the mushrooming of the labs, I see daily in and out the Vidal test is positive when the patient is not having fever at all. For 6 months he's saying my Vidal is positive, and he's keep on taking antibiotics even from all qualified doctors, you see. That is the basic problem.
Yes, sir.
I mean, even if I talk about your GMC, Chandigarh, even you operate on a certain knee surgery, for that matter, for any surgery, you will give the patient antibiotics without fail.
I won't go into other fields of practices, but yes, don't fall for typhi dot IgM positive, Vidal positive. These are serological tests. They are highly false positive, highly false negative. So the diagnosis of enteric fever should not be based on those serological tests. Yes, if you get culture positive, that's a different story. Or if you have strong clinical suspicion, that is also a valid reason, but not on the basis of a person carrying a report of so and so positive.
Thank you, sir. Thank you very much. With this, we proceed to the next lecture. That again is very, very important, delivered by Dr. Seema Mahant. Again, I am very thankful to ma'am from coming all the way from Bhopal to deliver a lecture on this, and especially the most important after antibiotic is rational use of blood and blood products. I invite you, ma'am. And now we will stick to the time, 15 minutes for the lecture and 5 minutes for the discussion. Because antibiotic, we finished the paper presentations and you have the important topic and 10 minutes extra. So thank you, ma'am, for coming.
Thank you, sir. Good morning, all of you. First, I would like to give special thanks to organizing committee, especially Professor Dr. Vitul Gupta, sir, who invite me and gave me opportunity to speak on such an important topic, that is rational use of blood and blood products. Now, the concept behind the rational use of blood is we have to use right product in right dose at right time and for the right reason. Why this is important? Because there is a big demand and supply gap. Annual requirement of blood in our country is 14.6 million unit, despite collecting approximately 12 million unit annually. So we are facing a shortfall of around 1 million unit every year. To fulfill this deficiency, we have to adopt some strategy. First and most important thing is we always use blood component therapy. We adopt transfusion avoidance strategy, avoidance of fresh blood transfusion, avoidance of single unit transfusion. We promote autologous blood transfusion, especially in elective surgical cases. We should increase the use of erythropoietin, iron and vitamin B12 replacement to increase the hemoglobin level, and use of vitamin K rather than FFP to correct altered prothrombin time. When we centrifuge the whole blood, it separated into packed red cell, platelet, fresh frozen plasma, cryoprecipitate and granulocyte. By this separation technique, we can provide optimum survival of each component, and we can allow transfusing only specific component that patient require and avoid use of unnecessary component. With 1 unit of whole blood, it can be useful to multiple patients. Indication of a specific component for whole blood. Nowadays, there are no absolute indication for whole blood transfusion, but we can use in case of blood loss with hypovolemia, in exchange transfusion in sickle cell disease and hemolytic disease of neonates. We use PRBC transfusion in symptomatic anemia, and with 1 unit of PRBC transfusion, there will be raise of hemoglobin by 1 gram%. We use platelet for prevention and treatment of bleeding due to thrombocytopenia or platelet dysfunction. We use FFP for replacement of multiple coagulation factor deficiency in case of liver disease, warfarin toxicity, depletion of coagulation factor in large volume transfusion, in disseminated intravascular coagulation and thrombotic thrombocytopenic purpura. Indication for cryoprecipitate, it is used as an alternative treatment of inherited deficiency of one Willebrand factor, factor 8 deficiency, factor 13 deficiency, and it is also used as a source of fibrinogen in acquired coagulopathy like DIC. Now first I will take the PRBC transfusion. So in our clinical practice, how we take decision regarding PRBC transfusion? Is hemoglobin only the deciding factor? No. Hemoglobin value should not be only deciding factor for PRBC transfusion. First we have to assess the patient clinically and think, is it really indicated? We should not transfuse if there is an alternative available. Benefit must outweigh the risk of the transfusion. It is likely to be inappropriate if hemoglobin is more than 10 gram%. It is usually indicated if hemoglobin is less than 7 gram%. And if the hemoglobin between 7 to 10 gram%, then clinical condition must be correlated. According to the International Transfusion Guideline, they recommend if the patient is hemodynamically stable, then cut point of PRBC transfusion is 7 gram%. If the patient have cardiovascular intervention, then cut point is 7.5 gram%. And if the patient have intra-abdominal surgery, then cut point of hemoglobin for PRBC transfusion is 8 gram%. This is common query which we face. Can we give IV fluid with blood transfusion? Only isotonic saline is recommended to use with blood component. We should not use 5% dextrose or ringer lactate solution with blood, because dextrose will cause hemolysis of the RBC and ringer lactate will cause clot formation. So before transfusing the blood component, we should completely flush out all the incompatible IV fluid and drugs, or preferably change the IV set. Another important query, do we need to warm blood? No. There is no evidence of warming blood is beneficial to the patient when transfusion is slow. But when transfusion is very massive and fast, then cold blood may cause cardiac arrest. Keeping the patient warm is probably more important than warming the blood. So warming blood required in large volume rapid transfusion, exchange transfusion in infants, and patient with clinically significant cold agglutinin. When warming is required, the blood should be warmed in blood warmer, and that blood warmer should have visible thermometer and audible warning alarm. Blood should never be warmed in bowl of hot water, because it will cause hemolysis of red blood cells that become life-threatening when transfused. Now, which blood is safe? One from unknown donor or one from family members? Transfusion from first-degree relatives should be avoided to prevent transfusion-associated graft versus host disease. Though it is a rare complication, but it is life-threatening. There are few conditions in which we can avoid PRBC transfusion even if the hemoglobin is low. These are iron deficiency anemia, so we should give IV injectable iron rather than PRBC transfusion, vitamin B12 deficiency anemia, and autoimmune hemolytic anemia. Now there is always debate on 1 unit of whole blood versus PRBC, which is better. PRBC always better than the whole blood because it contains 40% more RBC. With whole blood, it is available in volume 350 to 450 ml, so there will be high chance of volume overload. ABO antibodies are more, so there will be more allergic reaction, more transfusion reaction, and there will be wastage of other component. With PRBC, it is available in 200 to 240 ml, so chances of volume overload will be less. ABO antibodies are less, so there will be less allergic reaction, less transfusion reaction, and there will be no wastage of other component. So always you use PRBC in spite of whole blood. Second important component is the platelet transfusion. They are available in two forms, random donor platelet and single donor platelet. Random donor platelet available in 50 to 70 ml per unit. With this, there will be increase of 5 to 10,000 platelet per unit. The dose for adult 6 unit, dose for infant 1 unit per 10 kg body weight. Number of donor exposure are more with RDP, near about 6 to 7 donor required, and ABO compatibility play minor role in platelet transfusion. For SDP, it is available in 300 to 350 ml per unit, and there will be increase of 30 to 50,000 platelet per unit. Dose for adult 1 unit, dose for children 10 cc per kg body weight. Number of donor exposure usually single, so there will be less chance of transfusion reaction, less HLA, alloimmunization, and less chance of transfusion transmitted CMV infection. This is very important. Cut point for platelet transfusion. In any patient who is prone for bleeding, the cut point for platelet transfusion is below 10,000. If the patient have fever, sepsis, and the patient is on amphotericin B therapy, then cut point for platelet transfusion is less than 20,000. If the patient undergo intra-abdominal surgery, then cut point is 50,000. If the patient have epidural anesthesia, then cut point is 80,000. And if the patient undergo neurosurgical procedure, then cut point is less than 1 lakh. If the patient have bleeding, that is due to thrombocytopenia, that at any point, that in any platelet count, we have to transfuse platelet. Now this is very commonly faced clinical situation. A dengue patient with platelet count of 10,000 in a peripheral hospital where arrangement of component separation not available, will you ask for fresh whole blood? No. The whole blood transfusion is generally not recommended for dengue thrombocytopenia because it may complicate patient due to fluid overload, transmission of infections, transfusion reaction like urticaria or anaphylaxis, or whole blood have slower platelet recovery rate. So rather than transfusing whole blood, we have to refer patient immediately to higher center where the separation facilities are available. Another important clinical scenario, a 11-year-old child diagnosed as idiopathic thrombocytopenic purpura 1 year back, who is responded well with therapy. He complained sudden onset of gum bleeding and platelet count was found to be 15,000. Whether platelet transfusion will control the bleeding? Again, no. There are relative contraindication of platelet transfusion. These are heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, and idiopathic thrombocytopenic purpura. In these conditions, we should avoid platelet transfusion and we should give definite therapy. Next important component is the fresh frozen plasma. It is available in 200 to 250 ml package and it contains plasma protein and stable coagulation factors. All coagulation factors are available at the level of 1 international unit per ml of FFP, and we can store FFP up to 1 year in below 18-degree temperature. Once thawed, it should not be refrozen, and thawed FFP is stored in 1 to 6 degrees centigrade and transfused within 24 hours. So we use the fresh frozen plasma in coagulation factor deficiency, in disseminated intravascular coagulation, in warfarin toxicity, dilutional coagulopathy in case of massive transfusion, hemorrhage in liver disease, and thrombotic thrombocytopenic purpura. The dose is 15 ml per kg body weight. It should be ABO compatible, but any RH group may be given, and it should not be used for correction of hypovolemia or hypoalbuminemia. Another important component is the cryoprecipitate. It is prepared from FFP, thawed at 4 degrees centigrade and refrozen. It contains more than 80 international unit factor 8, 150 to 250 milligram fibrinogen, 30 to 50 milligram fibronectin, 40 to 70 milligram 40 to 70% bond bilirubin factor and 30% factor 13. It is available in 5 to 15 ml package and it is stored in minus 18 degrees centigrade and must be thawed before transfusion. So primarily it is used to control bleeding associated with fibrinogen deficiency and to treat factor 13 deficiency. It is used as second line therapy for von Willebrand disease and hemophilia A. It is used to control active bleeding in uremic patient. It is also used in DIC when fibrinogen level less than 100 milligram per deciliter. Because it is small, it is available in a small volume in each unit, so ABO compatibility not needed. Again, it is a very important clinical scenario. A young boy who have transfusion dependent beta thalassemia and started blood transfusion at the age of 2 years, and survival depend on blood transfusion. What precaution we have to take for such type of patient and why? So we have to go for extended red cell antigen typing, and we try to use leukodepleted blood for prevention of alloimmunization, febrile non-hemolytic transfusion reaction, and transfusion transmitted CMV infection. So we always use leukodepleted blood when there is a chronic blood transfusion. Another important clinical scenario, a 45-year-old male patient diagnosed as chronic lymphoid leukemia and received first cycle of chemotherapy, that is fludarabine, cyclophosphamide and rituximab regime. Few days after the chemotherapy, he developed pallor and given 2 units of PRBC. Patient developed post-transfusion fever, diarrhea, skin rash, hepatic failure and expired. What was the cause of death in such patient? It may be a case of transfusion-associated graft versus host disease. In this complication, mortality is very high, more than 80%. Because patient received fludarabine-based therapy, so he should have received irradiated blood product. So use of irradiated blood product to prevent transfusion-associated graft versus host disease. And in this technique, we give minimum dose of up to 25 grays of irradiation, and all cellular components require irradiation except FFP and cryoprecipitate. Indication for use of irradiated blood component are intrauterine transfusion, neonatal exchange transfusion, primary immunodeficiency syndromes, Hodgkin's lymphoma, and patient treated with purine analog drugs like fludarabine. So in all immunocompromised patients, we should give irradiated blood component. While transfusion the blood, we have to take following precautions. Blood component should be checked and matched with patient detail at bedside before transfusion. All transfusions should get completed within a specific time. For platelet, infusion start within 30 minutes and should complete within 4 hours. For platelet, infusion start immediately and should complete within 20 minutes. For FFP, infusion start within 30 minutes and completed within 20 minutes. Routine pre-medication is not required in all patients. Electrotransfusion preferably should be done during daytime, and only fluid which is compatible with blood is normal saline. So take home message, think before transfuse. Does your patient really need blood? Choose the right component, weigh up the benefit versus risk of the transfusion, and do not transfuse if there is an alternative available. So this is my last message, donate blood and save a life. Thank you.
Thank you, ma'am, for finishing in time. But we have next 10 minutes because we are missing a lecture.
Sir, okay, sir,
So any question, answers, any doubts? संगो ना यार पीजीएम तो पूछना चाहिए कि मैडम आ समझा दो जी वो समझा दो जी.
Now there are 2-3 points which I want to add.
Yes.
Previously when the patient come for the physical fitness, so if the hemoglobin is less than 12, हम उसको fitness नहीं देते थे. But right now there are very good surgical techniques available. There are laparoscopic techniques, robotic surgeries. So the need of the PRBC transfusion are little bit less. So even in the 8 g% we give fitness, and if suppose the transfusion is required, then we promote autologous transfusion. So in this autologous transfusion, we just used to take the patient own blood few days prior, and we can use to the patient at the time of surgery. So these are few techniques, and there are one thing more. Usually we advise one PRBC transfusion. So one PRBC transfusion should be avoided. 1 unit of any transfusion should be avoided. Because 1 gram hemoglobin, if the patient is alive at 6 gram hemoglobin, तो एक 7 gram hemoglobin में भी वही condition रहेगा. So usually when the blood is indicated, there should be 2 or more units.
So any other comments?
Yes. In ITP cases,
Yes, sir.
when we should transfuse, this is from PG students.
Ji, sir. Very good question, sir. In ITP patient, usually we give the definitive therapy. We give the steroid, immunosuppression, and in some cases we do the splenectomy. But in ITP patient, we transfuse platelet when the bleeding is life-threatening. When the patient have the intracranial bleeding or the massive bleeding, the hemodynamically unstable patient, then only we transfuse platelet. Otherwise, minor bleeding, we should not transfuse platelet.
So platelet count is not a guideline for
No,
transfusion.
no.
Yes.
Not at all, not at all.
Second, again for my PGs,
Sir.
patient is thrombocytopenia. When we should not transfuse platelets.
Sir, there are 2-3 conditions. One is the thrombotic thrombocytopenic purpura, वहाँ पर हम नहीं करेंगे. And heparin induced thrombocytopenia, वहाँ पर भी अगर count low है तो भी हम नहीं देंगे. We will give the definitive therapy for that.
Thank you.
For the surgical fitness, when the patient comes, patient looks normal, but the platelets are very reduced. The idea at that time is not to give platelets or worry about it. I think the manual checking of the platelets at that time is very necessary, because when the size of the platelets is bigger, they get counted by the machine into the megakaryocytes and so on.
This is oftenly happen, ma'am.
Yeah,
When
this is very often
very
because the
oftenly.
patient comes to you for the fitness, and one really gets bothered. What's happened to the platelets? Why are they less? The attendants these days post dengue, now they are very aware. They call it cells. We cell कम हो गए तो पता नहीं अब कैसे होगा सारा कुछ. So nothing to panic. I just want to convey that the manual checking of the platelets at that time is must be done.
Yes, and for the clinician, we assess the patient and we can do the tourniquet test if possible, whether there are chances of bleeding or not. And just single reading the platelet is low is not important. We can go for the manual checking. If the clumps are there, then the patient have the adequate platelet. There were very less risk of bleeding.
So any other comment? So basically what happens is in general practice, once the platelet are less than 50,000,
Yes, sir.
so most of the doctors they write कि डेंगू का यहाँ पे स्पेशल इलाज होता है.
Sir,
So
everywhere
basically, yes. So that is very dangerous.
Sir.
And the platelet count should not decide whether the patient needs platelets or not.
Absolutely, sir.
So it is
Absolutely,
the
sir.
complications which we expect, shock syndrome or hemorrhagic fever. So only then they should be. So young doctors should learn from this and resist from becoming a doctor कि यहाँ पे डेंगू का स्पेशल इलाज होता है, क्योंकि डेंगू का स्पेशल इलाज है ही नहीं है कोई.
Even I have managed many patients of the dengue fever when the platelet count is 6,000, platelet count is 5,000, and not transfuse the platelet. Yes. We just wait and watch and monitor the patient.
So last take-home message for all the young doctors as well as the old doctors.
The platelet transfusion, you should avoid the overuse of the platelet transfusion. Assess the patient clinically. If the patient is prone for the bleeding, then only you give the platelet. Single unit blood transfusion should be avoided. There is no use of 1 point PRVC, 1 point of platelet. There is no use of that. If your patient is needed transfusion, it should be 2 or more unit. Thank you.
So thank you, ma'am.
Thank you, sir.
So next, I am honored to invite Dr. B.K. Agarwal. So he is a very versatile personality. So he is
very fast acting. One thing to remember is renal elimination is almost 80%. So we'll have to be careful when we are prescribing the patients when their GFR is low. Rivaroxaban, apixaban, edoxaban, all of these are factor 10A inhibitors. XA is in their name, so all are 10A inhibitors. All are fast acting. Apixaban, renal elimination is only 25%. So maybe it is a good candidate for the patients who have CKD. Heparin, Probably it is not very clear, is it? Anything can be done? Okay, I'm sorry about that. So unfractionated heparin, low molecular weight heparin, and fondaparin X. Unfractionated heparin, action starts almost immediately. Route is IV or subcutaneously. Low molecular heparin, half-life is 20 to 30 minutes. Route is only subcutaneous. Fondaparin X can be used when we cannot give heparin, like if the patient is heparin-induced thrombocytopenia. Route is subcutaneous and it is given once a day. Antiplatelet drugs and their duration of action. Aspirin, it is 4 days. P2Y12 inhibitors like clopidogrel, prasugrel, ticagrelor, or cangrelor. Clopidogrel is more potent than aspirin. Prasugrel and ticagrelor are more potent than clopidogrel. Cangrelor is given as infusion. Its action will last for 30 to 60 minutes after we have discontinued it. Abiciximab, again given as infusion, its action lasts up to 48 hours after discontinuance of therapy. So when a surgery or procedure is required, we will have to assess what is the risk of bleeding. There is not much trials are available, but as per the International Society of Hemostasis and Thrombosis, it can be grouped into 3 categories: high risk of bleeding, low to moderate risk of bleeding, and minimal risk of bleeding. Minimal risk of bleeding, when the risk of major bleeding is 0%, low to moderate risk 0 to 2%, and high risk more than 2% risk of major bleeding. In the category of minimal risk of bleeding, procedures can be cataract, dental extraction, pacemaker implantation, cardioverter defibrillator implantation, minor skin procedures. Low to moderate risk, 0 to 2% risk of major bleeding, that is GI endoscopy or biopsy, bronchoscopy or biopsy, lap cholecystectomy, epidural injection, abdominal hysterectomy, coronary angiography, abdominal hernia repair, pile surgery, skin or lymph node biopsy, arthroscopy, hand or foot surgery. The procedure that carries high risk of bleeding when the organ is highly vascular like liver, kidney or spleen, ERCP procedure, colonic polyp resection, cardiac surgery, intracranial surgery, spinal anesthesia, and any major operation lasting for more than 45 minutes. Bowel surgery, cancer surgery like solid tumor resection, major orthopedic surgery, plastic surgery, urologic surgery. This list is not exhaustive, but I have tried to cover the common procedures and surgeries. Then we have to assess what is risk of thrombosis. It depends on patient's profile. High risk of thromboembolism, if the patient had suppose recently DVT in the past in 3 months, or the Chats VAS score is very high, or the patient has atrial fibrillation with rheumatic heart disease, or the patient has received some mechanical valve, or the patient had TI recent cardioembolic stroke, and active cancer who are at high risk of thromboembolism. LV thrombus diagnosed recently, severe thrombophilia, antiphospholipid antibodies. So the high risk of thrombosis, this category probably they will require what we call bridge therapy. Moderate risk of thromboembolism, if the patient had DVT in last 3 to 12 months or Chats VAS score is 5 to 6. Low risk of thromboembolism, if the patient had DVT in the remote past or Chats VAS score is 1 to 4. So this is as per a study. If the patient is not on anticoagulant, what is risk of stroke? If the Chats VAS score is highest, that is 9, annual risk of stroke is 14.4%. When it is 2, risk of stroke is 2.5%. As the score increases, chances of stroke increases. So if the patient has received mechanical valve, so the risk of a stroke or arterial thromboembolism would depend on what is the type of valve, what is the position of the valve, and time since placement. Caged ball valve carries the highest risk. If the valve is placed in mitral position, is more riskier than aortic position. If the patient received valve only recently, it carries the highest risk of thromboembolism. If the valve is placed in the remote past, it carries lower risk. So based on the pharmacokinetics of the anticoagulants, as I have told in the earlier slide, you will have to stop or interrupt this anticoagulant prior to surgery. So let us take an example of apixaban. If the surgical procedure carries a high risk of bleeding, then you stop it at least 2 days prior to surgery, and it can be restarted in 48 to 72 hours after surgery. If there is low to moderate risk of bleeding, you stop it for a day before surgery, and it can be resumed in 24 hours after surgery, provided hemostasis has been achieved and we are not planning any further surgical intervention. Same is the case with all the newer anticoagulants like dabigatran, edoxaban, rivaroxaban. But for dabigatran, because it is majority PET eliminated through kidney, so the GFR is less than 50. The interruption period is almost doubled. So that is in high risk of bleeding. You stop it for 4 days before the procedure, and when the risk of surgery is low to moderate risk of bleeding, you stop it for 2 days before surgery. So what is bridge therapy? During this period, because the risk of bleeding is there, we interrupt the anticoagulant or antiplatelet. And for this brief period, when the risk of thromboembolism is high, it is minimized by short-acting anticoagulants, and which has to be stopped hours before the procedure. So some studies which are available, this is published in NEJM way back in 2013. So pacemaker or defibrillator surgery without interruption of anticoagulation. As I told, these are all low risk of major bleeding. So as compared with bridge therapy with heparin, continued therapy with warfarin will carry the low risk of hematoma. That means you just continue warfarin, don't interrupt warfarin and give heparin. So bridge therapy should be avoided in this situation. So this is systematic review published in the American Journal of Medicine. Patient had venous thromboembolism and were on this warfarin group of drugs, and it is seen that when you do not give bridge therapy, also there is risk of bleeding is less and risk of thromboembolism is also less. So again, no bridge therapy required if the patient had DVT or in the past and patient is on anticoagulants. And this is published in NEJM 2015, famous bridge trial. Patients had atrial fibrillation and were taking vitamin K antagonists. So one group received no bridge therapy, another group received bridge therapy. So what it says that risk of thromboembolism is almost similar in both the groups, but the risk of major bleeding almost doubles or more than doubles if you give bridge therapy. So again, as per this study, bridge therapy is not required in majority of the cases. And this was published in JAMA Internal Medicine in 2019. Same as I told you earlier, same protocol was followed in this PAUSE trial, perioperative anticoagulant use in surgically evaluated patients. So same protocol was followed, and what they found is simple protocol of interruption of anticoagulants is enough, and there is no need to assess coagulation function. And in those cases, there is low rates of major bleeding and low risk of arterial thromboembolism. So what to do with the patient is on warfarin or vitamin K antagonist? When there is minimal risk of bleeding, same therapeutic dose can be continued, but if there is low or moderate or high risk of bleeding, you stop it for 5 days before the surgery, and it can be restarted in 24 hours. But if there is thrombotic risk is high, then there is bridge therapy with low molecular weight heparin. So that can be given 3 days before the surgery. That is, by this time the INR might have reduced to less than 2. So chance of thrombosis increases during that period. So the dose is therapeutic dose of 1 milligram of enoxaparin twice a day. And the last dose of this heparin is given 1 day prior in the morning. That means suppose you have planned surgery tomorrow, then last dose of low molecular heparin is given today morning. And post-operatively, this breach therapy after 24 to 36 hours in case of low to moderate risk of bleeding. But if there is high risk of bleeding, you wait for 48 to 72 hours and start with half the dose, and after a day give full dose and continue this heparin till 5 days. So by this time the warfarin will take over. So just to repeat, if the patient is on warfarin group of drugs, check INR 7 to 10 days before surgery. Stop 5 days before surgery when INR is 2 to 3. If bleeding risk is high, check INR on the day of surgery, and if INR is more than 1.5, give a small dose of vitamin K. Some authors say there is no need to check INR, you continue with the surgery. And if there is high risk of thrombosis, breach therapy is required. And post-operatively, resumption of warfarin in high bleeding risk category restart after 24 to 36 hours with the same dose. Low to moderate risk, restart after 12 hours. And as I told you, continue breathing till INR 2 is achieved, that is about 5 days after the surgery. So that was of the anticoagulants. Now coming to antiplatelet drugs. Patient may be on single antiplatelet or double antiplatelet. If the patient is single antiplatelet and risk of bleeding is low, you can continue. But in the high risk of bleeding cases, temporarily interrupt and restart post-operatively once hemostasis has been achieved. But in those who have DAPT, that means the risk of thrombosis is high in those patients. So consider delaying elective surgery or consult a cardiologist. And in this situation, if surgery required, continue aspirin and stop clopidogrel group of drugs. So what are the situations with the patients may be on DAPT or double antiplatelet drugs? Acute coronary syndrome like ST elevation MI, non-ST elevation MI, unstable angina. In these patients, we give it for 12 months. If the patient had undergone percutaneous coronary intervention and stent placement. So in case of drug eluting stent, it is given for 12 months. Post CABG after acute coronary syndrome, 12 months. Prevention stroke, suppose the patient had TIA or minor stroke, we give DAPT for 3 weeks or 4 weeks. If the patient peripheral artery disease, if it is symptomatic, or patient undergo lower limb revascularization, so the patient may be on double antithrombotics, that is antiplatelet and maybe with rivaroxaban. So in these situations, when the patient is on 2 antiplatelet drugs, stop one, and it is usually clopidogrel or P2Y12 inhibitors that is interrupted. These are more potent than aspirin. And once you stop clopidogrel, there is chance of rebound platelet hyperactivity. That means chance of thrombosis increases. But if you are able to give aspirin during that period, chance of this thrombosis will be minimized. But if the bleeding risk is high, like brain surgery or spinal surgery, stop aspirin as well. It can be restarted after 24 to 48 hours if hemostasis has been achieved. So management of antiplatelet drugs during the procedure, if possible, continue aspirin throughout. Clopidogrel need to be stopped 5 days before surgery. Ticagrelor will have to stop it 3 to 5 days before surgery. And prasugrel need to be stopped for 7 to 10 days before surgery. And in this situation, the chance of thrombosis is high. We can give cangrelor, which is given as IV infusion. but there is not very low quality data is available on this drug, so it should not be routine practice. And post-operatively, clopidogrel group of drug can be restarted within 24 hours. So, if the patient requires non-cardiac surgery, what is the period, optimal timing for elective or time-sensitive non-cardiac surgery for prior PCI requiring DAPT? If the patient had balloon angioplasty only, no stent was placed, delay it at least by 14 days. If the patient had received bare metal stent, which is rarely done nowadays, you stop it at least for 30 days. If the patient has received drug-eluting stent due to acute coronary syndrome, delay it for 12 months. If the patient received it for chronic coronary disease, delay it for 6 months. So, if at all we do require surgery, so what is the anticoagulant reversal options? In all these situations, FFP is a good option, fresh frozen plasma. But many people do not advise because of the volume overload. But it is very easily available in most of blood bank. Other options we have is 4-factor prothrombin complex concentrate. It is contains factor 2, 5, 2, 7, 9, 10. And for warfarin, antidote is vitamin K. For apixaban, rivaroxaban, edoxaban, it is andexanet alpha. Andexanet alpha is factor 10 decoy. That means this anticoagulant will bind to this andexanet, so that factor 10A will be available, will be free for coagulation process. And for dabigatran, we have idarusuzumab. So whenever in these situations, what to do? Consider what is risk of bleeding because of procedure itself, and what is risk of thrombosis because the patient's condition or profile, and what is the patient's renal clearance. And the patient is on newer anticoagulants, we interrupt it only for a brief period. So probably bridge therapy is not recommended. But if the patient is on vitamin K antagonist, we interrupt it for nearly 5 days. So in that period, chance of thrombosis may increase because of the patient's profile. So in those cases, maybe we can consider bridge therapy. Thank you.
Thank you, sir, for discussing such an important topic in a simpler way that everyone will understand what to do and when to do, especially pre-operative as well as post-operative and peri-operative. Thank you very much. Now the session is open for discussion. Any comments?
Thank you very much, sir. I want one question. Is all these antiplatelets and anticoagulants are available in Indian situation? In India, I mean to say.
Yeah, this apixaban, edoxaban, rivaroxaban, it is very commonly used.
And are they all cost effective?
Dabigatran. Yes. Or is your anticoagulants are nowadays it is quite economical.
Okay.
Yes.
Thank you, sir.
And moreover, you do not require PTI monitoring in those cases. Yeah, let us hope so.
Thank you, sir. Thank you very much. So now we proceed to the next topic. So I'm sorry to inform Dr. Gurpreet Singh Wonder is sick, so he is not coming to Bathinda. And with that, I requested Dr. Gursaran Kaur to please speak on rather important, fascinating and hyped topic of GLP-1A agonist Manjaro, new kid on the block. Everybody, every newspaper, everybody is talking about this anti-obesity drug. And I am honored to have Dr. Gursaran Kaur to speak on this important topic. Ma'am, please.
Thank you, Dr. Vittu, for inviting me over here, and a very good morning to all of you. I'm very passionate about this. Yeah, the GIP and GLP-1 receptor agonist, and the new kid in the block is the terzepatide, the Mounjaro. We are all quite excited about this molecule. During the course of my discussion, I'll be taking you through the incretin hormones, presence of receptors in the body, the therapeutic approach, the mechanism of action, and the weight management and the safety profile and FDA approvals. Non-disclaimer, only few slides have been taken from the Eli Lilly, and thanks to them I acknowledge it. Well, according to the WHO, the obesity is one of the most common yet most neglected public health problem in both the developing and the developed countries, and India has the third highest obese population in the world. WHO has already actually recognized it as a disease long time back in 1948, and in 1997 it has been given in the category of the global health problem. We all know it's the abnormal and excessive accumulation of the adiposity, which presents it as a risk of health. So obesity is a disease. Obesity is not good in look, it is not being healthy, it is a disease. So when does it become a disease? It is defined when the BMI is more than 30 millikilogram, more than 30, it is categorized into 3 classes. Before that, we understand for the Asian, our normal BMI is 22 to 26. Between 26 to 29.9 is the overweight, and beyond 30 to 34.9 is class 1 obesity, 35 to 39.9 is class 2 obesity, and more than 40 is class 3 obesity. This is such a chronic disease, though of course it is because of dysfunctional adiposity, that the person doesn't realize that he is getting the problem. Because it is chronic, it is every day, we get so used to it, we don't realize when the same problem becomes a disease for us. And prevalence is across the globe, and many obesity related complications, because they are because of obesity, they will almost get cured and preventive with the weight loss. So what are the causes? It is very multifactorial. We know mainly it is the in and the out. Intake is the food, the environmental factors, our habits, and out is how much you exercise, how much you become active, how good is your metabolism. So it is a acute balance between both of them. And factors like socio-cultural, what are your sleeping times, what are your waking times, how much you party, the environmental factors, the epigenetic, the genetic factors, which are very important, which you can't help. But there are others, like physiological, like behavioral. Behavioral, why? Because it's a mind-gut axis. Whatever is in your mind and whatever you put into your gut actually goes into your mind. It is completely a mind-gut axis which works. And it is the behavior of the person, how to eat, when to eat, what to eat, that realization is extremely important. Coming to the epidemiology, it is estimated that from 2010, the cases are rising from 511 million, and they are expected to extrapolate by 2030 to 1025 million cases. And in US, the magenta color, which is seen across, it is getting more and more. This is the prevalence which is going to be there till 2030. And in India, we are in a crisis of obesity now. We have always said health is the greatest wealth. We say wealth is lost, nothing is lost. Health is lost, everything is lost. And as obesity emerges as a silent epidemic, with no hue and cry, it's not like COVID that everybody knows about it, because it is so chronic. And it is again like as silent as diabetes and hypertension. And now it cuts across all the socioeconomic groups. It was earlier confined to the affluent section of the society, but now it affects 24% of women and 23% of men. And what has happened? It is driven by the urbanization, by the sedentary lifestyle and unhealthy diets. The World Obesity Atlas 2023 warns that by 2030, over 163 million Indians could be obese and posing a grave health, social and economic challenges. And tackling obesity is not just a health necessity, but a step towards realizing the vision of Sarvashreshtha Bharat and a healthier, productive Viksit Bharat by 2047. Well, obesity, we all know, is a multi-system disease and is associated with comorbidities. I know all of you are aware of the problems which the obesity causes in every system of our body. Just let's go through it. What does it do? You know, what does it do to the neurological and psychological? There is increased incidence of stroke. There is increased incidence of diabetes mellitus, diabetic retinopathy, diabetic neuropathy, pseudotumor cerebri, dementia, depression, anxiety, binge eating, migraine, social stigmatization, and cardiovascular. Of course, incidence of hypertension rises, heart diseases, coronary artery disease, peripheral artery disease, atrial fibrillation, heart attack, congestive cardiac failure, high lipids, as we have been studying since morning, poor circulation, venous stasis in the legs, thromboembolism and blood clots. And because there are clots in the peripheral veins, the incidence of pulmonary thromboembolism and sudden deaths suddenly rises. Not to leave the genitourinary involvement in the woman, we all these days now, there's like every woman, most of them are, they say we talk about PCOS, the reduced fertility, the urinary stress incontinence, the irregular periods, the pregnancy complications. In men also there is reduced fertility and erectile dysfunction. And in the lungs, obstructive sleep apnea, which is so much a huge complication, pulmonary hypertension, restrictive lung diseases and respiratory failure. In the kidneys, because the fats in the kidneys, they decrease the perfusion, they can cause CKD, nephrolithiasis, proteinuria, and of course in the GI, the NASH, the NFLD now being called as MASH, the gallbladder disease, the hepatic steatosis, and in the musculoskeletal, the severe osteoarthritis, the lower backache, the disc problems, and sarcopenia. So NASH and sarcopenia, which are the two current latest problems of the metabolic syndrome. So of course people want to lose weight. So whenever the weight is lost for a short term, it has been seen that within 2 years 50% of the weight is regained, and within 5 years more than 80% of the weight which was lost is regained, and it's like a ping pong ball. The regained weight is even higher than the weight which was lost. Well, this is the etiology. We all are familiar with this etiology. This is the intake. And now let us see what are GLP-1 and GIP receptors and what are these drugs, the coagonists. So GIP is the glucose dependent insulinotropic polypeptide, which is a hormone that is secreted from the duodenum and that binds with its receptors, the GIPR, and the G protein coupled receptor, which is found on the pancreatic beta cells, adipocytes and the bone cells. So upon binding, what happens? It signals the pancreas to produce insulin, and it promotes the fat deposition and influence the bone remodeling. So the GIP and GIPR, this system, along with the glucagon-like peptide 1 and its receptor system, they are very crucial for the metabolic health, and the therapy, which is a dual agonistic therapy like tirzepatide, it shows superior effects in managing both diabetes mellitus type 2 and obesity. So let us look at the gut-pancreas axis, because both these drugs are called incretins. Well, not the incretins are both these hormones, the GIP and the GLP-1. So the gut-pancreas axis is the incretin signal to the pancreas in response to the nutrient load. So when the gastric nutrient load goes to the duodenum, from the K cells the GIP is released, and when it goes into the jejunum, the GLP-1 is released to be acting on the pancreatic different cells. The glucagon cells, the pancreatic polypeptides, and the beta cells. So this load in the gut, it stimulates the release of the incretin hormones, the GIP-1 and the GLP-1, and then it enhances the glucose dependent insulin secretion, and this incretin effect is the major contributor to the regulation of the postprandial glucose clearance in the healthy people. So let us see what happens in the healthy people. The gray graph is when it is the glucose is given intravenously, and the red one is when it is nutrient load of the glucose is given. So what we are looking at, the amount of insulin production. At the same level, after 1 hour, the red graph, which is because of insulin secretion because of the nutrient glucose load from the gut, is much higher. This is called the incretin effect, because when you eat, the insulin is secreted more as compared to when you give it the same load in the intravenous form. And this very incretin effect is blunted and diminished in the patients with diabetes. You're looking at on the other side of the graph, and that is completely blunted. So this is the one, this is how the incretins, these enzymes, they work. And on the adipocytes, we all know that adipocytes are like brown and white adipocytes. The white adipocytes, they also store energy and they act as endocrine cells, because there is also representation of these receptors on the endocrine cells of the adipocytes as well. And the brown adipocytes, they generate heat through thermogenesis. Now let us see what is the mechanism of action of the terzepatide, because as I said, the receptors are on most part of the body, in the brain, in the GI, in the liver, in the stomach, in the periphery, in the pancreas, in the CNS. So what does it do in the CNS? It decreases the appetite, it decreases the food intake, and in the liver, it decreases the fat content of the liver, it decreases the inflammation of the hepatocytes, and even it is known now for the reversal of fibrosis as well. And in the stomach, it decreases the gastric emptying, so that the food there takes little longer and the satiety remains for a longer time. And in the it acts on the pancreas by producing insulin and by decreasing the glucagon secretion, and in the periphery it acts as a insulin sensitizer. The effect on the appetite and food intake is so great that many of the patients, they really say we don't feel like eating anything, and they don't feel like taking alcohol. Somebody who's been binging on alcohol, they say, oh, I don't feel like taking alcohol at all. And somebody who's a smoker, they even stop smoking. One of my patients was on the drug. He was getting a very good result of a diabetes. He was obese, and I saw he was not coming for 1 or 2 months. 3 months later, he landed up with the Department of Orthopedics with a broken fibula, tibia fibula. So he came to me for the medical clearance. I said, what happened? We were giving you the drug and you were doing so well. He says, वो शराब पीने को दिल ही नहीं करता था फिर. तो मेरे को शराब पीनी थी इसलिए मैंने वो छोड़ दी. So it is the other way around as well, because the effect is so great that you don't feel like taking alcohol. So it is, that such a great effect of the drug is there that the patients absolutely don't feel like taking it. So this terzepatide, as a single molecule, it activates both the GIPR and GLP-1 receptors. As compared to the native GIP, it is almost the same, but the potency of tirzepatide as compared to GLP-1 native receptor is slightly weaker. This is the molecular structure and the property that this is a long-acting GIP and GLP-1 receptor agonist. What makes it a long-acting is the albumin binding. It is bound to the albumin, so that the half-life of this molecule is approximately 5 days, so that it enables us to make it a once-a-week dose. And the plasma concentration in the patients with renal and hepatic impairment, they do not differ from those in the healthy people. So let us see what were the weight effects of tirzepatide in phase 2b study in the type 2 diabetes. This was compared with dulaglutide, the Trulicity, which we all had been using since tirzepatide has come now only. Trulicity we all have been using, that is dulaglutide. So comparing, this was how the study was conducted with the placebo with dulaglutide 1.5 milligram and various concentrations of tirzepatide 1, 5, 10, 7.5 and 15. Look at the effect. The top line, with the dulaglutide, is the rounded one with the dulaglutide, the round circles. There is a weight loss along with the diabetes control, but it is only to the action of like 5%. It doesn't continue more than that. And the lowest one, the dark blue and the turquoise one, is with various doses of tirzepatide, and with the 15 milligram of tirzepatide, there is almost a loss of more than 25% of body weight and continuation of maintenance of the loss of body weight. So these were the clinical trials, phase 3 clinical trials. They were done with, this was the program. Surmount 1 was done for the weight management. In 2, the weight management in diabetes mellitus. 3, it was continued with intensive lifestyle. 4, with maintenance of the weight loss. And with 5th, with the related comorbidities. So what we achieved was like 25% weight loss with the maximum dose of 10 to 15 milligram of tirzepatide. And so same is the improvement in the BMI. So greater than 81% participants in the 15 milligram arm achieved at least minimum 5% body weight loss, and over 50% participants, they at least got 15% weight loss as a key secondary objective. So, and the impact on the maintenance of weight reduction and benefits of the continued therapy. So the therapy was continued, the benefit was continued as such. This is a very, very important trial, the Synergy NASH trial, because now is again the epidemic of our MASH cases. We are every day, all the reports from the radiology are coming, fatty liver, fibrosis, grade 1, 2, 3, 4, and we are again heading towards the, so much of liver disease burden because of the MASH is coming now. And this is again a light by the end of the tunnel, that this phase 2 clinical trial, they evaluated tirzepatide for treating MASH with liver fibrosis, and there was almost complete disappearance of the inflammation of the hepatocytes and also improvement of the fibrosis at least to grade 1 or 2, like somebody having F2 could come down to F1, for F1 to F0. So with 15 milligram, there was MASH resolution in around 73% cases compared to placebo with 13%, and fibrosis improvement with 54% cases compared to 32%, and a persistent good weight loss. And even a weight loss of 5%, it improves the adiposity related complications. Name it, like whatever we named as the complication, like diabetes, hypertension, obstructive sleep apnea, osteoarthritis, dyslipidemia, metabolic syndrome, dysfunction associated, and NASH and steatohepatitis, everything improved even with the 5% weight loss. Now let us have a look at the FDA approved GLP-1 and GIP agonists and frequency of administration. We have semaglutide with Novo Nordisk once in a week injection, the Ozempic and the Wegovy. It is recommended both in diabetics and weight loss, but compared to tirzepatide, the weight loss with semaglutide is less because it stimulates only one GLP-1 receptor agonist. So while tirzepatide and the one which is oral Rybelsus is effective only for diabetes, it doesn't achieve that kind of a weight loss, not recommended without diabetes. So tirzepatide by Eli Lilly, the frequency of the injection is once a week, available in India especially from 2.5 dose, so that the cost can be less. Otherwise in abroad they have started only from 5 milligram, 5, 7.5, 10 and 15 milligram, so that we can gradually increase the dose according to the need of the patient. Recommended both for Mounjaro, recommended both for obesity and the tremendous weight loss, which is, I would say, it said cut down the role of bariatric surgery to almost very, very low now. So anybody who wants to go in for a bariatric surgery must be given the choice with Mounjaro. And then we had compared with, I've already shown the slide with dulaglutide. It is recommended only in diabetes. The weight loss is not that much. And the others like liraglutide, lexenatide, exenatide are actually to be administered daily. So hence that kind of things, the weight loss is not achieved with them. So the combined actions of GIP and GLP-1, it helps to maintain the metabolic balance by preventing both the hyperglycemia and hypoglycemia. And it improves the insulin sensitivity and it reduces the ectopic fat distribution. The safety, it is extremely safe. It includes only nausea, vomiting, diarrhea and some injection site reactions. And hypoglycemia risks is very, very low. Long-term safety data are still being collected. Well, this is one of our children only from relatives. I've taken his permission to show the picture. He is a radiologist. The one standing tall, 6 feet 7 inches, weighing at 158 kgs. And this is the other picture after losing 40 kgs of weight and within 4.5 months. So research is ongoing to explore the expanded indications. Cost and accessibility are still little challenges, but personalized treatment approaches, they are important to maximize the benefits and to minimize the risks. Thank you very much. Total therapy actually depends, but it depends how much weight loss and at what time you started the patient on, what kind of BMI you started the patient on. If you started somebody from a BMI of 40 or more than that, naturally you will require it for that long. And any weight loss therapy, anything, if the person goes to same kind of a lifestyle, same kind of food, will come back. You will have to watch with exercise, you will have to prevent sarcopenia, and anybody who's any kind of a weight loss therapy needs to be told that you must continue to do exercise. Patients do because they become more agile. Once they become more agile, they just can't sit. So exercise along with this is also very important. And then looking at your diet continuously, your stomach shrinks. You really don't need to eat that much, but still you have to be watchful. And if you feel that it is coming back, it is again continue, you better restart the therapy. Tapering off, you can, once you have achieved that kind of a weight, you can taper it off by then, because it is only once a week, and then twice a week and by next week, and the patient can keep observing on himself. Well, they had said, but no, it's not that bad, the one it has been publicized before. We had heard of pancreatitis, we were DPP-4 inhibitors also, and look now how much DPP-4 inhibitors we use, sitagliptin, vildagliptin, teneligliptin. We used to be so afraid of pancreatitis. It's almost the same. I haven't seen any personal case of pancreatitis, but still the results are coming, but it's not to be, we don't need to be afraid of it. At the most, we can be watchful. We can stop if we feel the enzymes are rising.
Thank you, ma'am.
this topic has really generated interest wherever we go in conference. The lecture is of 20 minutes and 30 minutes is of discussion. So this is a hyped product, I think. Any comments, Dr. Atul?
Yeah, they must come from Dr. Atul.
Thank you. I could just listen to a part of the talk, but we also reviewed it just now, and it's a great molecule, especially for liver. And I think, like you said rightly, that people who are opting for bariatric, they must be given a chance with this. I think bariatric surgeons' work is going to get affected,
Yes,
surely.
definitely.
And like you said, the pancreatitis risk with tirzepatide is less.
Yeah.
Dominantly was with semaglutide, but that also is not much. There is not much. It was just a little hyped.
Yeah.
I think they are great molecules, and they are also very potent anti-inflammatory agents. And once they are anti-inflammatory agents, I think things will really change with these molecules.
It is amazing to see, within 4 or 5 months how the things change. People also become aware of their food and they just don't feel like eating. And as I told you, the aversion from alcohol, the aversion from smoking is so much. And somebody who's really a dedicated alcohol, as I told you, my patient was such a dedicated alcoholic, he left the molecule because he didn't feel like
That's right.
taking alcohol.
The go off alcohol also.
Yeah.
But very good topic. Thank you.
By doing exercise, and the diet is, then you have to be watchful about the diet. Proteins need to be increased in the diet, and proteins would work both ways, by increasing the satiety for a longer time, and then again the molecule also helping, and the proteins also helping the patient to decrease the sarcopenia. It's a myth. Persons with 90 years also are doing exercise.
Fauja Singh is, example for
It's
that.
when you don't want to exercise, you say that you are aging. When you want to exercise, then at the age of 60, you say I'm 16.
Any absolute contraindication?
Absolute. I mean, it is needed where it is needed.
Actually, why I'm asking is, I think we must rule out retinopathy before starting it. So we have any variability, because this is one drive which predisposes to retinopathy, and diabetic patients, they are already prone for retinopathy, you see. And if you have early changes of retinopathy, probably it is contraindicated.
Fine. The complications of diabetes.
10% of weight loss should be done.
How much?
What time 10% weight loss should be done?
Again, it will depend from patient to patient, I think. Some depending upon their lifestyle before and depending upon the change in the lifestyle. But within 4, the result I have shown you was just a result of 4 months. We can use it in young patients. We will have to use it in young patients because childhood obesity is the main thing.
Yes, main problem is there.
Yeah.
So we can use in 16, 18 years old.
Yes, after this has been tested from 16 to 18 years above.
So any comments, Dr. Preetham Singh?
With the use of drugs, there has to be active involvement of a qualified nutritionist as well,
Yes,
because
that's why I was
just advising the patient and increase your dietary intake and increase the protein, not easy for the patient, especially the main side effect of the drug is anorexia. So I think a qualified nutritionist must also be involved in the treatment plan of such patients.
It has to go everything hand in hand, diet, you need to increase your protein levels, and nutritionists, and of course, as I said, prevention of sarcopenia, because when you lose weight, you lose not only want to happen. It is only with the change in the diet, leaving the carbohydrate diet, putting a more protein diet, and exercising your muscles.
Because this is such an interesting subject as well as molecule. What is your opinion, Dr. Agarwal, please?
No doubt what Professor Sidhu has done is excellent. She has covered most of the things. Tirzepatide, what we call as twin creatine. It is a in thing nowadays, but it is not available.
It's available.
But it is costly.
It is, for India, they have decreased the cost. In India now, 2.5 milligram is available in vial. Now it is coming in the pen also with 4 dosages of 5 milligram each. You dial one dose, then second, then third, fourth. That means it's for 1 month. And you don't have to tell the full cost to the patient because it is worth it. When you compare it with the bariatric surgery, when you see the problems of the patients, it costs around 3,500 to the patient, per single dose. Yeah.
Yeah, that way it is very cost effective, but we still, yes.
I mean, you really need to, that's why I said, cost are always the issues with Indian patients. And we have to be careful with the cost. We always have to ask the patient if he's ready to take the molecule. And then, we tell them, we give them time. Okay, take 1 month, 2 months. With the other drugs and we suggest them lifestyle modifications, we suggest them diet. I always tell them, okay, I give you 1 month, 2 months. You come down to certain weight. If you are showing your weight reduction, we believe we don't give you the molecule. But even after 2-3 months, the patient says, nahi hota, then he asks for it. Madam, ab to de hi do. So
that's true.
the mindset becomes first that I need to lose, and then I've already tried other measures, and now since they're not going to work, so now let's have it.
And what Professor Goel asked is 10% weight reduction in 6 months is very good achievement. Yes. Thank you.
Thank you, sir, for your comments. And I would like to comment that Indian patients fit a jugaad also. So there is news that half of the dose they take in first and second week. So they reduce the cost of that drug because the lower cost and higher cost are the same. So they take the higher dosage and take it twice in a week or so. So that is how they reduce the dose. And it was such a big news in Times of India day before yesterday, documented this jugaad by the Indian patients.
I think jugaads are good.
Yes.
This is not if it is working, it's better to have it. If it works, it's very well. And actually the mindset which gets set. As I said, it's a brain gut axis. When the person knows I'm spending money and I want to save money, and then he's not eating other things, he knows you have to change your diet and you have to change your exercise, and a lot of good effect will come with once you've regulated your mind yourself. And that's the big thing, Once you have to tell yourself, okay, this is no, this is yes, this is a lifestyle. It's actually changing the whole lifestyle. The sleep pattern, you need to be adequately rested, you need to be eating at a proper interval, and you really need to eat a good food, a protein-rich food at that particular interval, not to mix too much of the diets. So everything proper will help. And once the patient is spending money, they know, okay, why not, why should I? This works both ways, If it would be very cheap, I think they will get more, lax about it. Now that it is expensive, they are again very serious about it, and that helps.
Definitely.
And anything which helps, it does help.
So before we close the session, any other question or query from the audience? So I think nobody is obese here or using it. That is why there is
I'm so glad.
So I can just see everybody is quite fit. कोई जिन्ना बड़ा मोटा होगा उन्ना ही पूछूगा ना जी और questions. So thank you, ma'am.
We need to be fit actually now before showing the molecule to the patients.
Yes.
At least patients need to realize. Thank you very much.
So thank you very much for an enlightening talk on this real important topic. With this, we are going to initiate our inaugural session. So that is the most important session, and it is most important because today we have the super chief guest in form of Dr. हमारे टीचर हैं पुराने डॉक्टर जनकराज सचदेवा who inaugurated the first MAPICON also at Desh Medical College, and we are really thankful to Dr. Atul who was motivating force to bring Dr. J.R. Sachdeva to Bathinda, second time. And so we have a super chief guest and chief guest in the form of Atul. So he was our junior, but I must tell you, those who are not aware, कि Dr. Sachdeva da na style hunda si. Jime from the dance you can see कि whether it is Salman Khan or it is Shah Rukh Khan type. So Dr. Sachdeva de PG da khade hon to pata lag janda si कि Dr. Sachdeva da student hai. So he was such a great personality. So I am really honored to have you here, sir. Sir, about MAPICON, I think this is our 12th MAPICON and we are growing. But we have come to a smaller hall from the bigger hall, cost cutting, because a little bit raising of funds is becoming difficult every day. So we are honored to have Mr. Jagrup Singh Gill, our MLA from Bathinda Urban, Mr. Neil Garg, versatile personality, Dr. Mohanlal Garg, and our special guest today from whom we are going to felicitate as our special award, that is Lifetime Achievement Award, to Dr. Sonlal Grover, the oldest and versatile physician of Bathinda, who initiated the Physicians Forum in Bathinda 25 years back. That was his idea. Then only 15 doctors were there in Physicians Forum, and it went very well for next 15-20 years. After that, the academic atmosphere decreased somehow. So that is why we initiated the process of API Malwa branch and started conducting this CME. So that has grown for 4 days and it is the largest. Now it is hybrid also, and almost 150 online registrations. You can find 50-70 people here and more than 200 people online. So we are going to initiate the proceedings by lighting the lamp. I invite Dr. J.R. Sachdeva to please come. Mr. Jagrup Singh Gill, Mr. Neil Garg. Dr. S.L. Grover, Dr. Mohanlal Garg ji, Dr. Sonia Gupta and Dr. Meghna Gupta to please come. So these are the two most important part of organizing MAPICON, Dr. Sonia and Dr. Meghna. Dr. Atul. So we are really very thankful, Dr. Atul. You don't know how much overwhelmed I am to have Dr. Sachdeva here. So this is very informal type of inaugural function, because generally you will find Saraswati Vandana along with, jute utar ke jana hai. So we just want this to, honor our guests. So I welcome our SSP ma'am, Ms. Amneet Kondal, to please join us on stage, and I'll request all the dignitaries to please stay there. Dr. B.K. Agarwal to please join us. Thank you. So please take your seats. Now we will proceed with the felicitation of our So first I request Dr. Sonia and Dr. Meghna to please felicitate our super chief guest, Dr. Janakraj Sachdeva, please. So ma'am, he is our teacher and he inaugurated the first annual conference of physicians of Bathinda in 2014. So next, I request our organizing committee member, Dr. Noria and Dr. M.R. Gupta, to please facilitate Dr. Atul Sachdeva, father and son. First time, father is super chief guest and son is our chief guest. He retired as director, GMC Chandigarh. So next I request Madam to please come, and I request our friends Mr. Anil Pola and Ashwini Malhotra to please honor our special and honored guest. Ashwini kithe hai? Mr. Surinder. So next I request our Honorable MLA Saab, Mr. Jagrup Singh Gill, and I request Dr. Garg please from GMC Faridkot to please come, and Mr. Rajinder Setia to please honor our MLA Saab. So next I request Dr. B.K. Agarwal to please come. He is our honored guest of honor. So I request Mr. and Dr. Kakkad and Mrs. Kakkad to please come on stage to honor our guest of honor. So next I request Mr. Neil Garg Mr. Neil Garg, please. And I will request Dr. R.K. Goyal and Mrs. Goyal to please honor our great friend, enthusiastic supporter of API Malwa branch, Mr. Neil Garg. So request Dr. Mohanlal Garg to please come. So he is our special guest, patron, and versatile physician of Bathinda, one of the oldest. And I request Mr. Sukhdeep and MLA Saab to please honor our guest. For the Lifetime Achievement Award, this time we are conferring it to Dr. Sonlal Grover ji. So please come on stage. And I'll request our super chief guest, Dr. J.R. Sachdeva ji and Madam SSP to please honor our oldest physician of Bathinda.
He is my oldest student from Mumbai.
Okay, sir. So as Madam SSP has to go because it is such a fluid situation, so I'll request her to give a few words to our audience. No, I don't know what to say, but we need such enthusiastic young officers who are inspiration to us. So this is first time that we are inviting any district administration, because whenever we have interaction with ma'am, and it is very pleasant experience, contrary to the image of the police. So you will, forget about all the image of the police once you interact with ma'am. So it is great honor to have you here in physicians meeting, ma'am. Please.
Thank you, Dr. Professor Vitul Gupta. And at the start, jadon unhone mainu, is it Punjabi or Hindi is comfortable or English is okay? So the other day when he, Dr. Sahab aaye sige mere office, I think kal parson di gal hai. So he came to invite me. So firstly, तो I got quite scared with this heading only. Like मैं थे देख रही हूँ, approach to a patient with dyspepsia. So I told him I have got nothing to do with मैं की उत्थे गल करांगी. Plus due to various time contingencies, he had asked me to come on Sunday. So I excused myself. था उन्होंने कैसे चलो आज आ जाना. But I told him with the rider that I'll come, but please don't ask me to speak anything because मैंने कुछ नहीं पता. I'm an arts background, although I'm a master's in psychology, but physicians दा मैंने कोई idea नहीं है. But still, I'm very happy to be here. इस तरह दी gatherings च साडे लिए भी एक fresh change होता है. The doctors know या physicians know मिलके. So I'm very glad I am able to attend this. Though today I had a very packed schedule, so I requested him कि मैं cut time ले आ सकती हूँ. So congratulations to the organizers and such senior doctors ਨੂੰ ਮਿਲ ਕੇ ਬੜਾ ਵਧੀਆ ਲੱਗਿਆ. Whenever one is in a crisis, in any kind of life-threatening situation of the family, ਤਾਂ ਰੱਬ ਵੀ ਲੱਗਦੇ doctors, and especially COVID ਦਾ time ਸਾਰਿਆਂ ਨੇ ਹੀ ਚੱਲਿਆ ਹੈ. So at that time we could not look up to anybody else more than doctors. So thank you for having me here, and I wish you all the best for all of you for good health and better careers. And police ਦਾ ਜਿਵੇਂ ਇਹਨਾਂ ਨੇ ਕਿਹਾ ਮੇਰੀ ਨਾਲ mostly traffic related ਸ਼ਾਇਦ ਕੋਈ ਨਾ ਕੋਈ ਗੱਲਬਾਤ ਹੁੰਦੀ ਰਹਿੰਦੀ ਹੈ। ਸੋ ਦ ਵੈਰੀ ਫੈਕਟ ਦੈਟ ਆਈ ਰਿਸਪੌਂਡ ਹੈ ਮੋਸਟਲੀ ਤਾਂ ਉਸੇ ਗੱਲ 'ਤੇ ਖੁਸ਼ ਹੋ ਜਾਂਦੇ ਆ ਜੋ ਮੈਂ ਦੇਖਿਆ। ਟ੍ਰੈਫਿਕ ਦਾ ਮੈਂ ਇੰਨਾ ਨਹੀਂ ਠੀਕ ਕਰ ਪਾਉਂਦੀ, ਬਟ ਹੀ ਸੇਜ਼ ਯੂ ਰਿਸਪੌਂਡ ਟੂ ਮੀ, ਦੈਟ ਵਿਲ ਆਲਸੋ ਸੋਲਵਸ ਹਾਫ ਆਫ ਦ ਪ੍ਰੋਬਲਮਸ। ਸੋ ਬਾਕੀ ਪੁਲਿਸ ਰਿਲੇਟਡ ਵੀ ਆਰ ਵਰਕਿੰਗ ਡੇ ਐਂਡ ਨਾਈਟ ਟੂ ਟਰਾਈ ਰਿਜ਼ੋਲਵ ਮੋਸਟ ਆਫ ਦ ਪ੍ਰੋਬਲਮਸ, ਬਟ ਸਾਨੂੰ ਵੀ ਕਈ ਤਰ੍ਹਾਂ ਦੇ ਚੈਲੰਜਸ ਹੁੰਦੇ ਹੈ। manpower issues are always there, and Bathinda being a very big city with too many issues going on, we strive our best and we try to give the best of the services. So thank you for the kind words, and thank you so much. Bye.
Thank you, ma'am. आजकल ना जी बेसिकली कम्युनिकेशन का ही गैप है. Why doctor-physician relationship is deteriorating? Because the doctors don't communicate. So whenever a district administration official communicates, so it is a great, you can say experience. So that is why I think in every aspect or every relationship, communication is the most important thing. And communication will heal any atrocity, any misgiving, any misadventure once you communicate. अगर आप कम्युनिकेट करते हो कि मेरे से यार गलती होगी, मैं करना नहीं चाह रहा था, तो half of the things are solved. That is what I have learned in 40 years of my practice. So really grateful, ma'am, for you to come and address the audience. Now I'll invite, हाँ जी. So thank you so much ji. Now I'll invite Mr. Neil Garg, our friend and patronizing API Malwa branch, to say a few words.
बहुत बहुत शुक्रिया डॉक्टर साहब. फैकल्टी मेंबर्स, पार्टिसिपेटिंग डॉक्टर्स, मैडिकल स्टूडेंट्स, सब तो पहला तो मैपीकॉन 2025 बठिंडा ਦੀ ਆਰਗੇਨਾਈਜ਼ਿੰਗ ਕਮੇਟੀ, ਸਪੈਸ਼ਲੀ ਡਾਕਟਰ ਵਿਤਲ ਗੁਪਤਾ, ਮੈਂ ਇਹਨਾਂ ਦਾ ਧੰਨਵਾਦ ਕਰਨਾ ਚਾਹੁੰਦਾ ਕਿ ਇਹੋ ਜਿਹੇ ਵਿਗਿਆਨਿਕ ਪ੍ਰੋਗਰਾਮ ਦੇ ਵਿੱਚ ਸਾਡੇ ਵਰਗੇ ਲੇਮੈਨ ਨੂੰ ਵੀ ਬੁਲਾ ਕੇ ਇੱਥੇ ਤੁਸੀਂ ਇਹ ਮਾਣ ਬਖਸ਼ਿਆ। ਔਰ ਦੂਸਰੀ ਗੱਲ ਜਿਹੜੀ ਇਹ ਕਾਨਫਰੰਸ ਹੋ ਰਹੀ ਹੈ ਔਰ ਬਠਿੰਡਾ ਦੇ ਵਿੱਚ ਇਹ ਮਾਣ ਵਾਲੀ ਗੱਲ ਹੈ, ਸ਼ਾਨ ਵਾਲੀ ਗੱਲ ਹੈ, ਇਹ ਇਕੱਲੀ ਜਿਹੀ ਕਾਨਫਰੰਸ ਨਹੀਂ ਹੈ, ਬਲਕਿ ਇਹ ਗਿਆਨ, ਸੇਵਾ ਅਤੇ ਜੇ ਮੈਂ ਕਹਾਂ ਮਨੁੱਖਤਾ ਦੇ ਮਿਲਾਪ ਦਾ ਇੱਕ ਤਿਉਹਾਰ ਹੈ। ਔਰ ਡਾਕਟਰ ਦੇ ਲਈ ਅੱਜ ਇੱਕ ਮਰੀਜ਼ ਹੈ, ਸਿਰਫ ਉਹ ਉਸ ਦੇ ਇਲਾਜ ਤੱਕ ਸੀਮਤ ਨਹੀਂ ਹੈ, ਬਲਕਿ ਉਸ ਦੇ ਵਿੱਚ ਨਵੀਂ ਊਰਜਾ, ਨਵੀਂ ਉਮੰਗ, ਨਵੀਂ ਸ਼ਕਤੀ, ਜਿਉਣ ਦੀ ਇੱਛਾ ਪੈਦਾ ਕਰਨਾ ਵੀ ਯਾਨੀ ਕਿ ਇੱਕ ਡਾਕਟਰ ਦੀ ਸੇਵਾ ਦੇ ਵਿੱਚ ਆਉਂਦਾ। ਡਾਕਟਰ ਬਾਖੂਬੀ ਇਸ ਚੀਜ਼ ਨੂੰ ਕਰਦਾ ਆ। ਔਰ ਮੈਨੂੰ ਪੂਰੀ ਉਮੀਦ ਆ ਕਿ ਇਸ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਜੋ ਵਿਚਾਰ ਚਰਚਾ ਹੋਏਗੀ, ਆਪਣੀ ਜਿਹੜੀ ਖੋਜ ਹੈ, ਉਹਨਾਂ ਦਾ ਐਕਸਪੀਰੀਅੰਸ ਡਾਕਟਰ ਪਾਰਟੀਸਪੇਟਿੰਗ ਡਾਕਟਰਸ ਦੇ ਨਾਲ, ਮੈਡੀਕਲ ਸਟੂਡੈਂਟਸ ਦੇ ਨਾਲ ਕੀਤਾ ਜਾਏਗਾ। ਮੈਨੂੰ ਉਮੀਦ ਹੈ ਉਹ ਇੱਕ ਸਿਹਤਮੰਦ ਅਤੇ ਉਜਵਲ ਜਿਹੜਾ ਹੈ ਸਮਾਜ ਦੀ ਸਿਰਜਣਾ ਦੇ ਵਿੱਚ ਵੱਡਾ ਰੋਲ ਅਦਾ ਕਰੇਗਾ। ਔਰ ਤੁਹਾਡੀ ਇੱਥੇ ਕੀਤੀ ਹੋਈ ਵਿਚਾਰ ਚਰਚਾ ਦਾ ਨਾ ਕੇਵਲ ਬਠਿੰਡਾ, ਨਾ ਕੇਵਲ ਪੰਜਾਬ, ਬਲਕਿ ਹਿੰਦੁਸਤਾਨ ਪੱਧਰ 'ਤੇ ਜਿਹੜੀਆਂ ਵੀ ਸਿਹਤ ਸੇਵਾਵਾਂ ਹੈਗੀਆਂ ਨੇ, ਉਸ ਫੀਲਡ ਦੇ ਵਿੱਚ ਸਭ ਨੂੰ ਉਸ ਚੀਜ਼ ਦਾ ਬੈਨੀਫਿਟ ਹੋਏਗਾ। ਅਤੇ ਮੈਂ ਤੁਹਾਨੂੰ ਸਾਰਿਆਂ ਨੂੰ ਨਮਨ ਕਰਦਾ ਕਿ ਤੁਸੀਂ ਇੱਕ ਨੋਵਲ ਕਾਜ਼ ਦੇ ਲਈ ਕੰਮ ਕਰ ਰਹੇ ਹੋ, ਅਤੇ ਡਾਕਟਰ ਸਾਹਿਬ ਨੂੰ ਮੁਬਾਰਕਬਾਦ ਦਿੰਦਾ ਕਿ ਇਹ 12ਵੀਂ ਕਾਨਫਰੰਸ ਹੈਗੀ ਹੈ। ਇੱਕ ਅੱਧੀ ਕਾਨਫਰੰਸ ਕਰਾਉਣੀ ਬਹੁਤ ਈਜ਼ੀ ਟਾਸਕ ਹੁੰਦਾ ਆ, ਕੰਮ ਨੂੰ ਸ਼ੁਰੂ ਕਰਨਾ ਬਹੁਤ ਸੌਖਾ ਹੁੰਦਾ ਹੈ, ਔਰ ਉਸ ਕੰਮ ਨੂੰ ਲਗਾਤਾਰ ਕਰਦੇ ਜਾਣਾ। ਇੱਕ ਹੁੰਦਾ ਨਾ ਸਕਸੈਸ ਬਾਈ ਡਿਫਾਲਟ, ਇੱਕ ਹੁੰਦਾ ਸਕਸੈਸ ਬਾਈ ਡਿਜ਼ਾਈਨ। ਇਹ ਸਕਸੈਸ ਬਾਈ ਡਿਜ਼ਾਈਨ ਹੈ। 12 ਸਾਲ ਐਵੇਂ ਨਹੀਂ ਗੁਜ਼ਰਦੇ। ਅਤੇ ਬਹੁਤ ਬਹੁਤ ਮੁਬਾਰਕਾਂ ਸਰ ਤੁਹਾਨੂੰ ਵੀ, ਤੁਹਾਡੀ ਟੀਮ ਨੂੰ ਵੀ, ਅਤੇ ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਕਰਦੇ ਰਹੋ। ਅਤੇ ਉਮੀਦ ਆ ਕਿ ਇੱਥੇ ਕੀਤੀ ਹੋਈ ਵਿਚਾਰ ਚਰਚਾ ਸਾਡੇ ਸਮਾਜ ਨੂੰ ਇੱਕ ਨਵੀਂ ਸੇਧ ਦੇਗੀ। ਬਹੁਤ ਬਹੁਤ ਸ਼ੁਕਰੀਆ, ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ।
ਥੈਂਕ ਯੂ ਗਰਗ ਸਾਹਿਬ, ਤੁਹਾਡੀ ਸਪੋਰਟ ਰਹਿੰਦੀ ਹੈ ਅਤੇ ਸਾਨੂੰ ਇੰਥੂਜ਼ਿਆਸਟਿਕਲੀ ਅਸੀਂ ਅੱਗੇ ਕੰਮ ਕਰਨ ਦੀ ਉਹ ਕਰਦੇ ਹਾਂ। ਜਦੋਂ ਕੰਟੈਕਟ ਕਰਨਾ ਹੁੰਦਾ ਕਿਸੇ ਨੂੰ, ਨੀਲ ਗਰਗ ਜੀ ਨੂੰ ਫੋਨ ਕਰ ਦਈਦਾ ਕਿ ਯਾਰ ਸਾਡਾ ਕੰਮ ਕਰਾ ਦਿਓ, ਅਤੇ ਅਲਟੀਮੇਟਲੀ ਇਟ ਇਜ਼ ਡਨ ਇਨ ਅਕੋਰਡਿੰਗ ਟੂ ਹਿਜ਼ ਕੈਪੈਸਿਟੀ ਟੂ ਡੂ ਇਟ। ਨਾਓ ਆਈ ਰਿਕੁਐਸਟ, ਮੇਰੇ ਮੂੰਹ 'ਚੋਂ ਨਾ ਹਮੇਸ਼ਾ ਜਗਰੂਪ ਅੰਕਲ ਨਿਕਲ ਜਾਂਦਾ, ਆਈ ਰਜਿਸਟ ਟੂ ਸੇ ਦੈਟ। ਸੋ ਮਿਸਟਰ ਜਗਰੂਪ ਸਿੰਘ ਜੀ ਗਿੱਲ, ਆਵਰ ਆਨਰੇਬਲ MLA ਬਠਿੰਡਾ ਅਰਬਨ, to please address the.
ਬਹੁਤ ਹੀ ਸਤਿਕਾਰਯੋਗ ਅੱਜ ਦੀ ਇਸ ਕਾਨਫਰੰਸ ਨੂੰ ਆਯੋਜਿਤ ਕਰ ਰਹੇ ਡਾਕਟਰ ਬਿੱਤਲ ਗੁਪਤਾ ਜੀ, ਪਹਿਲੀ ਗੱਲ ਤਾਂ ਮੈਂ ਤੁਹਾਨੂੰ ਦੱਸਾਂ, ਤੁਸੀਂ ਕਿਹਾ ਵੀ ਜਗਰੂ ਪੰਕੜ ਨਿਕਲ ਜਾਂਦਾ, ਉਹ ਚੀਜ਼ ਸੁਭਾਵਕ ਨਿਕਲਦੀ ਹੈ ਜਿਹਦਾ ਕਿਸੇ ਕੋਲ ਅਧਿਕਾਰ ਹੋਵੇ। ਤੁਸੀਂ ਬਚਪਨ 'ਚ ਪੜ੍ਹਦੇ ਸੀ ਜਦੋਂ ਦੇ ਅਸੀਂ ਕਾਮਰੇਡ ਬੇਦ ਪ੍ਰਕਾਸ਼ ਗੁਪਤਾ ਦੇ ਨਾਲ ਆਪ ਦਾ ਬੜਾ ਲੰਬਾ ਸਮਾਂ ਗੁਜ਼ਾਰਿਆ। ਨੈਚੁਰਲੀ ਹੈ, ਪਰਿਵਾਰ ਦਾ ਜਿਹੜਾ ਸੰਬੰਧ ਹੈ ਉਹ ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਲਗਾਤਾਰ ਚੱਲਦਾ ਰਹਿੰਦਾ ਔਰ ਚੱਲਦਾ ਰਹਿਣਾ ਚਾਹੀਦਾ। ਡਾਕਟਰ ਸੋਨੀਆ, ਡਾਕਟਰ ਮੇਘਨਾ ਔਰ ਸਾਰੇ ਹੀ ਡਾਕਟਰ ਸਾਹਿਬ ਹੋਰੀ ਜਿਹੜੇ ਸਾਡੇ ਇੱਥੇ ਬਠਿੰਡੇ ਦੀ ਅਥਾਰਟੀ ਨੇ, ਡਾਕਟਰ ਨੌਰੀਆ ਜੀ, ਡਾਕਟਰ ਗਰਗ ਸਾਹਿਬ, ਡਾਕਟਰ ਗਰੋਵਰ ਔਰ ਸਾਰੇ ਹੀ ਜਿਹੜੇ ਤੁਸੀਂ ਇੱਥੇ ਚੱਲ ਕੇ ਆਏ, ਮੈਥੋਂ ਸਾਰੇ ਹੀ ਵੱਧ ਸਿਆਣੇ ਹੋ। ਔਰ ਇਸ ਮੈਪੀਕੌਨ ਦੀ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਮੇਰੇ ਵਰਗੇ ਲੇਮੈਨ ਬੰਦੇ ਦਾ ਸੰਬੋਧਨ ਕਰਨਾ ਮੈਨੂੰ ਜੱਚਦਾ ਨਹੀਂ। ਮੈਨੂੰ ਲੱਗਦਾ ਤੁਹਾਡਾ ਮੈਂ ਟਾਈਮ ਹੀ ਖਰਾਬ ਕਰੂੰਗਾ। ਮੈਂ ਜਦੋਂ ਆਇਆ ਸੀ, ਡਾਕਟਰ ਸਾਹਿਬ ਬੜੀ ਬਰੀਕੀ ਦੇ ਨਾਲ ਜਿਹੜਾ ਆਪਦਾ ਲੈਕਚਰ ਦੇ ਰਹੇ ਸੀ ਔਰ ਸਾਰੇ ਹੀ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਉਸ ਨੂੰ ਬੜੇ ਧਿਆਨ ਨਾਲ ਸੁਣ ਰਹੇ ਸੀ ਅਤੇ ਉਸ ਦੇ ਉੱਤੇ ਜਦੋਂ ਡਿਸਕਸ਼ਨ ਹੋਈ ਉਸ ਦੇ ਉੱਤੇ ਕੁਐਸਚਨ ਵੀ ਕਰ ਰਹੇ ਸੀ। ਮੇਰੇ ਦਿਮਾਗ 'ਚ ਇੱਕ ਗੱਲ ਆ ਰਹੀ ਸੀ, ਤੁਹਾਡਾ ਪ੍ਰੋਫੈਸ਼ਨ ਹੈ, ਹਰ ਵਿਅਕਤੀ ਚਾਹੁੰਦਾ ਹੈ, ਡਾਕਟਰ ਔਰ ਵਕੀਲ ਦੋ ਪ੍ਰੋਫੈਸ਼ਨ ਇਹੋ ਜਿਹੇ ਹੈ, ਡਾਕਟਰ ਚਾਹੁੰਦਾ ਹੈ ਕਿ ਜਿਹੜਾ ਪੇਸ਼ੈਂਟ ਮੇਰੇ ਕੋਲ ਆਵੇ ਉਹ ਠੀਕ ਹੋ ਕੇ ਜਾਵੇ, ਉਹ ਉਸ ਦੀ ਸੁੱਖ ਮੰਗਦਾ ਹੈ ਹਮੇਸ਼ਾ। ਵਕੀਲ ਹਮੇਸ਼ਾ ਚਾਹੁੰਦਾ ਹੈ ਕਿ ਜਿਹੜਾ ਕੇਸ ਮੇਰੇ ਕੋਲ ਆ ਗਿਆ ਮੈਂ ਉਹ ਜਿੱਤ ਕੇ ਦੇਵਾਂ, ਇਹਨੂੰ ਦੋਨਾਂ ਦੀ ਇੱਛਾ ਹੁੰਦੀ ਹੈ। ਤੁਸੀਂ ਸਾਰੇ ਇੱਥੇ ਜਿਹੜਾ ਆਪਸੀ ਗਿਆਨ ਸਾਂਝਾ ਕਰਨ ਆਏ ਹੋ, ਇਸ ਦੇ ਨਾਲ ਤੁਹਾਡੇ ਗਿਆਨ ਦੇ ਵਿੱਚ ਜਿਹੜਾ ਵਾਧਾ ਹੋਣਾ ਹੈ ਉਹ ਇਕੱਲਾ ਤੁਹਾਨੂੰ ਫਾਇਦਾ ਨਹੀਂ ਹੋਣਾ, ਤੁਸੀਂ ਸਾਰੇ ਸਮਾਜ ਦੇ ਲਈ ਸੋਚ ਰਹੇ ਹੋ। ਜੋ ਕੁਛ ਵੀ ਇੱਥੋਂ ਤੁਸੀਂ ਬਿਮਾਰੀਆਂ ਦੱਸ ਰਹੇ ਸੀ, ਮੋਟਾਪਾ ਹੈ ਜਾਂ ਕੋਈ ਹੋਰ ਹੈ, ਟੈਕਨੀਕਲੀ ਵਰਡ ਮੈਨੂੰ ਨਹੀਂ ਬਹੁਤੇ ਯਾਦ ਰਹਿੰਦੇ, ਜਿਹੜੀਆਂ ਤੁਸੀਂ ਇੱਥੋਂ ਕੀਤੀਆਂ ਤੁਸੀਂ ਆਪਦੇ ਵਾਸਤੇ ਤਾਂ ਨਹੀਂ ਸੀ ਕਰ ਰਹੇ, ਤੁਸੀਂ ਉਹਨਾਂ ਦੀ ਚਿੰਤਾ ਸਮਾਜ ਦੀ ਕਰ ਰਹੇ ਸੀ ਕਿ ਸਮਾਜ ਦੇ ਵਿੱਚ ਆਹ ਬਿਮਾਰੀਆਂ ਫੈਲ ਰਹੀਆਂ ਨੇ, ਇਹਨਾਂ ਨੂੰ ਦੂਰ ਕਰਨ ਦੇ ਲਈ ਆਹ ਮੋਲੀਕਿਊਲ ਜਾਂ ਆਹ ਜਿਹੜੀ ਮੈਡੀਸਨ, ਆਹ ਐਕਸਰਸਾਈਜ਼ਿਸ, ਆਹ ਖਾਣ ਪੀਣ ਦੇ ਉੱਤੇ ਪ੍ਰਤੀਬੰਧ ਜਿਹੜਾ ਲਾਉਣਾ ਹੈ ਉਹ ਜ਼ਰੂਰੀ ਹੈ। ਤੁਸੀਂ ਆਪਦੇ ਲਈ ਨਹੀਂ ਸੀ ਕਰ ਰਹੇ ਹੋ, ਤੁਸੀਂ ਸਮਾਜ ਲਈ ਕਰ ਰਹੇ ਸੀ। ਜੋ ਕੁਛ ਤੁਸੀਂ ਆਪਦੇ ਪ੍ਰੋਫੈਸ਼ਨ ਜਾ ਕੇ ਦੇਣਾ ਹੈ ਉਹ ਸਮਾਜ ਨੂੰ ਦੇਣਾ ਹੈ। ਇਸ ਲਈ ਮੈਂ ਤੁਹਾਡਾ ਸਾਰਿਆਂ ਦਾ ਧੰਨਵਾਦੀ ਹਾਂ ਕਿ ਤੁਸੀਂ ਜਿੱਥੇ ਆਪਦੀ ਪ੍ਰੈਕਟਿਸ ਕਰਦੇ ਹੋ ਤੁਸੀਂ ਬਹੁਤ ਵੱਡੇ ਸਮਾਜ ਚਿੰਤਕ ਹੋ ਔਰ ਹੋਣਾ ਚਾਹੀਦਾ। ਪਰਮਾਤਮਾ ਕਰੇ ਤੁਸੀਂ ਸਾਰੇ ਵਧੋ ਫੁੱਲੋ ਔਰ ਅੱਜ ਦੀ ਜਿਹੜੀ ਇਹ ਕਾਨਫਰੰਸ ਹੈ 25ਵੀਂ, ਇਸ ਦੇ ਵਿੱਚੋਂ ਬਹੁਤ ਕੁਛ ਲੈ ਕੇ ਜਾਓ ਜਿਹੜਾ ਸਮਾਜ ਦੇ ਵਿੱਚ ਆਪਣੇ ਮਰੀਜ਼ਾਂ ਨੂੰ ਦਿਓ, ਸਮਾਜ ਤੰਦਰੁਸਤ ਰਹੇ। ਇਹੀ ਮੈਂ ਕਾਮਨਾ ਕਰਦਾ ਹੋਇਆ ਡਾਕਟਰ ਸਾਹਿਬ ਹੋਰਾਂ ਦਾ ਧੰਨਵਾਦ ਕਰਦਾ, ਇਹਨਾਂ ਨੇ ਸਾਨੂੰ ਯਾਦ ਕੀਤਾ ਸੀ, ਹਾਜ਼ਰ ਹੋਏ। ਤੁਹਾਡਾ ਸਾਰਿਆਂ ਦਾ ਧੰਨਵਾਦ ਕਰਦਾ ਕਿ ਤੁਸੀਂ ਇਸ ਮੈਪੀਕੌਨ ਦੀ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਆਏ। ਲਗਾਤਾਰ ਜਿਵੇਂ ਨੀਲ ਜੀ ਨੇ ਕਿਹਾ, ਇਸ ਤਰ੍ਹਾਂ ਕਾਨਫਰੰਸਾਂ ਨੂੰ ਚਾਲੂ ਰੱਖਣਾ ਹਰ ਵਿਅਕਤੀ ਦਾ ਬੱਸ ਦਾ ਰੋਗ ਨਹੀਂ ਹੁੰਦਾ। ਕਈ ਵਾਰੀ ਅਸੀਂ ਕੰਮ ਸ਼ੁਰੂ ਕਰਕੇ ਛੱਡ ਜਾਂਦੇ ਹਾਂ। ਡਾਕਟਰ ਬਿੱਤਲ, ਮੈਂ ਤੁਹਾਡਾ ਬਹੁਤ ਧੰਨਵਾਦੀ ਹਾਂ। ਆਸ ਕਰਦਾ ਕਿ ਲਗਾਤਾਰ ਇਸ ਤਰ੍ਹਾਂ ਹੀ ਤੁਹਾਡੀ ਜਿਹੜੀ ਇਹ ਕੋਸ਼ਿਸ਼ ਚੱਲਦੀ ਰਹੇਗੀ, ਸਮਾਜ ਨੂੰ ਇਸ ਦਾ ਫਾਇਦਾ ਹੁੰਦਾ ਰਹੇਗਾ। ਧੰਨਵਾਦ। ਜੈ ਹਿੰਦ।
ਸ਼ੁਕਰੀਆ MLA ਸਾਹਿਬ। ਇਹਦਾ ਕੰਸਿਸਟੈਂਟਲੀ ਅੱਗੇ ਵਧਣਾ ਸਾਡੀ ਆਰਗੇਨਾਈਜ਼ਿੰਗ ਕਮੇਟੀ ਦੋਨੇ ਮੈਡੀਕਲ ਅਤੇ ਉਸ ਤੋਂ ਜ਼ਿਆਦਾ ਇੰਪੋਰਟੈਂਟ ਨਾਨ ਮੈਡੀਕਲ ਜਿਹੜੀ ਆਰਗੇਨਾਈਜ਼ਿੰਗ ਕਮੇਟੀ ਹੈ, ਜਿਹਦੇ ਸਾਡੇ ਤੁਸੀਂ ਵੀ ਸਰਪ੍ਰਸਤ ਹੋ, ਸੋ ਉਸ ਕਰਕੇ ਅਸੀਂ ਅੱਗੇ ਵਧ ਰਹੇ ਹਾਂ। ਅਤੇ ਮੈਂ ਬਹੁਤ ਸ਼ੁਕਰਗੁਜ਼ਾਰ ਹਾਂ ਆਪਣੇ ਦੋਸਤਾਂ ਦਾ ਜਿਹੜੇ ਮੈਨੂੰ ਹੈਲਪ ਕਰਦੇ ਹੈ। ਉਸ ਕਰਕੇ ਮੈਂ ਤੁਹਾਨੂੰ ਇੱਕ ਸਿੰਪਲ ਜੀ ਇੰਸੀਡੈਂਟ ਦੱਸਦਾ ਕਿ ਪਤਾ ਲੱਗਦਾ ਹੈ ਕਿ ਵੱਡੀ ਕਾਨਫਰੰਸ ਹੋ ਰਹੀ ਹੈ, ਫੋਨ ਆਉਣ ਲੱਗ ਜਾਂਦੇ ਆ ਇਹਦੇ ਇਵੈਂਟ ਮੈਨੇਜਰਸ ਦੇ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਵੀ ਵਾਂਟ ਟੂ ਆਰਗੇਨਾਈਜ਼ ਯੂਰ ਕਾਨਫਰੰਸ। ਮੈਂ ਉਹਨਾਂ ਨੂੰ ਪੁੱਛ ਲੈਂਦਾ ਕਿ ਯਾਰ ਕਿੰਨੇ ਕੁ ਪੈਸੇ ਲਾਓਗੇ ਤੁਸੀਂ? ਉਹ ਕੋਈ ਕਹਿੰਦਾ ਜੀ 12 ਲੱਖ ਰੁਪਈਆ, ਕੋਈ 15 ਲੱਖ ਰੁਪਈਆ ਆਰਗੇਨਾਈਜ਼ਿੰਗ ਕਾਸਟ। ਉਹ ਮੈਂ ਕਹਿ ਰਿਹਾ ਇਸ ਤੋਂ ਅੱਧੇ 'ਚ ਤਾਂ ਮੈਂ ਕਾਨਫਰੰਸ ਕਰਾ ਦਿੰਦਾ। ਤੁਹਾਨੂੰ ਕਾਨਫਰੰਸ ਕਰਾਉਣ ਵਾਸਤੇ ਮੈਂ 12 ਲੱਖ ਕਿਉਂ ਦਊਂਗਾ ਜੇ ਮੈਂ 6 ਲੱਖ 'ਚ ਕਾਨਫਰੰਸ ਕਰਾਉਣਾ ਤਾਂ? ਸੋ ਇਟ ਇਜ਼ ਬਿਕੋਜ਼ ਆਫ ਦੀ stable, good organizing committee, and I stress my non-medical friends, they work tirelessly. ਸਵੇਰੇ ਸਾਡੇ ਵੋਲੰਟੀਅਰ ਨਹੀਂ ਆਏ ਸੀ ਅਤੇ ਉਹ ਰਜਿਸਟ੍ਰੇਸ਼ਨ ਸ਼ੁਰੂ ਹੋ ਗਈਆਂ ਸੀ। ਅਤੇ ਤੁਸੀਂ ਇਮੈਜਿਨ ਕਰੋ ਕਿ ਮਿਸਟਰ ਅਸ਼ਵਨੀ ਮਲਹੋਤਰਾ ਰਸੋਈ ਦੇ ਜਿਹੜੇ ਓਨਰ ਹੈਗੇ ਆ, ਹੁਣ ਕਲੱਬ ਦਾ ਵੀ ਉਹਨਾਂ ਕੋਲ ਚਾਰਜ ਹੈਗਾ, ਉਹ ਸਵੇਰੇ 8 ਵਜੇ ਆ ਕੇ ਅਤੇ ਉਹਨੇ ਮੈਨੇਜ ਕੀਤਾ ਸਾਰਾ ਜਿਹੜਾ ਰਜਿਸਟ੍ਰੇਸ਼ਨ ਕਾਊਂਟਰ ਹੈ ਸਿੰਗਲ ਹੈਂਡਡਲੀ. ਸੋ ਦੈਟ ਇਜ਼ ਵਾਈ ਆਈ ਐਮ ਰੀਅਲੀ ਥੈਂਕਫੁਲ ਟੂ ਮਾਈ ਫਰੈਂਡਸ to help me organize this conference. So now I'll request my friend, my junior, our chief guest, Dr. Atul Sachdeva, to please give us some guidance, because he has gone to the position, unparalleled, like Director GMC Chandigarh. ਜਦੋਂ ਆਪਾਂ ਨਾਮ ਲੈਂਦੇ ਹਾਂ ਤਾਂ ਉਹੀ ਹੁੰਦਾ ਵੀ ਮੇਰਾ ਮੁੰਡਾ ਜੀ GMC ਚੰਡੀਗੜ੍ਹ ਐਡਮਿਟ ਹੋ ਗਿਆ, ਅਤੇ ਸਾਨੂੰ ਬੜਾ ਗਰਵ ਹੁੰਦਾ ਕਹਿਣ ਲੱਗੇ ਕਿ GMC ਚੰਡੀਗੜ੍ਹ ਦਾ ਡਾਇਰੈਕਟਰ ਸਾਡਾ ਮਿੱਤਰ ਹੈ. ਤੇ ਅੱਜ he has graced the occasion. So please say a few words to encourage us, to guide us how to grow further.
Thank you, Vitul. You don't need guidance actually, first of all. Pehli gal tha, because I think organizing a 12th conference of this magnitude, although like you said, that you have actually now come down to a smaller hall. Once I came, it was in that huge hall. I think that was the adjacent hall. So, but nevertheless, it is a great initiative, and keep the, like MLA Saab keh rahe si, we keep the flag flying. I think we always share knowledge, in all this. You've done a great job. I'm very, very grateful for you to call me here. It's always a pleasure. But thank you again, I think, of calling my father also. You see, basically, my dad has taught us. I was the last batch, or the second last batch that he taught. And but I've learnt everything from him. Obviously, as a child, you learn from your parents and everything. Thank you for honoring us. But like I said, it's a great learning experience. जब भी आप कोई कॉन्फ्रेंस करते हो तो आप हमेशा सीखते हो एक दूसरे से, बहुत कुछ सीखते हो. सो आपको मैं वही कह रहा हूँ कि आपको गाइडेंस की ज़रूरत नहीं है. यू राइट सो वेल, एंड ही इज़ ऑल्सो अ ग्रेट ह्यूमन राइट्स एक्टिविस्ट बेसिकली. आप ऑफ कोर्स, एंड ही राइट्स, contributes regularly to newspapers. So that's a great thing. I really don't know what to say beyond this, because मेरे को लग रहा है कि आपका सारा बहुत अच्छी ऑर्गेनाइजेशन है. You have a good core of people supporting you. You have the support of administration. You have the support of the politicians. You can take this forum even higher. And I wish you have a national conference, which I think you are very capable of organizing. And you have also organized Punjab level conferences earlier, but you can always now, of course, organize national level conference. You're a well-known figure in various conferences. I know you have done very, very well, and I'm grateful to all the people who are here, and I'm also very happy to meet some of my old friends, Dr. Gurshan and Dr. Agarwal, and my colleague from GMCH, Preetam. So it's thank you very much. Thank you, and all the very best. I don't think you need any guidance. Thank you.
Thank you, Atul, for really kind words. I am really thankful to all the faculty. Basically, this time we have called 15 national faculties. So unfortunately, the Bathinda-Delhi flight is very controversial or very inconsistent, or you can say you cannot predict. So we have, out of 6, 5 cancellation of flight. So that is why most of the faculty could not come here. So otherwise we had invited 15 national faculties. For cancellation also we are suffering a monetary loss. So that is, in spite of that, so we are carrying on. And second is, our mentor, our guide, Dr. Gurpreet Singh Wander, could not make it today because he fell sick yesterday. So he called me that he was unable to come. So we always relish his guidance, because that is his promotion from the very first day of my college in August 1978. The very first day of college I met him, and throughout he is guiding me like a younger brother, like a student, and he has promoted me like anything. So we really miss Dr. Gurpreet Singh Wander. And last but not the least, super chief guest sir, Dr. J.R. Sachdeva, icon in itself, a style in itself,
And we are really honored, overwhelmed to have you here, sir, after 12 years. You inaugurated our first conference, and we wish we could call you next time also to please address the audience and give your blessings to us.
I think it's a great pleasure to be here, and I'm thankful and humbly appreciate Dr. Vittal, his colleagues, for inviting me over. I remember about 12 years back, 12 ਸਾਲ ਕਹਿ ਲਓ, ਜਦੋਂ ਮੈਂ ਇਹਨਾਂ ਦੀ MAPICON ਇਨਾਗਰੇਸ਼ਨ ਕਰਨ ਵਾਸਤੇ ਆਇਆ, ਫਸਟ ਮੀਟਿੰਗ ਸੀ। ਬੜਾ ਖੁਸ਼ੀ ਵਾਲੀ ਗੱਲ ਸੀ ਕਿ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਅਸੀਂ ਐਸੋਸੀਏਸ਼ਨ ਆਫ ਫਿਜ਼ੀਸ਼ੀਅਨਸ ਦੀ ਬ੍ਰਾਂਚ ਨਹੀਂ ਖੋਲ੍ਹ ਸਕੇ ਸੀ, ਪਰ ਇਸ ਨੇ ਵਿਤੁਲ ਨੇ ਮਿਹਨਤ ਕਰਕੇ, ਇਹਨਾਂ ਦੀ ਕੁਲੀਗ ਨੇ, ਇਹਨਾਂ ਦੇ ਦੋਸਤਾਂ ਨੇ ਇੱਕ ਮਾਲਵਾ ਦੀ ਬ੍ਰਾਂਚ ਸ਼ੁਰੂ ਕੀਤੀ। ਔਰ ਪੰਜਾਬ ਦੀ ਬ੍ਰਾਂਚ ਅਜੇ ਤੱਕ ਨਹੀਂ ਬਣ ਪਾਈ। ਮੈਡੀਕਲ ਕਾਲਜਸ ਨੇ, ਅੰਮ੍ਰਿਤਸਰ ਬਹੁਤ ਐਕਟਿਵ ਹੈ, ਪਟਿਆਲਾ ਬੜਾ ਐਕਟਿਵ ਹੈ, ਅਤੇ ਕੰਟੀਨਿਊਸ ਮੈਡੀਕਲ ਐਜੂਕੇਸ਼ਨ ਤਾਂ ਚੱਲਦੀ ਰਹਿੰਦੀ ਹੈ, ਪਰ ਅਜੇ ਤੱਕ ਉਹ ਨਹੀਂ ਕਰ ਸਕਦੇ। ਇਸ ਤੋਂ ਇਲਾਵਾ ਆਈ ਫਾਈਂਡ ਬਠਿੰਡਾ ਇੱਕ ਬੜਾ ਵੱਡਾ ਮੈਡੀਕਲ ਸੈਂਟਰ ਬਣ ਗਿਆ ਹੈ। ਜਦੋਂ ਮੈਂ ਪਟਿਆਲੇ ਆਇਆ 69, ਪਟਿਆਲਾ ਦੇ ਵਿੱਚ ਬਠਿੰਡਾ, ਬੋਹਰ, ਇਹ ਸਾਰਾ ਏਰੀਆ ਬਹੁਤ ਆਉਂਦਾ ਸੀ, ਅਤੇ ਕੁਛ ਸਾਲਾਂ ਦੇ ਵਿੱਚ ਹੀ ਦੇਖਿਆ ਕਿ ਬਠਿੰਡਾ ਹੈ, ਹੁਣ ਕੁਛ 15-20 ਸਾਲਾਂ ਦੇ ਵਿੱਚ ਖਾਸ ਕਰ ਬਠਿੰਡਾ ਇੰਨਾ ਅੱਛਾ ਮੈਡੀਕਲ ਸੈਂਟਰ ਬਣ ਗਿਆ ਹੈ ਕਿ ਇੱਥੇ ਲੋਕ ਇੱਥੇ ਆਉਣਾ ਸ਼ੁਰੂ ਹੋ ਗਏ ਨੇ, ਇੱਥੇ ਰੁਕਣਾ ਸ਼ੁਰੂ ਹੋ ਗਏ ਨੇ। ਬੋਹਰ, ਬੀਕਾਨੇਰ ਵਗੈਰਾ ਦਾ ਏਰੀਆ, ਗੰਗਾਨਗਰ ਜਿਹੜਾ ਪਟਿਆਲੇ ਪਹੁੰਚਦਾ ਸੀ, ਉੱਥੇ ਪਹੁੰਚਣਾ ਔਖਾ ਹੋ ਗਿਆ। ਸੋ ਇਸ ਲੰਬੇ ਸਫ਼ਰ ਦੇ ਵਿੱਚ ਮੈਂ 1957 ਅੰਮ੍ਰਿਤਸਰ ਤੋਂ ਗ੍ਰੈਜੂਏਸ਼ਨ ਕੀਤੀ। ਇਸ ਲੰਬੇ ਸਫ਼ਰ ਦੇ ਵਿੱਚ ਮੈਂ ਅਬਜ਼ਰਵ ਕੀਤਾ, ਸਰਵ ਕੀਤਾ ਮੈਡੀਕਲ ਪ੍ਰੋਫੈਸ਼ਨ ਨੂੰ, ਅਤੇ ਕਿੰਨਾ ਚੇਂਜ ਹੋ ਗਿਆ ਸਾਰਾ ਕੁਛ ਹਰ ਥਾਂ ਦੇ ਉੱਤੇ। ਮੈਂ ਸੋਚਦਾ ਅੱਜ ਕੱਲ੍ਹ ਦੀ ਮੈਡੀਸਨ ਨਾਲ ਕੰਪੇਅਰ ਕਰਦਿਆਂ ਮੈਂ ਸੋਚਦਾ ਕਿ ਅਸੀਂ ਪੁਰਾਣੇ ਜ਼ਮਾਨੇ 'ਚ ਕੀ ਕਰਦੇ ਸੀ, ਕਿਸ ਤਰ੍ਹਾਂ ਮਰੀਜ਼ ਨੂੰ ਟੈਕਲ ਕਰਦੇ ਸੀ, ਕਿਸ ਤਰ੍ਹਾਂ ਇਲਾਜ ਕਰਦੇ ਸੀ, ਬੜਾ ਫਰਕ ਪੈ ਗਿਆ ਹੈ। ਪੈਟਰਨ ਵੀ ਬਿਮਾਰੀਆਂ ਦਾ ਚੇਂਜ ਹੋ ਗਿਆ। ਅੱਗੇ ਇਨਫੈਕਸ਼ਨਸ ਹੁੰਦੀਆਂ ਸਨ, ਮਲੇਰੀਆ, ਟਾਈਫਾਇਡ, ਵਾਰਡ ਦੇ ਵਿੱਚ ਕੋਈ ਥਾਂ ਨਹੀਂ, ਕੋਈ ਜਗ੍ਹਾ ਨਹੀਂ ਸੀ ਹੁੰਦੀ ਕਈ ਵਾਰੀ ਕਿ ਟਾਈਫਾਇਡ ਨਾਲ ਭਰਿਆ ਹੈ, ਟਾਈਫਾਇਡ ਦੀਆਂ ਕੰਪਲੀਕੇਸ਼ਨਸ ਨਾਲ ਭਰਿਆ ਹੈ। ਦੇਖਦਿਆਂ ਪੈਟਰਨ ਚੇਂਜ ਹੋ ਗਿਆ। ਮਲੇਰੀਆ ਕਿੰਨੇ ਕੁ, ਹੁਣ ਤੁਸੀਂ ਯਾਦ ਕਰੋ ਕਿੰਨੇ ਸਾਲ ਹੋ ਗਏ ਮਲੇਰੀਆ ਦਾ ਕੇਸ ਦੇਖਿਆ, ਇੰਨੀ ਪ੍ਰੋਮੀਨੈਂਟ ਬਿਮਾਰੀ ਸੀ। ਹੈਪੇਟਾਈਟਸ ਵਗੈਰਾ ਉਹ ਵੀ ਘਟ ਗਏ। ਰੋਮੈਟਿਕ ਹਾਰਟ ਡਿਜ਼ੀਜ਼ ਜਿੱਥੇ ਅੱਗੇ ਵਾਰਡਾਂ 'ਚ ਪਏ ਹੁੰਦੇ ਸੀ, ਉਹ ਵੀ ਘਟ ਗਏ, ਬੜੇ ਘੱਟ ਕੇਸਿਸ ਹੋ ਗਏ। ਸੋ ਸਾਰਾ ਕੁਛ ਇਸ ਤਰ੍ਹਾਂ ਬਦਲ ਗਿਆ ਉਹ ਕੁਛ ਸਾਲਾਂ ਦੇ ਵਿੱਚ। ਔਰ ਹੁਣ ਅੱਜ ਕੱਲ੍ਹ ਕੀ ਅਸੀਂ ਦੇਖ ਰਹੇ ਹਾਂ ਪੈਟਰਨ, ਆਬਾਦੀ ਵੱਧ ਗਈ, ਏਜ ਲੰਬੀ ਹੋ ਗਈ, ਔਰ ਅਸੀਂ ਅੱਜ ਕੱਲ੍ਹ ਦੇਖ ਰਹੇ ਹਾਂ ਏਜ ਰਿਲੇਟਿਡ ਬਿਮਾਰੀਆਂ, ਕਾਰਨਰੀ ਆ ਗਈ, ਸਟ੍ਰੋਕਸ ਆ ਗਈਆਂ, ਕੈਂਸਰਸ ਆ ਗਏ, ਇਹ ਸਾਰੀਆਂ ਨਵੀਆਂ ਚੀਜ਼ਾਂ ਆ ਗਈਆਂ। ਵਾਇਰੋਲੋਜੀ ਦਾ ਡਾਇਗਨੋਸਿਸ ਬੜਾ ਇੰਪਰੂਵ ਹੋ ਗਿਆ। ਅਸੀਂ ਹੁਣ ਉਹ ਵਾਇਰਸਿਸ ਦੇਖਦੇ ਹਾਂ ਜਿਹੜੀਆਂ ਅਸੀਂ ਪਹਿਲੇ ਕਦੀ ਸੁਣੀਆਂ ਨਹੀਂ ਸਨ, ਔਰ ਪੁਰਾਣੀਆਂ ਬਿਮਾਰੀਆਂ ਜਿਹੜੀਆਂ ਸਨ, ਉਹ ਡੇਂਗੂ ਵਗੈਰਾ ਆ ਗਏ। ਅੱਗੇ ਅੱਜ ਤੋਂ 40-50 ਸਾਲ ਪਹਿਲਾਂ ਕੋਈ ਕੇਸ ਇਹੋ ਜਿਹਾ ਸੁਣਦਾ ਹੀ ਨਹੀਂ ਸੀ, ਅਗਰ ਹੁੰਦਾ ਵੀ ਸੀ ਕੁਛ ਉਸ ਟਾਈਪ ਦਾ ਤੇ ਡਾਇਗਨੋਸਿਸ ਨਹੀਂ ਸੀ ਹੋ ਪਾਉਂਦਾ। ਸੋ ਇੰਨਾ ਚੇਂਜ ਹੋ ਗਿਆ ਪ੍ਰੋਫੈਸ਼ਨ, ਔਰ ਸਿਰਫ ਪੈਟਰਨ ਹੀ ਚੇਂਜ ਨਹੀਂ ਹੋਇਆ ਬਿਮਾਰੀਆਂ ਦਾ, ਇੰਨੀ ਐਡਵਾਂਸ ਕਰ ਗਈ ਹੈ ਮੈਡੀਸਨ ਕਿ ਹੁਣ ਸ਼ਾਇਦ ਅਸੀਂ ਕੁਛ ਸਾਲਾਂ 'ਚ ਬੰਦਾ ਹੀ ਨਵਾਂ ਬਣਾਉਣਾ ਸ਼ੁਰੂ ਕਰ ਦੇਈਏ, ਇਸ ਤਰ੍ਹਾਂ ਦੀ ਹਾਲਤ ਹੋ ਗਈ ਹੈ। ਟੈਕਨੋਲੋਜੀ ਇੰਨੀ ਚੇਂਜ ਹੋ ਗਈ ਹੈ ਕਿ ਲੰਗਸ ਰਿਪਲੇਸ ਹੋ ਰਹੇ, ਹਾਰਟ ਰਿਪਲੇਸ ਹੋ ਰਹੇ, ਸਾਰਾ ਕੁਛ ਇੰਨਾ ਚੇਂਜ ਹੋ ਗਿਆ ਹੈ। ਔਰ ਇੰਨਾ ਚੇਂਜ ਦੇ ਨਾਲ हॉस्पिटल किन्ने बन गए, मेडिकल प्रोफैशन महंगा भी बड़ा हो गया है। और रोज़ सुनते हैं कि गवर्नमेंट्स सपोर्ट करनगियां प्रोफैशन नूं। मोदी साहब सेंट्रल गवर्नमेंट कहते जी असी 5 लाख तक फ्री ट्रीटमेंट देंगे, पंजाब वाले कहते असी 10 लाख तक फ्री ट्रीटमेंट देंगे। होपफुली कामयाब होने अपने मकसद दे विच। और मैडिकल एड जड़ा लिमिट नहीं होना चाहिए सोसाइटी दे हेठां तक पहुँचता रहे। सो जिथे इन्ना कुछ एडवांस हो गया है, अर्बनाइजेशन दे नाल सानू बड़ा फर्क पै गया है। जिन्ना इंफ्रास्ट्रक्चर चेंज हो गया है उन्ने ही प्रॉब्लम आ गए। अर्बनाइजेशन दे नाल डायबिटीज़ आ गई, ओबेसिटी आ गई, हार्ट डिजीज़ आ गई। तो रूरल एरिया चो शिफ्ट करन दे नाल और ज्यों ज्यों अर्बनाइजेशन होंदी है स्ट्रक्चर बनता है, ट्रामा चेंज हो गया, हुण ट्रामा बड़ा हो गया। ये सारिया चीज़ां पैटर्न चेंज हो गए मेडिकल वर्किंग दे। सो कम अजे भी बड़ा है, पर स्पैशलिस्ट हो गए। और बड़े सारे जनरल फिजिशियन ये सोचते हैं कि साडा आने वाले दिनों की हाल होएगा। आई थिंक कोई अंधेरे वाली गल नहीं है कि जनरल फिजिशियंस की ज़रूरत रहेगी। फैमिली फिजिशियंस, फैमिली डॉक्टर्स का प्रोफैशन रहेगा। तो डॉक्टर्स जोड़े इंटर्निस्ट ने उन्होंने स्पैशलिस्ट के बावजूद मेरा ख्याल है जगह काफ़ी है। और आने वाले ज़माने शायद देल बी द सेंट्रल फिगर्स के पेशेंट सीधे कंसल्ट सुपर को नहीं जाएंगे, सुपर कंसल्टेंट्स को। वो सारे एक फिजिशियन जरा बेसिक लेवल के उत्ते हर एक चीज़ को देख सके, उस वास्ते फ्यूचर ब्लीक नहीं होएगा, इम्प्रूव करेगा। सो इन वर्ड्स नाल मैं ऑर्गेनाइजर्स की दोबारा थैंक्स करदा कि इन्होंने मैनू इन्नी वड्डी ऑनर दिती है कि मैं सैकेंड टाइम इन्हों की ऑर्गेनाइजेशन दे पाया। थैंक यू, थैंक यू।
Thank you, sir. Sir, it is really great honor to have you here. ये साडा मतलब मान वधिया है जी थोड़े आउण नाल। सो सर ने गल कीती, मैं दूजे पासे कहना है, मैं कहा ये जिहड़ी मैंटैलिटी है ना वो भी चेंज होगी। जदों असी स्टूडेंट सीगे, जदों सर वर्गे टीचर चाह पी के कॉफ़ी क्लब हुंदा सीगा, जिन्हों कप दिंदे सी धोण वास्ते, वो शाम नूं पार्टी करदा सीगा कि जी मैं फेवरेट स्टूडेंट हैं अपने प्रोफैसर का, जिन्हों ने मेरे कन्नी कप किया, थोनू नहीं दिता यार। ये वो पार्टी करता सीगा। अजकल के जमाने जे कोई टीचर कप दे दिंदा, अगले दिन वो शिकायत हो जाती है कि साडे बच्चे तो जी जूठे भांडे धोआंदे आ। जिमें NSS का सीगा, पहले स्कूल ग्राउंड है जोड़े बच्चे साफ करते सी। अब पिछले महीने मैं पढ़िया अपने गवर्नमेंट स्कूल च बच्चों को कहता भी तो कुर्सियाँ ला लियाओ, तो पेरेंट्स ने शिकायत करती कि जी लेबर कराते हैं। सो जिथे तक ये चीज़ है ना, मैंटैलिटी भी चेंज होगी। तो उवें प्रोफैसर का भी जोड़ा हैगा वो वतीरा है, जोड़ा पहला बच्चों वांगू समझते सीगे, हुण वो भी थोड़ा जिहा चेंज हो गया। मेरे ख्याल इस करके थोड़ी जी डिफरेंस आ रही है। सो आई वेलकम डॉक्टर राजेश जिंदल टू ग्रेस आर ओकेजन एंड डॉक्टर शीबा फ्रॉम लुधियाना DMC. She has come to deliver the lecture. I am really grateful to you both to have come to encourage us basically. So now we will end formally our inaugural session, and on time we are going to initiate the next lecture by our chief guest Dr. Atul Sachdeva, approach to a patient with dyspepsia. Dyspepsia is a great nuisance condition which almost 100% of the peoples experience one or sometime in lifetime. So to discuss this important topic, I request Dr. Atul to please come on stage.
Bye, Ji. Thank you. Thank you.
I guess we thank you, Vitul, once again. So I'll keep my talk very simple because I know it's a multi-speciality kind of gathering. People have different interests. So I'll just limit to what exactly is dyspepsia, be very brief, and of course to the point, try and be to the point. So basically dyspepsia, if you look at it, it refers to bothersome upper abdominal symptoms which are originating from the gastroduodenal area. Bothersome means that they are severe enough to have an impact on daily activities. So predominant symptoms we feel, we often come across पेट फूल गया, गैस बन गई, पेट खाते ही पेट फूल जाता है, I don't feel like eating, थोड़ी burning हो जाती है, थोड़ी जलन हो जाती है. So that's all dyspepsia. And I'm sure, lot of physicians, even gynecologists or other specialities, they come across patients who just complain of these symptoms. Now there's been a change. What I just want to apprise you that dyspepsia was called functional dyspepsia for a long time. Functional made it was very stigmatizing. Functional means that there is something wrong with mental problem or it's a psychological issue. So there was a stigma attached with that. And then the data was coming from West, so people were just talking about West. So they said, okay, this is not the right term. So now the term for these kind of disorders is called disorders of gut-brain interaction. Basically, that's the new term which is there. And it's now very clear that it's just not only mental issues which are affecting, you find patients coming to you with irritable bowel, but it's not only just functional. There is now evidence to suggest that there are changes which happen in the gut. There is a motility disturbance. Some people's gut is very sensitive, so it sends more signals to the brain. There is altered mucosal function. There is altered immune function. There's a change in gut bacteria. Now gut bacteria, intestinal microbiota or microbiome as we call it, is now undergoing a lot of research, and a lot of things are related to this. Mrs. Sidhu talked about obesity. Now there's enough data to show that there are gut microbiota which determine our weight. So I'll not go into details, but that gut microbiota is now also shown to cause this kind of bloating, this kind of symptoms. So that is why this actually sends signals to the brain. So that's why these disorders are now called as disorders of gut-brain interaction. Now functional dyspepsia, still the term is functional dyspepsia because it is stuck there. Hopefully it will also change. The nomenclature is yet the same. Now dyspepsia, like I said, it's upper gut symptoms, but there's a lot of overlap with other gut symptoms. So there is an overlap with anorexia, eating disorders, binge eating, bulimia, and so on. And there's also there is also an overlap with irritable bowel syndrome. Now irritable bowel syndrome is also a disorder of gut-brain interaction, and there's an overlap. 26% of patients with functional dyspepsia, they have an irritable bowel syndrome. There are about 9% of people, they have reflux, and then they have other symptoms, other syndromes also. So it doesn't occur in isolation. Dyspepsia doesn't occur in isolation. There is an overlap with other conditions. So upper GI symptoms plus you have problems with motions, or you have diarrhea or constipation. So for calling it dyspepsia, you have to have certain symptoms. Like I said, the 4 symptoms, they should be there for at least one day or 3 days, depends on what the symptom is, per week for 3 months, and the onset should have been about 6 months earlier. And the other thing is that there should be no evidence of any structural disease. So that these are the criteria. These are now called the Rome 4 criteria, which have been used for the past, almost 10 years. Rome 4, the Rome determines the criteria. There was conferences which are held there. So this is the 4th conference in 2016, which had a consensus, and they gave this terminologies, criteria for making these diagnoses. Now, when you have a patient who comes to us with these upper GI symptoms, our idea is to see, is there any structural defect, or is all just functional? Functional means gut interaction abnormalities. So organic is important. Organic happens in about 20%, 80% is just functional. So that's the important thing we must understand. But it's those 20% of people, they need to be looked at, because they will have an organic reason for causing this, and you need to address this. What is the global prevalence? You see, this is the figure which shows that widely prevalent all over. Asia, we have about 7-8%, but rough figure is about 10 to 15% of world's population complains of upper GI symptoms of dyspepsia. This is just another chart, although a little old, but shows that look at the prevalences. Basically the red areas, they have very high incidence of prevalence. India is intermittent, in between, or 20% of people, they get this dyspepsia. Now there was a physician survey also a few years back. There was a physician survey where they asked physicians, okay, tell us how many patients who just come to you on an average for dyspepsia. 20 to 30% of patients of any physician, they have this complaints. Gas hi nahi jati, pet bhara, khata hu, kam khata hu. It happens. But it's good for people like, well, on a lighter note, it's good for people like gastroenterologists like me. Basically, it gives us our bread, and it also gives our butter. Basically, you end up investigating, and of course, they keep coming back. So 10 to 30% patients are diagnosed on a daily basis. So it's a very, very common problem, and this gas affects the life. I'm sure everybody's family members have gone through these phases, and it affects the quality of life to such an extent that they are not able to work properly. So there it leads to absenteeism. It leads to problems, economic problems, health aspects are there. Frequent visits to the physicians are there. So they are spending a lot of money there. So the quality of life is definitely affected. So one has to be aware of all these aspects. Interestingly, there's another study which was done in DMC, where they looked at students, MBBS students, the nursing students, and students who were, the paramedics, etc., or another college student they looked at. And they found that dyspepsia, functional dyspepsia, is more common in females, and females who are in the medical course, not in the nursing or non-medical courses. So it's the stress also. That's the other aspect to it. And then they have, of course, they also could correlate with consumption of non-vegetarian / junk food. And we know the effects of these things: excess of tea and coffee, and of course anxiety. That is there. Now functional dyspepsia has two major groups. One, of course, is the epigastric pain syndrome. The other is the postprandial distress syndrome, which is mentioned on the other side. So epigastric pain, on eating, they're all related to meal. On eating, you have burning or pain. 1 day a week or 3 days a week, starting 3 months before presentation, and of course the symptoms have been there for 6 months. So that's, you call it as epigastric pain syndrome. The other is, patients say, I feel bloaty after eating and I don't want to eat. Early satiety, that means he's not able to finish a normal meal. That's postprandial distress syndrome. So the two, you need to just differentiate between these two, because you start with different therapies. If a person says epigastric pain, then the better drug is an acid suppressive agent. Otherwise, if you just say bloating after meals, then it's better to start a prokinetic. And then there are certain patients who have an overlap. that is there. So that's the classification that we have. Now, you also see that this is just a picture which shows that the prevalences of various of both these disorders. You find that there is more prevalence in females, like as per the study which was from DMC, more in females, and it's the young people who have more dyspepsia. As the age increases, the incidence, the prevalence of dyspepsia decreases. Now, what is the pathophysiology? I just alluded to this, that it's not just functional. There are lots of factors which are important. There's a motility problem. There is, the stomach is not contracting very well. It's not able to accommodate food very well. So since it doesn't expand very well, so it sends signals to the brain. There is a subclinical inflammation which is happening there. So there are problems. All these are very well documented. So it's just not only functional, and they are sending signals to the brain. So to the extent that there are duodenal, one has looked at duodenum, and there is a abnormal intestinal permeability. You have more toxins going through. There is infiltration by eosinophils. Mast cells are there. There is an abnormal acid exposure, and of course there is presence of Helicobacter pylori. So it's not functional alone. So there are actually reasons for these symptoms. It's not that they are life-threatening things, but there are reasons for this. And I talked about the bacteria, which are very important. So people have now started looking at the gut bacteria, and we have found that there are different types of bacteria which change. There's more harmful bacteria which come, and they lead to more gas production, more symptoms, more inflammation, more sensitivity changes. So that leads to these kind of symptoms. So but the data is not very clear which bacteria or what bacteria or what species will cause this, but there is a change. That's called as bacterial dysbiosis. I will not go too much into detail of this. Now a person comes to us with dyspepsia, and we need to just rule out the organic causes. Very important to take a good history, talk to the patient, and do a good examination. One must rule out the systemic causes like cardiac causes which are there. Sometimes we find a lot of patients who are in actually congestive heart failure, and they have bloating because their liver is enlarged, so they don't feel hungry. After a meal, they have bloating. So one must please rule out congestive heart failure. Look at diseases like diabetes, thyroid, because they do affect gut health. Look at diseases which have a calcium abnormality like hypercalcemia, can also present as dyspepsia. SIBO, bacterial overgrowth, giardiasis, medications. Please do also look at the history of drugs that the patient is taking. Rule out chronic pancreatitis. Look at fatty liver, although fatty liver doesn't cause dyspepsia. Gallstones don't cause dyspepsia. Please understand that if a patient comes to you with dyspepsia but no biliary colic, do not recommend cholecystectomy to these patients, because these symptoms will not improve. They go ahead, you do a cholecystectomy, but the patient comes back to you and says, you told me to get cholecystectomy done, but my symptoms are the same. The symptoms, gallstones don't cause dyspepsia, typically. They will cause pain, and once the pain occurs, then you go ahead with surgery. But do not recommend cholecystectomy for incidental detection of gallstones, number one, or for dyspepsia. So these are the things that one needs to look at. One more important aspect is milk. There is a lot of lactose intolerance. So a lot of people have this bloating because of consumption of lactose. Now you have lactose-free milk, you have almond milks, you have other milks which you can take. So one must rule these out and also go through the list of medications. Common ones are acarbose, which of course is used as an anti-diabetic. It really causes a lot of bloating. Bisphosphonates, given we all know by the orthopedic surgeons, corticosteroids, herbs, iron causes a lot of dyspepsia, and metformin, another anti-diabetic agent which causes this. Anti-diabetics cause a lot of these issues, and non-steroidal anti-inflammatories, opioids, these are things which one must look at. Bronchodilators like theophylline. So these are the drugs which we must exclude before, we say this is all functional. Then look at the alarm signs. If a person has weight loss, dysphagia, odynophagia, iron deficiency anemia, persistent vomitings, GI bleeding, or a palpable mass or lymphadenopathy, they should be investigated. These are all alarm signs. So one must always investigate if you find these signs. So go ahead with basic tests. Rule out gluten sensitivity in these patients. At least do a IgA anti-TTG. And what is recommended is when you have symptoms, at least do a basic ultrasound and an endoscopy should be done. Just rule out these symptoms. The other, advice is that when first time a person who is above 40, 45, he comes to you for the first time with dyspeptic symptoms, please do an upper GI endoscopy, because lots of times they have a small malignancy and they don't feel like eating, they have early satiety. You must rule out an upper GI endoscopy, especially if a person starts for the first time above 40 years of age. There are other techniques now to assess this, like we have, drinking ultrasound. You drink water and do an ultrasound, dynamic ultrasound, do an MRI. You have scintigraphies, etc. These are very important techniques, but still research techniques. But they will tell us what is the exact physiology, what is the pathophysiology. So one can determine that and then tailor the therapy. That's the advantage of this. But this will come up in the near future, and hopefully we will do a better job as far as managing our patients is concerned. So there are, on the left you have the symptoms, and as you move towards the right, please look at the other aspects also. Whenever you have a patient of dyspepsia, look at the psychological profile. Very important. Please also investigate for H. pylori. Helicobacter pylori is extremely, extremely important. Keep in mind that it could all be dysbiosis, or rarely you may have some eosinophilic infiltration or mast cell infiltration. So these are the things, but a person not improving, please do look at their psychological profile. That's very important, and rule out H. pylori. So that's the treatment options that we have for dyspepsia. Dominantly based on symptom relief, because they keep coming back. First thing, you must address the symptom. Rule out organic causes, rule out alarm signs. A person has dyspepsia, okay, look at the dominant symptom and treat that. If you have more of epigastric pain, if you have more of epigastric burning, give them a proton pump inhibitor or or antacid or H2 antagonist or vonoprazan, whatever you have. If there's bloating, satiety, give them a prokinetic. And you have a list of prokinetics. You can pick up any prokinetic, basically. It's just your personal choice. And if you don't improve, then of course look at the psychological profile. Give them anxiolytics, give them antidepressants, SSRIs or SNRIs. Those are important, and also encourage them to go ahead or indulge in pleasurable activities. Maybe do yoga, play games, or do some kind of a hypnotherapy. Sorry, I think can I? I think it's stuck. I think this needs to change here. No, okay. Thank you. So I'll just briefly talk about H. pylori and dyspepsia. Now, do you need to do an endoscopy for all patients to check for H. pylori? Well, the Europeans do it, but we have such a high prevalence of H. pylori that you just don't, treat just like that, right? You can do it. There's nothing wrong with it, but then drugs also have side effects. So a lot of patients are not able to tolerate that. So that's what I advise, is that if you have, you get an endoscopy done, or if you find the patient is not improving, then do check for H. pylori. And then if you find it is positive, then treat it. Europeans are in a routine, they do it because the prevalence of H. pylori there is much less. It's more in the developing world that we have a very high incidence of H. pylori. So if you can, nothing wrong with that, look for it and treat it. What about probiotics? I talked about dysbiosis. So probiotics help, but They help by eliminating bacteria, reducing inflammation, reducing visceral sensitivity, improving motility. But do we have data on probiotics? Yes, there are some probiotics which help. Lactobacilli genus, and various species of lactobacilli, Rhamnosus, Paracasia, Reuteri, etc., or even a friendly fungus, Saccharomyces boulardii, those are supposed to be helpful. But no clear-cut, indication, but they are supposed to be helpful. There's enough data to show that you can try these drugs and there's improvement in symptoms. So that's basically, another interesting study was there's dyspepsia with anxiety. So people had anxiety and they give probiotics to people and their anxiety also improved. So probiotics are helpful, but we really don't know which probiotic is really important. What about diet? It's very individual. You tell these patients to go off milk and also look at gluten. A lot of patients feel better without gluten. So that's not celiac disease, it's called non-celiac gluten sensitivity. And tell them to avoid fat, spicy foods, avoid soft drinks. You can try low FODMAP diet. It does make a difference. The list is there, and once, of course, you can try that. Very interesting Iranian study I came across, and there are certain foods or fruits which cause worsening. And typically, we think, watermelon, because it causes a lot of symptoms. Watermelon, melon, kheera, grapes, cherries. So and apples, both ways. Apple also causes more of dyspepsia. Sometimes it helps. So basically, you have to just tailor your therapy. Tell the patient whatever they feel uncomfortable with, they should avoid. What about dietary patterns? You can't just pick up one food. You look at the dietary patterns. So what has been seen that if you give them protein-rich DASH diet, the dietary interventions for control of hypertension, low salt, and other things, unsaturated fat-rich diet, they also increase symptoms in PDS. Mediterranean diet, like they say, which is rich in fibers, mono-polyunsaturated fats, antioxidants, they reduce symptoms. What about vegetarian diet? We don't have enough data to show that being vegetarian reduces functional dyspepsia. So not much of data. So ladies and gentlemen, I'll just end my talk by saying that a person comes to us with chronic dyspeptic symptoms. Take a good history, do a good examination, look at the alarm symptoms, and if you have no alarm symptoms, you can investigate for H. pylori. If you find H. pylori, treat it and document that it has been treated, and that documentation is 30 days after completion of treatment. Document it. If it's negative, if the patient improves, good. If the patient doesn't improve, well, of course, then treat him like functional dyspepsia. If you have, the other aspect is, if you have alarm symptoms, please do investigate and come to a probable diagnosis. Of course, one can, just tailor therapy. If dominantly acid-like symptoms, give PPI. If it's more bloating, give prokinetics or a combination of two, and look at their abnormal psychological profile and add an antidepressant or an anxiolytic. Thank you very much. Thank you.
Thank you, Dr. Atul.
Thank you.
To discuss such an important topic, 2 points I think you are very right, that when there are gallbladder stones, the surgeon does not explain to the patient that you will be relieved of your dyspepsia with operation or not. So most of the times they say कि यार तू operation करा ला ठीक हो जाऊगा, and patient goes on for 20 years के जी operation कराया सी ठीक था होया नहीं मैं. So this is a great learning that whenever you suggest that these are two different diseases, one will not go with other disease. Second, I think most of the Indian patients have a psychological onset also. कि डॉक्टर साहब गैस चढ़ गई जी दिमाग नूं, मेरा आ हो गया जी, वो गैस जिहड़ी वो गोड्यां चली जाती है, गिट्टियां चली जाती है. So it goes round and round in whole of the body, and patient think it is gas because of this thing, I have headache, I have this thing. So it really needs both psychological at psychiatric level as well as physician's level to treat dyspepsia.
Exactly.
So any comments from our learned
Thank you.
audience?
Thank you for bringing those aspects.
Yes.
Thank you.
Manometry.
No, see, reflux is associated with lot of these. I showed you the data. About 8 to 10% of people of functional dyspepsia will have reflux, right? So you can just do depends. Reflux management is totally different. So either if it happens to be a young person, you give them therapy for some time. If they're not improving, or the person says I can't well take PPIs or for a long time. So that's somewhere you say, okay, he's not improving, we need to be more sure. Then there is a role of esophageal manometry. Manometry is dominantly for a esophageal motility disorder. So you're looking for that. And there you need to suspect a motility disorder. Now motility disorder typically comes with, the patients will have, if I may, I have time, I guess I can just explain that. So basically if a person comes to us with, say, chest pain, along with that there is dysphagia to both solids and liquids, intermittent symptoms, it's not daily, long-standing symptoms, then you suspect, okay, this could be a motility disorder. It's not a reflux, it's chest pain like this, like a cardiac chest pain, and they have dysphagia both to solids, liquids, intermittent. It's not daily. Once a month or once in 2 weeks they'll have that, or they'll feel bloaty like that. So that's esophageal motility. There you do a manometry.
So any other question? संगियो ना यार किसे दे आपके गैस गूस बांधी होवे तां भी पुछो.
Yeah.
Thank you for such a nice
Thank you.
presentation.
Thank you.
I wanted, gut microbiota are something which we are vouching on that, It's the gut microbiota, we're saying it causes your anxiety levels, it causes something in the brain, it causes in the gut, it causes obesity, it causes even, hypertension and all. Are we able to choose, like there are many ads, they are giving you this probiotic, this is good, this is, can we choose out of the lactobacilli or, which ones are really good and will it be different for different people or, can we really choose, okay, this is a good gut bacteria, we should continue taking it?
Yeah, excellent question actually. And I'm sorry I can't give you an answer totally, basically, because data is lacking on it. We have certain molecules which have shown improvement in certain disorders like IBD. The trade name, I can take it. VSL3 was supposed to, there was data which was there with VSL3. And that has shown to be beneficial in ulcerative colitis. So that is one study. There are other studies which have shown, but dominantly they are around lactobacilli. Different species have had different benefits. Like I said, rhamnosus, gassii, reuteri, these are, the species, lactobacillus, this species, they are supposed to be better. And, the other thing, of course, is we really don't really know which bacteria is very important. I think we don't have that so-called super bacteria. We know the super bugs, but we really don't know what is good. But I think you can just start with fermented foods. Somehow fermented foods, they change the bacteria. So that's I think I advise my patients to switch to yogurt, to dahi. I find it very convenient basically. That's one super good probiotic which you can advise to patients and see what the effect is. But so beyond that, if you say one preparation, I can't. So Saccharomyces boulardii is a good thing which really helps in certain situations. Good molecule. It's been shown to reduce diarrhea and change the gut microbiota. So another good molecule there.
So this is very good question because there are a lot of these probiotics coming up in the market, big advertisement in newspapers also. But like Dr. Atul has said, I was attending a conference, a very learned person told the audience rather, ਕਿ ਤੁਸੀਂ ਅੱਧੀ ਕੌਲੀ ਜਾਂ ਇੱਕ ਕੌਲੀ ਦਹੀਂ ਦੀ ਖਾ ਲਓ ਨਾ, ਤੇ it is good. So basically you should replace, like the Hippocrates said, you are what you eat. So basically if we go for the dietary modifications to enrich our gut microbiota, that will be the best option, rather than prescribing 20 rupees capsule thrice a day, which cost more than the basic drug. So that is why most of the studies which are with gut microbiota and probiotics are sponsored by the pharma. So there is a great question mark also whether these studies we should follow or not. As far as textbook concerns, I think no textbook is recommending any probiotic to be given except for a good dietary consultation.
Yeah, that's true. That's true. I think we really don't understand our gut bacteria. And if you look at the gut bacteria, the level is 10 raised to the power 12 in colon per ml. And the basic two gena are, Firmicutes and Bifidobacteria. So really don't know much.
It is the largest body organ as far as we consider.
But I think time is not far. You will have those you have the FMT already happening. Fecal microbiota transplantation is already happening.
Yes.
And it's accepted in certain indications.
Yes, definitely.
And so it's happening. I think data is emerging. It's good for some diseases. Ulcerative colitis, great data for FMT. Thank you.
Yeah, so much of weight of microbiota we continue in our body. They say it's around 1 to 5 kgs as such also. And I think it was the observation, like you said, the diet. Diet is very, very important, and we have a changed diet now. So I think in older people, they had observed, they were doing everything right, the intermittent fasting they used to recommend, and so that people would follow them. That's why they had combined it with the religion. You do this, it will happen this. So that was the easiest way, the psychology of the person. You take a fast, you will be better off, God will give you something more. So I think even for the gut microbiota, we went to Rajgir, they said the locals here who were from the tribals, what do they do is whatever is rice they have left, they put some water in this, and the next day they eat the same old rice because it produces microorganisms in that. And I remember, like Dr. Saidar, my own dad-in-law, he used to tell his patients that the khatta atta jada ho janda, when you make that, we throw that, but this is even better. You should eat that. I think those were the old observations. The old drinks, the kanji, you keep it gets fermented. So which we actually left, considering that they were kind of old and our Coca-Colas were good, but they were really good foods, and and these were all, I don't think so, we do not know the good bacteria, probably they also did not know, but it was the good observations through which they were working and following the same from one generation to another.
Yeah, I think very correct, very absolutely correct.
Thank you very much. I mean, though this is none of my fields, but this has invoked so much of interest. My brother, he's an ophthalmologist, actually a retinal surgeon. He's in L.B. Prasad Eye Institute. And the recent work that he's been doing with WHO, which I'm aware of, is on the gut microbiome and diabetic retinopathy. And they're actually working on which bacterias, and they're actually having a large data set in which they're comparing the patients, the healthy volunteers versus the diabetic retinopathy. So I think we used to read about the cardiovascular and the gut, but this was really very interesting because they are expecting good preliminary results also.
Yeah, thank you. It's happening all over, I think, everywhere. I think we are focusing there. The second hit, so-called, through that. Thank you.
It is being implicated, gut microbiota, almost all the systems of the body being influenced by the gut. So the medicine is going to start in future from the gut and going to go in whole of the body, like vitamin D3 is now being implicated. So thank you, Dr. Atul.
Thank you.
For a good talk and interaction, good interaction on your talk. Thank you very much.
Thank you. Thank you.
With this next speaker, I invite our learned, good, enthusiastic, spirited doctor, promotion of women's empowerment, especially in medicine, Vinkar, Dr. Shiba Thakkar Chabra. She is going to talk to us seeing the unseen imaging for women CVD prevention. So thank you, Dr. Shiba, for gracing the occasion, and prestige of MAPICON increases with your presence. Thank you.
A very good afternoon. Thank you so much, sir, for your kind words. But I always have wondered that if I have half the enthusiasm that you have, then it makes my day. Thank you, Dr. Vitul, sir, and to the organizers of MAPICON for having me here and talking on a talk which is very dear to my heart and concerns about a woman's cardiovascular health. So cardiovascular disease in women is really very important because there's a lot of disparity in care. The average lifetime risk of developing cardiovascular disease in around a 50 years old woman is 40%, and it increases with more and more risk factors that a woman has. It is actually an undertreated and an under-recognized problem because of the disparities which occur. There are disparities in how we are testing our women, how we are treating our women, and of course the outcomes that they have. So when we talk of men and women, and we look at the risk factors that we have, and we talk of prevention, prevention can be primary prevention or it can be secondary prevention. In primary prevention, of course, we are aware of some risk factors which men as well as women have: age, sex, diabetes, hypertension, and so on. And then there are some risk factors which we look, which are cardiovascular risk factors, which are more predictive of worse outcomes in women. So they are smoking, diabetes, and psychosocial factors. If a woman is a diabetic, she has risk factors which are multifold in her to develop cardiovascular disease. If a woman is smoking, again, she's multifold at risk of developing a cardiac problem. If she has psychosocial problems, again, her risk increases. And besides these risk factors which are more predictive of worse outcomes in women, there are some risk factors which occur just in women. And those risk factors, we all are aware, could be some contraception use, hypertension, gestational diabetes, eclampsia, preeclampsia, pregnancy-induced hypertension, and so on. So women are entirely different. They have got some female-specific cardiovascular risk factors, like pregnancy-related risk factors, which we just now talked, which we hardly bother. A woman gets pregnant, she has hypertension, and then she forgets about it, rearing babies after around when she has an early onset of a cardiovascular event. So pregnancy-induced hypertension, eclampsia, preeclampsia, maternoplacental syndromes, stillbirths, abortions, everything contributes to cardiovascular risk in a woman. Then there are some female predominant cardiovascular risk factors, and those female predominant cardiovascular risk factors are autoimmune diseases like SLE, rheumatoid arthritis, scleroderma, breast cancer associated with chemotherapy, and so many other things. And then these were the risk factors. There are some conditions which are female-specific cardiovascular conditions which occur just in women, like we know is peripartum cardiomyopathy, and then female predominant cardiovascular conditions like Takotsubo cardiomyopathy, myocardial infarction with normal coronary arteries, endothelial dysfunction, microvascular dysfunction, SCAD, and so on. So with this understanding, we proceed further and realize that women may have less obstructive coronary artery disease, and even with this less obstructive coronary artery disease, they have much higher cardiac mortality. So why could that be? That could be because of some differences which are there in their coronary arteries, which are smaller, which have abnormal coronary reactivity, or the ones which produce more of superficial plaque erosions. They have more microvascular dysfunction, more distal embolization, and of course, we cannot forget the hormonal changes, increased arterial stiffness, which comes with the menopause. So this is how it is. If we look at the coronary artery of a woman and a man, the coronary artery in a woman would be smaller, and it would be, subtending a smaller area of myocardium as compared to that in a man, when it is going to subtend a larger area of myocardium. So with the same account of lesion that a woman would have, she would have a higher FFR. That means that her fractional flow reserve would be higher across a coronary artery as compared to man. We understand that when FFR is high, that woman may not need revascularization. So with same degree of occlusion and similar coronary artery, the way a man and a woman would behave would be different, with higher FFRs which are recorded in women. Now let us look at plaque erosions. Women have high incidence of plaque erosions, less of plaque ruptures, which we know are associated with acute coronary syndromes. The plaques in women are different, less calcified, less obstructive, a diffusely diseased coronary artery, and outward remodeling which occurs. Microvascular dysfunction, more common. Higher coronary blood flow reserve, flow at rest, and coronary flow reserves are lower. So when all this is different, ladies and gentlemen, don't we think that women would need a different kind of imaging also? Probably yes. So women also have worse outcomes. If a woman infarcts, her outcome would be worse than a man. Why? More comorbid factors, elderly age, more bias, biological responses different to antiplatelets. She would be attended by a physician late. She would have atypical symptoms. When attended, she would probably get less thrombolytics. She would get less angioplasties, less aggressive management, and inferior secondary prevention. So primary prevention as well as secondary prevention as well as rehabilitation has been proven by enough evidence to be different in women who are getting less utilization of cardiac resources. Their first medical contact to device time is different. They are referred less for revascularization. They get less rehabilitation and of course less evidence-based treatment. So having said that, the prevention is undermined whether it is primary or secondary. Also the risk assessment tools. We have the similar risk assessment. So the risk factors are different, but the risk assessment tools are same for men and women. So if we look at these risk assessment tools which are traditional, they undermine women, whether it is pooled cohort equation or whether it is Reynolds risk score or the score 2, they all underestimate the risk in any given woman, arising the need for probably more preventive tools in women, which could be an efficient imaging. So if we talk of imaging in women, what comes to our mind for prevention, for primary prevention? Somebody would say coronary artery calcium. You're right, that is how we start. So let us see how guidelines place it. Coronary artery calcium has been placed somewhere in the ACC guidelines for guiding the therapy. A CAC score, you have a woman, you suspect risk, send her to get her coronary calcium score without giving her the dye for CT angio. A coronary calcium score of 0 says very low risk for the next 5 years, and we can probably defer any statin or preventive therapy in this woman. A statin is recommended in a woman for primary prevention if she is having a non-zero calcium score, a non-zero CAC. If her recommended score is more than 100 or more than 75 percentile for age and sex, of course it's recommended to treat her with statins. Intensive therapy with statins is recommended if CAC score is more than 300, and aspirin in women for primary prevention may be considered once you have a coronary calcium score of more than 100. So it's a critical tool for assessing women. And how is it in comparison to men? Are men also to be treated in the same way? Let's see. So if we have at any given age, women would have a lower prevalence of calcium which is present in their coronary arteries, and they would have lower scores. A woman's score would often be comparable to a man who is 10 years younger than her. However, whenever coronary artery calcium is present, more than 0 in a woman, this predicts a much higher adverse event of coronary event in a woman as compared to man. So a lower burden of calcium, however, a greater risk in women. So this is how this cartoon describes. A woman would have a smaller vessel, lower plaque volume, less necrotic core, lower calcification, a lower calcium score. However,
With this presence of lower calcium score, she would be placed with almost an equivalent or more adverse risk than a man and would probably have ischemia without the presence of obstruction in her coronary arteries. So no obstruction, however, would mean adverse coronary events. So we talked of coronary artery calcium and now CT coronary angiography for primary prevention minded. We are talking of a woman who is not symptomatic and we are assessing her for primary prevention. So there was a trial called as a PROMISE trial which was conducted, and it was found that women who have abnormal CT coronary angiography had higher rates of major adverse cardiac events as compared to any woman who would have an abnormal stress echo or an abnormal TMT, suggesting that probably CT coronary angiography has a better prognostic value. So they did this trial and then they followed it up further also for 5 years, and it was found that when compared, and when we were just giving a standard care and using traditional risk scores and treating our women, vis-a-vis when we were using CT coronary angio for primary prevention and treating them with statins, it was found that women who were treated with standard care plus coronary CT coronary angiography, the death from coronary artery disease, the primary endpoint, was much lower in the women who had CT coronary angio based treatment. So coronary CT angiography in women detects more of non-obstructive coronary artery disease, predicts a higher risk with a hazard ratio of maybe 1.36 for mortality for women who are not detected with coronary artery disease. And CT coronary angio not just looks at the lesion, it also defines the high-risk lesions in women which can be identified on the basis of outward modeling, some napkin ring lesion appearances which are picked up in the CT coronary angiogram. So we talked of coronary artery calcium, we talked of CT coronary angiography. Now the next thing which we usually do, we do and look at the carotid intermedial medial thickness and the plaques. So plaques are known to prove more of association with the atherosclerotic burden in women, and their presence is more predictive of cardiovascular events in future as compared to carotid intermedial thickness. However, the new thing which is emerging in this era is not just to go and look at the intermedial medial thickness of the carotid artery, but to look at the progression which is occurring in this IMT. So it is found that if the IMT progression is higher with coming times, that could be a predictor of coronary events. Now talking of something which we cannot escape when we talk of imaging in women, and that is INOCA. What is INOCA? We know that INOCA is presence of myocardial ischemia without any significant epicardial coronary artery disease. So INOCA is of several endotypes, but the first one and the commonest one which occurs in most of the women whom we are labeling at present as functional and psychiatric disorders, that is probably coronary microvascular dysfunction which they have. A woman comes to us, we do a treadmill test, the TMT is positive, she goes for an angiogram is normal, everyone in the family tells her you are, some psycho, you are stressed out or whatever. However, that doesn't end because coronary microvascular dysfunction is a very important emerging diagnosis where treatment can act. So traditional risk scores and traditional thoughts are undermining what is ischemia with non-obstructive coronary artery disease. This is what we think coronary artery disease is, right? This red cartoon, obstructive coronary artery disease, lesions in angiogram. However, CAD is much more beyond. CAD is also diffuse, non-obstructive, maybe 20 to 30 degree plaque. CAD is also coronary microvascular disease. CAD is also epicardial spasm and coronary artery diseases, ischemia, a documented ischemia, maybe on a treadmill test, maybe on any other functional test with a non-obstructive presence in an angiogram. So these are the types of INOCA, these are the types of ischemia with non-obstructive coronary artery, and the first one, the microvascular angina, is what occurs commonly in women. Look at this cartoon. So if a woman has come to you with a cardiac chest pain, just 10% times it would be non-cardiac, Beat it, 90% of the times, even if you are not able to find a coronary lesion, she would be having some coronary abnormality, and the commonest of that in 50% of the cases would be microvascular dysfunction, that is microvascular angina. It could be vasospastic or a mix of both, either ways. And it is important because women who are having microvascular dysfunction and myocardial flow, abnormalities, they have a prognosis which is really bad and entirely different from men. And if we look at this, this is the obstructive CAD and the risk which is associated, clinical risk with obstructive CAD. The non-obstructive CAD in presence of microvascular dysfunction has almost similar risk. So if it has similar risk, it obviously needs similar degree of attention and management, especially in women who are having it. So how to identify it? A cardiac PET, a cardiac MRI. A cardiac PET is the gold standard, and it is said that a myocardial blood flow rate of less than 2 is abnormal. Women with very reduced, less than 1.6, are at maximal chances of having adverse cardiac events, and they need to be treated. But treated with what? So there was a group which is called as COVADIS, Coronary Vasomotion Disorders International Study Group. They said that how to identify. So this would be a woman who would come to you with symptoms of myocardial ischemia, maybe chest pain, exertional dyspnea, some angina equivalent. Then her angiogram would be normal. There would be absence of obstructive coronary artery disease. However, she would have an objective evidence of myocardial ischemia. So what is that objective? A positive TMT, a positive stress echo, a positive stress thallium or a SPECT. And beyond that, if you subject her to the assessment of myocardial blood flow in a PET or a SPECT, there would be evidence of reduced myocardial blood flow rate. That means evidence of impaired coronary microvascular function. So the CORE-MICA trial says identify the woman, find out the cause and treat it. Find out the endotype. If it is coronary microvascular dysfunction, your modality of treatment would be different. Maybe you would like to treat her with calcium channel blockers and drugs like nicorandil, or maybe diltiazem, or maybe nitrates, which would act at the level of endothelium and give functional as well as objective relief to the patient. Vis-a-vis, if you have an obstructive disease, of course you're going to give aspirin, statins, beta blockers, and the stuff which is the routine. Having said that, we now also have an advanced imaging system in which there is a hybrid PET-CT. So what is this hybrid PET-CT? PET identifying coronary microvascular dysfunction, and a CT or a CT coronary angiogram picking up any obstructive lesion. So cardiac PET, cardiac MR, coronary microvascular dysfunction, and so on, and important care needed for patients for INOCA, because this personalized care is what a patient of microvascular dysfunction needs, which we not at all think in our OPDs. Woman comes, angio normal, go. So a lot of evidence gap is there. There are trials which are coming up to address it. For example, the CORCUL trial, the Robinska trial. These are the trials for primary prevention. They are studying studying the role of CORCUL trial, for instance. This studies the coronary artery calcium score and compares it to the routine screening rules which we are using for primary prevention. And it was found that superior statin adherence is found in the patients who are studied with coronary calcium score arm. It is also found that if we are using these trials, probably we will have less patients who turn out to be very high risk, and we are going to give tailored treatment only to at-risk patients, would save our resources as well. So the future of imaging probably talks of CCTA, talks of cardiac PET, talks of cardiac MRI. There are trials which are ongoing. This is a trial, Scott Hart 2 trial. This is ongoing. A sub-study, a part of it, has already said that a coronary CT angiogram for primary prevention, mind it, a patient who is not symptomatic, you're just doing a risk assessment, was associated with modest improvements in healthier lifestyle. This is the cartoon of that trial, which is ultimately going to study the outcomes, the primary as well as secondary outcomes in these patients. So these are the imaging tools: a coronary CT angiogram in setting of stable pain, a calcium score for predicting CV mortality, a cardiac MRI or PET, and these are the sensitivities and specificities of these tests, which are almost equivalent in men and women. This cartoon is big. It would take a day to talk everything. However, all these investigations have their pros and cons. Of course, cost is a big limiting factor for us in treating these patients. It's difficult to get an angiogram for our patients at times. So what to say? However, understanding the disease and targeting it in the right way would almost always remain very important. Studies like Women's Health Wake Up Trial are on to study the ultrasonography and study the endothelial dysfunction, not just in the carotid but in the iliofemorals and everywhere. So before I end, this is a patient, an example, a 40 years old lady who walks into your OPD and she says that she's had some chest pain. You send her for an angiography. The angiography is normal. So you said, okay, your angiography is normal, but I still want to see that if there is any functional ischemia. You send her for a routine SPECT test, a stress thallium or a stress echo. That also turns out to be normal. You think that probably all is fine, but the story actually doesn't end there, and that's what I'm trying to say. You have to probably send this patient for a specialized cardiac PET where myocardial blood flow should be assessed. And if you look at down here, normal coronaries, the cartoons are showing good bright images suggestive of no ischemia which is documented. But if you look at this one figure out here, 1.3. So 1.3 is less than that 1.6 myocardial blood flow rate which I mentioned. So the myocardial blood flow rate is pretty low. So this patient is having chances of having adverse coronary events and should be treated like you're treating your diabetics and considering them as high risk patients. So to conclude, we need to go beyond the usual traditional scores that we have. We need to probably consider coronary artery calcium, which we already are doing as a stratifier. We can use CT coronary angio for phenotyping our patients. We need to address the coronary microvascular dysfunction in our patients. However, the future of cardiovascular prevention for a woman isn't in just better algorithms. It is in our ability to apply these advanced imaging tools and the knowledge that we have to a truly sex-specific, targeted and effective preventive strategy. Because this is one slide which I really loved when I was going through some of the literature. It is of 2017. However, in words of Angela Maas, ischemic heart disease in women is not about religion. Cardiology for women is not a religion for cardiofeminists, as some of us call them, but it is an evolving scientific field with evidence-based data that needs to be implemented in clinical practice. A culture shift is needed in cardiology. Thank you very much.
Thank you, ma'am, for a great talk. Not only cardiology, but a medicine in itself. I remember when I wrote the editorial for your journal, that is general medicine really matters, and that is where when I searched the literature, that is where I became aware that definitely gender matters. You cannot apply the same principles to men and women, both medically as well as socio-cultural atmosphere also. And that was my awakening that it should be gender-specific medicine, and we cannot have one-fit-all medicine as far as gender-specific medicine is concerned.
Sure.
So thank you very much for making me aware of this topic. So the discussion is open. Any comments?
ECG change is always different from men to women, and we always end up saying nobody can understand women's heart.
So with your statement, I remember in 1990s, Dr. Wander called me and I was posted in PSC Gunyana, how many ECGs do you do in a day? So I told them 20-25 ECGs, and that was a huge amount. So at that time, there was no specific differentiation between standardization of ECG in women and men. So he told me to get the ECGs. I did almost 2,500 ECGs, and then we published the data on the gender specific or female specific standardization of ECG in females.
Oh,
so definitely that is upcoming science also. Now everybody is talking about gender specific medicine in all the fields. You take neurology, cardiology,
Yes.
you are spearheading
Yes,
the
yes.
cardiology work group also. So thank you very much. Any other comments, sir?
Yeah, this is a very important topic because recently one of the postgraduates undertaking this study, like gender differences among patients of STEMI.
Right.
So it's just starting this study. I think that is also going to be a good one.
Yeah, really. Yeah, so thanks. I mean, this is really very interesting in this part of world.
Yeah.
There has been a lot of publication. I mean, whatever we know is that STEMI women are presenting very late. They are being thrombolized less. They are getting less of primary angioplasties, and their mortality is much higher as compared to men with similar degree of infarct and coronary occlusion. So thanks.
Thank you.
So I'm also contributing a chapter in Dr. Chopra's book on gender-specific obesity and diabetes.
So he was also very passionate about it. So you've always been great. So thanks a lot for all your help and support. And you know, when I told him, I mean, I requested rather, sir, for that editorial, and he was ready within 2 weeks. And it was such a beautifully written editorial. And that is the first time when we discussed that what is sex and what is gender.
Yes.
And we actually discussed on phone that these are two different entities and we should not confuse. And I think we should work harder and treat women the way they should be. Have more participation in trials, more representation in the patient subset as well as on the part of physician. So thanks for being a part and encouraging.
Thank you.
Thank you very much.
Now for next session, I request Dr. M.R. Gupta to moderate our next session and call the next speaker.
Hello. Our next talk will be by Dr. Ravinder Garg. He is professor and head Department of Medicine, Government Medical College, Faridkot. He is a great teacher, great personality. His topic of discussion will be glycemic variability. Why, what, why and how to manage it. We usually see that the patients say that maybe swear the sugar that ठीक होती है, पर evening ਨੂੰ मेरी sugar 200 हो जाती है. Patient usually कहते हैं मेरा HbA1c 6.5-7 रहता है. But we have to see that the 24-hour glycemic control is there. Professor Garg will tell us how to manage the things, how to manage this glycemic variability. Please, Dr. Ravinder Garg.
Thank you, sir. Thank you so much. In fact, I think Dr. Vitul has given a perfect slot for this talk, because right now, all here they are into glycemic variability. Those who have had lunch are having an upswing, and those who are yet to have it are going to have a downswing. So thank you, Dr. Vitul. So if you want, we can wait for 20 minutes for glycemic variability to clarify. So because 1 hour of speaker is missed, so we have liberty for 20 minutes. No, it's okay. It was. This conference is informal. Yeah, I know. So it was a lighter part of the talk. So let's talk about glycemic variability. What, why, and how. So in the next few minutes, we'll be just going through what is glycemic variability, HbA1c and glycemic variability, need for monitoring glycemic variability, what are its types, and why would we need to manage glycemic variability, how to identify it, and what are the various parameters, or we call as matrix, to assess GV and the management of glycemic variability. Generally, you see, variability is taken as a negative word. Actually, it's not always a negative word, because variability is one which helps us in the circadian rhythm of so many hormones. Not only that, even carbohydrate metabolism is dependent on variability. So let's not always take it a negative. Here, when we talk of glycemic variability, what we mean is fluctuations in blood glucose, but fluctuations are both up and down. So if we are talking upward, that is postprandial hyperglycemia, and a downward swing in the form of hypoglycemia. Both are considered a part of glycemic variability. And why is this important these days? Because this has a direct impact on the diabetes outcomes and diabetes management. So HbA1c. Now, these glycemic excursions which we discussed just now, up and down, they are very important contributors to diabetes outcomes. Now, the problem with HbA1c is that it gives us an average glycemia. It tells us about average glycemia, but what it lacks is hypoglycemia. It cannot detect hypoglycemia, and the short-term fluctuations are not detected by HbA1c. Although we are going to discuss in the coming slides, we'll have a direct comparison with glycemic variability and HbA1c. So what is the need for glycemic variability? It has been seen that these spikes and troughs, that is hyperglycemia and hypoglycemia, they are directly linked to cardiovascular risk, cognitive decline, and quality of life, in spite of having a stable HbA1c. A person might have a very good HbA1c, but still, if that person is having glycemic variability, he or she is going to undergo cardiovascular risk. So therefore, monitoring glycemic variability, early detection, and managing this glycemic variability is very important. So glycemic variability is basically detected by continuous glucose monitoring. Now, what are the various indications of continuous glucose monitoring? So patients who are going repeatedly into hypoglycemia or who are unaware of hypoglycemia, subjects who want a better control of diabetes, avoiding hypoglycemia, pregnancy. Pregnancy is a very important indication for CGM, may it be type 1, type 2. Patients on insulin pumps, and any diabetic patient who wants to improve his brittle diabetes. So these are some of the indications, although these days even uncontrolled hyperglycemia patients are also undertaking CGM. Glycemic variability is of two types: short term, long term. What is long term? Long term is fluctuations over weeks and months. This is what is detected by HbA1c or even glycated albumin. When we talk of short term glycemic variability, now today our focus is on short term glycemic variability. So this could be variability within the same day, that is called intraday, or between different days, what we call as interday. So these two variabilities, intraday, intraday, they constitute short term glycemic variability, whereas HbA1c is a long term glycemic variability. Now let's have a head-on comparison with HbA1c, right? Most of our patients who come to us with treatment, they will not tell you their symptoms. They will not talk of anything else, but they'll show you their report of HbA1c. Okay, sir, ye meri HbA1c ki report hai. So they don't want their diabetes to be treated. They want their HbA1c to be treated, right? So before, or if he or she doesn't have that report, before you advise it, the patient will tell you, कि जी मैं अपना HbA1c करवा लूँ. So it is so common. Why? Because it is inexpensive. It is easily available modality. Yes, no doubt, it has predictive value in the vascular complications. We can predict it, and it helps in good diabetes management. There is no doubt about it. But on the other hand, it has a lot of shortcomings and limitations. One, there are few conditions where we cannot rely on HbA1c. Patient has renal failure, patient has some hemoglobin abnormalities. The second point is, the limitation is that it just gives us an approximate measure, just an average glycemia. And the most important point we just discussed just now it does not tell us about hypoglycemia, which is equally important, and it does not tell us about short-term fluctuations. So short-term fluctuations and hypoglycemia, they are very, very important, which HbA1c is lacking. Now this slide shows us two patients, patient 1 and 2. On the top, both these patients have same HbA1c, 8%. But look at the top patient. Look at the swings up and down. And on the other hand, the patient number 2 is just swinging a little around the baseline. So, patient 1 has a very high glycemic variability and high rate of complications as compared to patient 2, whose swings are not that much. So, low glycemic variability. Although HbA1c in both these patients is same. See the huge difference this factor makes. Now, here we have 3 patients, A, B, C. Patient A, you see what patient A is showing? Patient A is showing both intraday as well as interday variations. Same day also the sugars are swinging up and down, and within the consecutive days also it is swinging. Patient B, a very stable patient, very small swings around the baseline. And what is happening in patient C? Patient C does not have intraday. Within the day the patient's glucose remains stable, but interday fluctuations are again great. So both patient A and C, they have a high glycemic variability, and patient B is the most stable glycemic control. Why do we need to handle glycemic variability? Because it has both short-term and long-term adverse outcomes. So what happens if a patient has a high glycemic variability? There are free radical generation is there. There is oxidative stress, and this damages the blood vessels in the form of endothelial dysfunction. And this endothelial dysfunction has a direct implication on cardiovascular disease, cardiovascular outcomes. And this all acts by nitric oxide. This is less of nitric oxide. There is inactivation of nitric oxide. This is the pathophysiology. And it has impacts on microvascular and macrovascular complications. Now, not only that, what we are least bothered about is most important. And what is that? That is hypoglycemia. Even hypoglycemia is a pro-inflammatory state. There is release of inflammatory cytokines, and that is again damaging the blood vessels. So let's not underestimate the importance of hypoglycemia. And not only that, एक बार किसी पेशेंट को हाइपोग्लाइसीमिया हो जाए, वो एंजाइटी में आ जाता है, उसकी लाइफ क्वालिटी डिस्टर्ब हो जाती है, उसको सेल्फ कॉन्फिडेंस ही खत्म हो जाता है उसका कि व्हाट इज हैपनिंग. सो दिस इज व्हाई वी नीड टू हैंडल ग्लाइसेमिक वेरिएबिलिटी efficiently. If you look at any patient who has diabetes, there are 3 mechanisms by which there is vascular damage in the form of endothelial dysfunction. Hyperglycemia itself, insulin resistance. Now these 2 things we are managing very nicely. There is a lot of discussion on insulin resistance, hyperglycemia. There are so many drugs available. But have we ever thought of glucose fluctuations? See how important glucose fluctuations are. Glucose fluctuation is directly causing endothelial dysfunction, and there is generation of reactive oxygen species. So these free radicals, they are directly being generated by glucose fluctuations. Now this is a head-on comparison between chronic hypoglycemia and frequent acute fluctuations. On the top, we have frequent acute fluctuations, up and down swings, whereas the lower one is a chronic hyperglycemia. So which patient do you think is having more damage? The top one. Chronic hyperglycemia is not that damaging. Fluctuations are more damaging. So how do we identify glycemic variability? We have 3 modalities: self-monitoring of blood glucose, continuous glucose monitoring, and flash glucose monitoring. So just briefly, self-monitoring of blood glucose is very common these days. Everyone has those glucometers, right? Widely available, inexpensive, and you can do it anytime. But what is the drawback? It is patient dependent. रात को क्या हो रहा है? Nocturnal hyperglycemia हो रहा है कि hypoglycemia हो रहा है? You can't detect it. You are sleeping, right? But the utility is, it is giving us some broad trends. Patient come to you, tells कि सर मैंने अपनी शुगर में डेली करता हूँ, मेरी 180 रहती है, 170, कभी कभार 200 होती है. So broadly you see, you think patient is safe. Second is continuous glucose monitoring. Now this is the latest and the most important. It is in fact the ideal one. So where continuously, it's a real time, where a sensor is placed, it is attached to your body, it works for 7 to 14 days, interstitial blood glucose is being tested. It is not patient dependent. Yes, it is like costly hai, little costly as compared to the first modality, but it is round the clock happening and it is ideal to measure glycemic variability. Number 3 is flash glucose monitoring. Flash glucose monitoring, I would say, is in between the top 2 modalities. Little better than self-monitoring, but less important than continuous glucose monitoring. It is also not that expensive, but again, it is patient dependent. Patient can scan his glucose anytime, it is same. But most important and the wonderful would be continuous glucose monitoring. So what are the measurement parameters? How do you describe glycemic variability? There are so many, they are called metrics. So these are some of the metrics which I have mentioned. Coefficient of variation, time in range. MAGE means mean amplitude of glucose excursions, and time below range. There are some other metrics also like CONGA, MOD, mean of daily differences. So briefly we will be touching these 4, they are very important metrics. Coefficient of variation. So coefficient variation is the widely used metric. It is dependent on standard deviation. Its standard deviation is divided by the mean glucose and it is described in percentage. So for a good control of diabetes, having a low glycemic variability, ideally the coefficient of variation should be less than equal to 36%, right? Time in range. This is the latest thing. Time in range means the time duration during the whole day your sugar remains within range. And what is that range? That range is very clearly mentioned, 70 to 180 milligram deciliter के अंदर अगर आपकी शुगर रहती है, लेकिन वो 24 घंटे में कितने घंटे रहती है? 70% से ज़्यादा टाइम, more than 70% of the day. That means 16 to 17 hours in a day. If your sugar remains between 70 to 180, the patient is time in range, good time in range, right? But time below range is also important. If the sugar is less than 70, that is also harmful, right? This should be less than 4%. Less than 4% of the time during the day, your sugar should be less than 70. And above 180, we call it time above range. That should be less than 25%. So these 3 things are very important: time in range, time below range, and time above range. Now this is another matrix, MAGE, mean amplitude of glycemic excursions, which is nothing but average of the absolute differences between consecutive peaks and troughs, right? So in a very, healthy individual, the MAGE values should be around 36 milligrams per deciliter. This is another metric by which we measure the glycemic variability. Let's give some concentration on time below range. As I mentioned, time below range is less than 70 milligrams deciliter of blood sugar, very harmful. Hypoglycemia, very harmful. So we divide this time below range hypoglycemia into 2 levels. One is sugars are between 54 to 70 milligrams per deciliter. This is level 1 hypoglycemia. And level 2 is even less than 54 milligrams per deciliter. That is level 2 hypoglycemia. So level 1 hypoglycemia should be less than 4% in the day, whereas level 2 hypoglycemia should be less than 1% only, right? And you can imagine a patient having a blood sugar of 40, 35, and having that triad of sweating and everything. So there is good amount of evidence now that glycemic variability has its impacts and implications. Now we have so many studies. We have DCCT study, we have the Verona diabetes study, we have the Dobbs study which focuses only on hypoglycemia. So there is good evidence to suggest this, and we know that glycemic variability has adverse outcomes in the form of microvascular complications on your right and the macrovascular complications on your left. So the next big question is, इतना कुछ कर लिया, glycemic variability detect होगी, high glycemic variability है, how to control it, right? So we have two methods, non-pharmacological and pharmacological, as we have of most of the diseases. So first, one should always try non-pharmacological methods. So in non-pharmacological, we have four modalities. One is dietary modification. Second is regular physical activity. Third is weight management. And the fourth is stress management, most important these days. So dietary modification, we have to consume foods which are having low glycemic index, probably a glycemic index of 55 or less, like citrus fruits, high fiber diet, right, apple, right, and then we have some legumes also, and high carbohydrate diet should be avoided. And most important is we should spread our diet throughout the day, right? Timing of the meals is important, regular exercise is important, but what is more important is the last line. Most of the times we are doing unplanned strenuous exercises. We are avoiding our food, insulin lag gayi, khana khaya nahi, exercise heavy kar gayi. We are very happy, but this is causing hypoglycemia and this is damaging. Now we come to pharmacological. Pharmacological is non-insulin methods, and of course insulin is always there. So in the non-insulin agents, we have three important drugs. One is the GLP-1 agonists, which my colleague has already discussed in the previous talks. Second is the SGLT2 inhibitors. Third is the DPP-4 inhibitors. So we'll briefly touch these three group of drugs. So GLP-1 analogs, you know, very good drugs. They are stimulating insulin release, they are suppressing glucagon release, and they are slowing the gastric emptying. And not only that, they are reducing our appetite also. So that is why some of these are being used for obesity treatment. And this, the very important group of drug, they are showing improvement in all the metrics of glycemic variability. So this was a study, direct comparison between DPP-4 inhibitors and oral semaglutide, GLP-1 antagonist, right? So it was a prospective randomized multicentric trial. So what did the results show? The results demonstrated that if we switch from DPP-4 to oral semaglutide, it is significantly improves glycemic variability. So that means GLP-1 are better, have a better stance than DPP-4 inhibitors. SGLT2 inhibitors, no, these days they are being used left and right, not only in diabetic patients but even in non-diabetics also, cardiovascular disease, huff rough, huff puff, so many things. And you know their mechanism of action is increased urinary glucose excretion, and at the same time they have some side effects in the form of urinary tract infections, but a very important group of drug to decrease glycemic variability. And this is another study which was published in 2021, where the glycemic variability was seen by SGLT2 inhibitors and GLP-1 agonists. Now these two important group of drugs were studied in this study, and all these parameters, MAGE, MBG, and time in range, and all these were studied. So what were the conclusions? That both these group of drugs, GLP-1 and SGLT2, they are very effective in improving glycemic variability. So both are considered top slot drugs for managing glycemic variability. Now, vildagliptin, DPP4, third group of drug, another important group of drugs. Now, this is a very good study done, published very recently in 2025, where 44 patients were taken who were on insulin. So out of those 44, they were divided into two groups, 22 each. So one group of 22 continued on insulin alone, whereas the other group was given vildagliptin along with insulin. So what was the result? Very interesting result. All these parameters were studied. MAGE, MBG, TIR, time below range, everything. So vildagliptin significantly reduced all those metrics, controlled very nicely with vildagliptin. So the end result was that adding vildagliptin to patients who are on insulin significantly improves glycemic variability. And not only that, you can decrease the dose of insulin also if the patient is put on add-on therapy on vildagliptin. So the last modality is the insulin therapy, the optimized insulin therapy. And you know, these days we have latest insulins, insulin analogs, which are trying to mimic our routine physiological insulins in our body. So we have rapid acting insulin analogs, ultra rapid acting insulin analogs, we have basal bolus regimens, we have insulin pumps, we have automated insulin delivery systems, and not only that, we have ultra long acting insulins in the form of dagludec and long acting insulin in the form of glargine. So these two, glargine and dagludec, have really revolutionized the insulin therapy in diabetic patients. So, dear colleagues, in addition to HbA1c, continuous glucose monitoring is very important in monitoring and managing a patient of diabetes, and the recommended target in range should be equal to more than 70% and target below range less than 4%. Not only that, if we look at glycemic variability, the most important parameter metric is coefficient of variation, which should be less than equal to 36%, although MAGE and other parameters are also important. So I think we cannot ignore either. We cannot even ignore HbA1c. So the best would be that if we can combine HbA1c with continuous glucose monitoring and look at the glycemic variability and timely control it and optimize it, that can really give us good diabetes outcomes. Thank you so much.
Any questions, please? Any questions?
So great lecture. It was a really learning experience and refreshing the topic of glycemic variability. It is coming up in a very big way. Now most of the people are going for time in range rather than HbA1c, because it is considered to be now the biggest risk factor for all the things. I must congratulate you on your excellent lecture. And any comments? Sir?
It's excellent lecture, sir. Two things just I want to add, because these things are evolving now as we are having newer and newer modalities. CGMS is essential part of management of diabetes for each and everybody. Even if you are managing these patients on lifestyle modification, CGMS is definitely required. There is another thing which have come up is tight glycemic, tight to tight time in range. That means the range is now 100 to 140. So that is becoming, once you achieve between 140 to 180, then you try to bring it tight glycemic range. And another thing, when you're looking at time in range, I give you 70% time in range, remaining 30%, 5% hypo, time below range, and 25% time above range. But this ratio can also be changed. You can have more time below range, still you can have same time in range. So when you're looking at this AGP profile, you have to look at two things, time in range and time below range, which is more important, so that the total remains same. Thank you.
Thank you.
Excellent point. So I must congratulate you, sir. And don't get disheartened by the glycemic variability here, because we have online audience also. And this lecture will be uploaded on YouTube and distributed among all the things, all the, you can say audience and doctors across India. So thank you very much.
Thank you so much.
Thank you.
Our next speaker is Dr. Sandeep Suri. Again, a great speaker. He is a consultant physician from Ulli Health Hospital, Haryana, Hisar. Please, sir.
And you have chosen the great topic because sleep medicine is coming up a big wave or risk factor on almost all the diseases. And you are focusing on diabetes. So thank you very much for choosing this chapter and making us aware about how sleep is affecting diabetes.
Thank you, sir. Thank you. And Dr. Vital Gupta, no words to thank him. And he's a torchbearer for all of us, making MAPICON stronger and stronger. And thank you, sir, for inviting me. It's a more of family to come here. Yes. Thank you. Yes. So if you go back to 19th century, the life expectancy at that time was just around 45 years. Only 1 out of 100 used to live at the age of 80 or 90, and that was by chance or by luck. Most of the children, 1 out of 3, used to die below the age of 5 years. And at that time, the maximum mortality was infectious diseases, natural calamities, and hygiene related issues. So we focused on antibiotics, we focused on vaccines, we focused on sanitation. And we tried to increase the life expectancy, and as we moved on, every year the life expectancy increased by just 3 months. But that was incremental benefits. But when you reach up to the year or the century 2000, so the 2000th century or 20th century, the non-communicable diseases in the form of hypertension, dyslipidemia, cardiovascular disease, stroke, diabetes, they are just exploding. They are just exploding. And we call it genes remaining same, but it is the lifestyle which is being altered. Affluence is increasing, infrastructure is much more better, so we are developing lifestyle diseases. Our life expectancy has increased even up to 75 or 80 years. But you can imagine the person who retires at the age of 60 has got at least 2 comorbid issues in the form of hypertension plus diabetes, hypertension plus stroke, hypertension or coronary disease. So at least 2 of them are already in the baggage of these persons who are retiring at the age of 60. And we call it lifestyle. My topic is chronomedication. It's leading to the alteration in lifestyle and insulin resistance. But it is more of concept building. I'm not going to show you any studies, but going to show you some concepts which has been implicated in the disease, specifically non-communicable disease. So what is lifestyle? If you want to define lifestyle, person sitting in this room may be having their own definition. It's a very fuzzy word, lifestyle. If you want to sell anything in the world, you have one thing, that is lifestyle. You can put more of these on this slide, more of this. But if you want to define lifestyle, it's very clear. Lifestyle is what, when, and how much we eat, sleep, and move on a daily basis. So that means our sleep, our nutrition and metabolism, and physical activity. These are the three important pillars of our lifestyle. But importantly, I have highlighted one word, that is when. We always talk about lifestyle modification, we always talk about dietary therapies, we always talk about physical activity and exercise, पर कब करना कब है, we never talk about that. This is most important issue that is being lacking in our advocacy to our patients. So what is circadian rhythm? Billions of years our earth is rotating on its own axis and around sun. And this is a fundamental property of nearly all living organisms, right from ponds to human being, and which allows all these organisms to anticipate and subsequently initiate physiological, biological functions corresponding to appropriate phases of their daily environment cycle, and it is created due to rotation of earth. That means you are able to anticipate about temperature changes, anticipate about daylight cycle, anticipate about nutrition needs, and that is how we all survive. So on one day, if you are lucky enough to sleep around 10 p.m., lucky enough, we don't find this time. So 10 p.m. is just working hours. So 10 p.m. if you are sleeping, what is going to happen? Melatonin starts increasing. Just within few hours, you are going to sleep. Within few minutes and hours, melatonin, the sleep hormone, starts increasing. Bowel movements are suppressed. Then comes midnight, you fall into deep sleep, and then you have lowest temperature around early morning, that is 4:30, around that. But even before you awake, suppose you are having alarm clock around 7 a.m., roughly around 1 or 2 hours before, your temperature starts rising, blood flow starts rising, blood pressure starts rising, and body is preparing yourself to get alert, to awake. So that is alert time or awakeness time, and you awake. Melatonin switched off, bowel movement starts happening, you go to washroom, highest testosterone secretion at the level of 8 to 9 a.m., highest alertness at around 10 a.m., comes noon, then best coordination. The time when I am giving a lecture, there is a best coordination time. That's why I requested sir to make my lecture at this time, around 2:30. Fastest reaction time around 3:30 or somewhere around 3 or 4 p.m. Greatest cardiovascular efficiency and muscle strength around 5 p.m. and highest blood pressure comes around 6:30 or 7:30 in the evening. Body temperature rises around that time, and then slowly you start going for the rest, and that is the time to rejuvenate yourself, to rest, go to rest, and reset yourself for the next morning. So that is basically the sleep cycle. So this is the way to implicate about all these things which I have told you. But that is all regulated by an important circadian rhythm. So what is shift worker? So are we sitting in this room are shift worker? Anybody can raise hand. Are we shift worker? No. Okay. So I will prove that we are all shift worker. We are all shift worker. The term shift worker refers to any work schedule that falls outside hours of 7 a.m. and 6 p.m. So if you see, we are working every time. Shift worker can include evening shift, it can include early morning shift, as well as fixed or rotating shifts. So you can have various type of shift worker. Evening shift worker, waiters, chefs, bartenders, hairdressers, saloon staff, personal trainers, workers in the arts, sports, healthcare, and media. They are shift workers from 6 p.m. to 10 p.m. Night shift, 11 p.m. to 3 a.m. Very commonly seen. All NCR is awake at this time. All NCR. Doctors, we all, nurses, technicians, firefighters, bakers, truck drivers, air traffic controllers, conveyors, operators, all those who are dealing with transportation, material moving, employees, they are all awake at 11 p.m. to 3 a.m. whole night. Early morning shift, 4 a.m. to 8 a.m. Architects going to the construction sites, carpenters, equipment workers, farmers, fishing workers, forestry personals. So you don't leave any person who is not a shift worker. But why do we need shift working? Critical services on 24 hours are required. Police, firearms, also military personals, healthcare personals, utilities and transportation. So the shifts are required. Extra working, more than 24 hours we require, but God has given only 24 hours. If production required more than 8 hours, continuous production is required. Expensive machinery that must be used continuously, otherwise it will become dysfunctional. Sports services are required for other shift workers. They are basically passive shift worker. The convenience, if a shift worker is working at his own place, there is a passive shift worker at home, your spouse. The students are passive shift worker. They are awake. कब आएंगे घर में, कुंडी खोलनी है, अलार्म बजेगा, कैसे होगा, कौन आएगा, कौन खाना देगा उनको. So they are passive shift workers. So why the things have changed? To understand the molecular biology of circadian rhythm and our body homeostasis, we must understand few things. There are few thousand blue light sensing neurons in our retina. These are known as blue light sensing neurons, roughly around 2000, not more than that. They are not for the image building, they are basically to detect, to look for the bright sunlight. And the bright light has got roughly around 10,000 to 20,000 lux. And the daylight has got sufficient amount of blue light, which is not visible to us, but sufficient amount of blue light, and we have got definite blue light sensors in our retina. What they produce one hormone that is known as melanospin. Melanospin and melatonin both work in a opposite direction. If you have got melanospin or higher side, your melatonin will be suppressed. So melanospin is a bright daylight stimulating hormone, and it is secreted from your retina, and these are blue light sensory neurons in each retina, roughly around 5,000 in total, 2,500 on one retina and 2,500 on another retina. They synchronize the brain clock, they raises alertness, and they reduces depression. So a person who has cataract or is a blind, they are highly vulnerable to have depression, highly vulnerable to have neuropsychiatric disorder because of not having these blue light sensors. Luckily so, our mobiles, they have got night shift, because at that time they are emitting orange glow. Remember, orange glow. And this orange glow comes from the theory of candles and wooden light that was there at our homes maybe in 1940 somewhere. And that gives around 20 lux, not more than that. To stimulate blue light sensor, you require around 1000 lux light. So that was the time then you go for sleep, and melatonin starts increasing and melanospin goes down. So sleep hormone is melatonin, and it rises and it supports your sound sleep. Now coming to deep into the molecular biology. This sleep-wake occurs due to interplay of circadian and homeostatic processes. You have got one pacemaker, that is suprachiasmatic nucleus, just at the base of hypothalamus. This is the pacemaker, or we call it a circadian pacemaker. Roughly around 10,000 neurons are photosensitive, light sensitive neurons on one side and 10,000 on another side. So you can calculate 20,000 neurons are there in suprachiasmatic nucleus of human being. What is a sleep-wake cycle? This is exactly a flip-flop switch containing mutually inhibiting elements to go to daytime and to night time. You have got various hormones in the form of orexin, and this promotes wakefulness. Orexin means you have to take something to eat, and when you are eating something, you cannot sleep. So they have to be properly cycled. So that promotes wakefulness, and also it stimulates monoamine nuclei, and they promotes wakefulness. So MAO nuclei inhibits VLPO, ventrolateral preoptic nucleus, which is promoting sleep. So VLPO gets inhibited, nucleus ceruleus, tegmental nucleus, and reticulating activating system gets activated under the effect of orexin, and this is a wakeful state. On another side, you have got VLPO activated, and this is activated by GABAergic neurons, and GABA and galanin, these are sleep hormones. Under the guidance of melatonin and adenosine, they activate VLPO and you fall into sleep. So now you have got various triggers and we call them ZZBers. ZZBers are the triggers, and I have given you one trigger which is light. Light is the trigger for sleep-wake cycle. There are another important cues or peripheral cues or central cues like temperature. Once you feel increasing body temperature, always you will not feel sleepy. So that is again ZZber. Physical activity. You start doing physical activity at around 12 in the night, you will be just awake. That's why we tell our students to walk for some time, then come back to sit. Don't keep on sitting, because that increases alertness. But very important ZZber nowadays is a food. If you consume any food around 12 midnight, 1 a.m. in the night, at that we are all doing in the shift working, your body gets confused whether it is a resting time or it is a rejuvenating time, or it's a daytime or night time. You make your body confused, and that alters your internal clock system. And these internal clock systems are there in each and every organ. Each and every organ is an endocrine organs unless you prove it differently. So they are all endocrine organs. They are connected with each other, whether you are taking bones, muscles, adipose tissue, or your liver, kidneys, heart, intestine, brain, heart, everything is an endocrine organ, and they are interconnected, and they have got their own auto-regulation. Just you have seen, sir was presenting the glycemic variability and insulin secretion and hypoglycemia. So they are all regulated by your external circadian rhythm, and there are various ZZbers, they alter these clock of various organs. So as per the light and dark cycle, going to the pacemaker, that is suprachiasmatic nucleus, you have got feeding, endocrine and neuronal, and each and every tissue has its own auto-regulation and its own cycle or its own clock. And very importantly, you have got insulin secretion from beta cells of pancreas, continuous secretion as a basal format, and once you take food, that is a ZZber for insulin production from beta cells of pancreas, there is bolus secretion of insulin. First phase comes, then second phase comes, and even your basal insulin secretion has got its own rhythmicity. It is not always static. So each and every organ has got its own clock, and that is being governed by the external circadian clock. Now how we have changed it? Overall, if I say, आप outdoor रहते हो कि indoor रहते हो, so if you calculate 24 hours, 87 to 97% you are always indoor. Always indoor. You just go out on your car, reach to the clinic and remain there for say 6 hours, 8 hours, 10 hours, and not calculated. So roughly everyone is 85, 87% to 97% is indoor. So what is not aligned? This light is not aligning to us. This light is not, this light leads, or you can say blue rich light or bright indoor light, LED light, or even an hour of dim blue light from your phone, from your tablets, from that activates melanospin. And melanospin is just against melatonin. And that disrupts your circadian rhythm, reduces your sleep hormone melatonin, and keeps you awake all time. So you are awake all time, even when you are sleeping for few hours, it's not a peaceful sleep. You are not reaching up to the REM sleep. And that what is leading to us confusion, anxiety, depression, reducing performance, and promotes lot of neuropsychiatric disorder, and also it leads to altered homeostasis. All hormones which are there in the wakeful condition, sympathetic tone, cortisol, insulin, they are all upregulated throughout the time when you are awake and extra time when you are working shift hour, and those hormones which are to give you rest and repair and rejuvenate, they are just suppressed. suppressed. So what this leads to? This is basically an experiment on two group of mouse, where they continuously given food and light also, and they looked at the beta cell functionality. As the circadian rhythm gets disturbed, their insulin resistance increases, their insulin secretion goes down, and their insulin sensitivity goes down, and they become more pre-diabetic and diabetic. So that is the thing that we are developing recently. Altered sleep pattern, altered circadian rhythm leads to alteration of every hormone, every organ tissue, and that makes a sort of various metabolic issues which are increasing. And not only metabolic issues, cancer is a big non-communicable disease, and metabolic issues, they are increasing even in gynecology problems also. So if you continuously doing these type of activity and continuously adapting shift worker style, or deprived of proper sleep and not going into circadian balance, which your body should be, there are chances to develop epigenetic changing. There are also mutations in the clock genes like Bimali and clock and tri genes. These are genetic predisposition that leads to mutation in clock gene. But disruption of fasting and feeding, shift working, evening chronotype or social jet lag, altered light dark cycle, and disruption in sleep wake cycle, disruption in rest activity and rhythm, all leading to circadian disturbance, and that leads to type 2 diabetes. And we are always searching about newer and newer things what can cause type 2 diabetes. And pollution, Dr. Vitul Gupta is a pioneer in pollution, and he have given the book, and I think this book has circulated to even each and every corner of India, and that gives a very clear indication that if a particle ppm increases above 2.5, that has got direct implication leading to insulin resistance and decreasing secretion from beta cells of pancreas. So there is direct correlation with development of diabetes due to this pollution. And there are many endocrine disruptors which we are having and we are using. Even your plastic bottles, they are endocrine disruptors. So what tips you can give for management of diabetes in shift worker? You can have these type of population, and if you inquire, most of your population will be having shift workers. So advise them to eat lunch around 12 p.m. And if you can possible, you can change your circadian rhythm, or for better harmonious involvement, lunch at 12 p.m. I think that is not possible. Dinner around 6 p.m. Not existing nowadays, but these are the things which are being advocated. Avoid eating large meals during night, eating during day and early evening help to balance food sugar level. Eat healthy snacks during night shift to keep energy level up. At least you can tell your students, at least you can tell your children to, if they are on to work for night, they can go for healthy snacking at that time. They should not wait until they are too hungry to eat something. Pack healthy snacks like apple, whole grain granola, or sometimes oats, or raw vegetable, nuts and other high protein snacks like sprouts, beans, salads, that should be preferably on their table so they can munch on them. Choose low glycemic index carbs for snacks instead of those which are made of white flour and sugary snacks. Avoid fried and spicy foods to snack or during night shift. These are very, very simple things that can just make you more harmonious. Don't rely on snacks from vending machine that we all call कि अभी स्विगी से मंगवा लेते हैं, अभी ब्लिंकेट कर लेते हैं, अभी जोमेटो से मंगवा लेते हैं, but that is detrimental, that is simple a poison. Stay active, try to maintain a regular workout, and if you are having physical activity schedule, your muscle will be cranky that you are not doing regular exercise, so they will be having their own auto regulation. If possible, go for a walk during your shift. At least stretch out on your table or on your chair. Be sure to talk to your healthcare provider and diabetes team, and also tell them that you are going to a shift schedule so that they can manage your drugs also, they can manage your nutrition requirements also, and follow the advice of your diabetes team and healthcare physician. Concluding, it's a very simple talk, very simple messages, but important things we are into a dilemma how to prevent diabetes, how to slow down this NCD tsunami, and totally burdened about these NCDs. And I think this burden is going to increase day by day, hours by hours. Not only numbers, but complicated diabetes, complicated atherosclerotic cardiovascular disease is going to increase. Night shift disturbs body natural circadian rhythm, leading to metabolic dysfunction and impaired glucose regulation. Chronic exposure to night shift affects pancreatic beta cells, impairs glucose tolerance, and disrupts lipid metabolism, contributing to development of type 2 diabetes. Reduced and fragmented sleep due to shift worker exacerbates insulin resistance, promotes weight gain, may be a cause of obesity, not only prescribing GLP-1. You have to look at the behavioral issues of the patient also, both of which are risk factor in pathogenesis of type 2 diabetes. Effective management includes promoting lifestyle interventions like healthy diet, physical activity, sleep hygiene, alongside optimizing work schedule to reduce circadian rhythm misalignment. Thank you.
Thank you very much. So I think in almost all the adverse effect of health, we are reverting to the traditional things.
Absolutely.
Early to bed, early to rise makes a person healthy, wealthy and wise. Traditional diet is being promoted now instead of junk food.
Yes.
And sleep medicine, I think it is, what was considered an insignificant thing a decade ago. Now it is gaining importance, and sleep is implicated in all the NCDs. You have beautifully talked about how it is affecting the diabetes. Thank you very much. Any other comment or question?
Dr. Sandeep, are we only talking about night shift or talking about the sleep disturbance?
Sir, both things are involved. Sleep is very important.
Why I'm asking is, we see a lot of patients with depression.
Yes, sir.
And their sleep is always disturbed.
Yes, sir.
And in that case, you see all those patients, they are all prone for
Yes,
pre-diabetes.
both things are interlinked, and they are also separate. There is light therapy for depression also. Expose them to light for roughly around 60 minutes a day. So you will be, a normal person requires 2000 lux, light of 2000 lux, at least 60 minutes a day. So if you are not giving that amount of light itself, you are going to get more depression. So light exposure and also altered sleep pattern, both are important for having these issues. Both are important.
The people who are living in Norway, there is a six months nights and 6
Yes,
months days.
yes. So yes, absolutely. They are much more sufferer than us. We are basically we are blessed to have more sunlight with us. But issue is that we are all indoor. We are all sitting in Norway basically. It's not different.
That's why probably vitamin D is getting
Yes.
So like the ad of some refrigerator, they write Switzerland and they are sitting inside.
Yes.
Right?
Yes.
So any comment, ma'am?
Sir, is there any role of intermittent fasting? Well,
Yes.
there is a definite role of intermittent
Yes.
fasting.
Okay, fine. Just I will take 2 minutes, sir. There is a metabolic flexibility, term metabolic flexibility. When we are eating for 6 to 8 hours, what is happening? We are burning more of glucose and we are not burning fat. We are burning more of glucose and we are retaining in the form of, either in the form of glycogen or in the form of fat. So burning glucose and storing, that is the time when we are keep on eating, say 3 meals a day plus 2 snacks. And if you increase this time, once you stop eating, say at 8 p.m. at night, you stop taking food, 10 p.m. your fat burning starts increasing and your glucose burning is now lower side. So 10 p.m. your fat starts burning and you will keep on having burning of fat throughout your night till you consume the breakfast. Suppose if you extend this period, actually what happens that once, even when you are awake, when your eyes are open, your mouth is open. So you keep on munching everything till you are awake. So you are not into that metabolic switch. You are burning carb, you are storing fat. You are burning carb and storing fat. You are not burning fat. So that is the reason time-bound eating, that means intermittent fasting. You make it, say, 6 hours of eating and remaining fast, or 8 hours of eating and remaining fast. That is again very, very important. So intermittent fasting is a big thing that increases, that will just give you a metabolic switch or giving you more metabolic flexibility. But again, when you ask your patient to go for intermittent fasting, उस 6 घंटे 8 घंटे में क्या खाना है, ये भी बहुत important है. Quantity and quality of food at that time, because if you are eating like a pig at that time, so that will be a issue with that. Thank you.
Thank you very much. So I request Dr. Noria to proceed with the next session.
Thank you, Dr. Mitra. So we are almost to the last sort of leg of our today's sessions. Next speaker is Dr. Gagandeep Kwatra. She is additional professor and head Department Pharmacology, AIMS Bathinda. So she is going to talk about environmental impact of drugs beyond the patients. Dr. Gagandeep Kwatra, please.
Again, very important topic, and I thank you for picking up this topic because this is coming up in a very big way. Effect of pollution, effect of drugs, microbe resistance, and climate change. Yes. So let us hear how the drugs, they affect environment beyond patient. Thank you very much.
You are going for preventive medicine now.
Good afternoon, everyone. And at the outset, I would like to thank Dr. Vitul Gupta and the organizing team of MAPICON 2025 for giving me this opportunity. And as Dr. Vitul has already said, yes, this is a topic which is right now claiming a lot of attention because the effect of drugs goes much beyond the clinic and the patient. It goes into the environment. So when we are prescribing, the ripple effect of drugs goes into the environment, and with the changing demographics, epidemiology, the rising incidence of the non-communicable diseases, easy access to medication, increased longevity, there is a huge amount of drugs that are being used. But when you look at the life cycle of a drug, it does not end at the patient that we prescribe the drug to. So I'm going to talk a bit about the pharmaceuticals as environmental pollutants, how that happens, how do they affect the health and the environment, and then finally some measures which we can take and which we need to take to mitigate the effects of these drugs in the environment. Okay, now we know that drug use is increasing day by day. There is a study which projects that when veterinary antimicrobials consumption is going to be more than 100,000 tons by the year 2030, and there are several other studies which are giving these kind of alarming projections. What we also know is that pharmaceuticals from numerous therapeutic classes, and there are again lots of examples, they are being detected in the environment, although in small concentrations in most of the times. Now how are they getting in there? There are again several sources to these, starting from the manufacturing units, then the consumption of the humans and excretion both through animals as well as humans, unsafe disposal practices, we wash down drugs through the sink or into the toilet or into our dustbins. All of this goes into the environment. It goes into the water, it goes into our soil, then there is leaching from the landfills as well as the agricultural land, and the drugs enter the water sources. Underground sources, fresh water sources, all types of water sources have detectable amounts of, albeit low concentrations, but drugs in them. And then there are point of source discharges from the hospitals as well, which add to this. Now, the current water treatment plants that we have, they do not completely remove these residues. And the untreated wastewater sometimes is discharged into the environment in many parts of the world which do not have good systems. Now there is evidence to show that all of this drug residues, metabolized or unmetabolized, which are going into the environment, have the potential to damage aquatic life, the ecosystems, and they pose direct as well as indirect risk both to humans, all the other organisms, and the ecological chains. Now, although we know that these risks are being reported, there are small and large scale studies which are reporting that there are drugs in the environment, but the lack of global coordinated efforts is there. All regions, all countries are known to be affected with this problem. There is no specific region which can say that we do not have this problem. Most of the data, like the other literature, comes in from the high income countries, but there is sufficient information to suggest that low middle income countries which are associated with poor wastewater, poor waste management infrastructure, and poor control of pharmaceutical manufacturing emissions are more adversely affected. Now, when you look at literature, you will find several such reports. For example, drugs like fluoxetine, which are affecting fish behavior, which are making them less risk averse and more vulnerable to predators. Especially during the time of COVID-19 and after that, there is a lot of talk about the persistence of antidepressants in the waters. Active substances in the oral contraceptives have been shown to damage reproductive cycles and development of fish and amphibians, leading to concerns for ecosystem balance. Now again, this is a topic of great interest because there is a huge amount of estrogens which go into the water, both natural as well as synthetic estrogens, used both for humans for contraceptive purposes as well as in the livestock. But then there are several other factors which also play a role here. There are phytoestrogens, there are natural care products, and several other chemicals which could also be implicated in these alterations in the reproductive behavior. There is also a link between estrogens and human fertility, association with some of the cancers with estrogens. In India, we are familiar with the virtual extinction of vultures due to the use of diclofenac. The overuse and discharge of antibiotics into the environment exacerbates the risk of antimicrobial resistance, which again is a global problem, and it potentially impairs the role of bacteria in metabolizing the organic substances in water as well as soil. Now there are concerns over this chronic, long-term, low-dose exposure to residues of multiple pharmaceuticals, not just one, through consumption of water, crops, through the dairy products we use, fish we consume, and the meat products. Levels of some of these drugs like carbamazepine at times exceed those levels which are safe for us. Now, although these individual substances usually are found in low concentrations, but along with the other co-contaminants and pesticides and other chemicals, these may have a lot of long-term cumulative or synergistic effects. So this growing body of evidence indicates that there is a pressing need for urgent and global action. The UN Environment Programme has identified this environmentally persistent pharmaceutical products as a serious problem which requires urgent policy measures. So there is a call for action at the global level, at the national level. So let's see what all is happening and what all more needs to be done. So what we need is a global coordinated effort for a comprehensive assessment of the magnitude of the problem. There are a number of studies which are taking place, but they all use different methods, their populations are different, and we do not have good methods to estimate these low concentrations for all of the pharmaceuticals. So what we need to understand is the direct and indirect effect on humans, amphibians, reptiles, all of the ecosystem, so that we can get an idea of how huge this problem is. We need standardized methods to identify, assess and monitor the combined effects of these multiple substance residues that we have. Then we need evidence-based risk assessment so that we can identify the most urgent issues and then accordingly start dealing with those. We also need to remember at that same time that while we are dealing with these risks, the medicines and the drugs that we use, their benefits exceed the risks. So patient trust in the medicine system needs to be maintained. So what are some of the national and global regulatory actions? They need to be directed at monitoring, at reporting, setting of standards for manufacturing, wastewater treatment, allocation of responsibility throughout the life cycle of the drugs, including disposal, agricultural practices, and consideration of the environmental impact of drug prescribing and dispensing. So when we look around, there are regulations in place. The US FDA has regulations. In Europe, the regulations right now are currently under revision. They are looking at expanding these regulations to ensure that pharmaceutical companies, the prescribers, the pharmacies and the consumers understand and start behaving more responsibly. We ourselves have our own guidelines. We have the biomedical waste disposal rules. CDSCO in this year has released this guidance document on disposal of unused and expired drugs. So this pertains to the industry, the manufacturing units, the prescribers, the wholesale and the stockists, and whatever measures are needed to be taken at the level of clinics, government and private institutions. So in this guidance document, they have given recommendations of what and how disposal should be done and some measures of what should not be done. They've also given out a list of drugs which are safe to be flushed down because of the safety concerns of the misuse of some of these molecules. In some of the countries, we have this extended producer responsibility laws which are applicable, which shift the responsibility of this whole life cycle of the drug from the consumers, prescribers to the manufacturer themselves. So countries which follow this approach, they will shift the financial as well as the organizational burden of this unused pharmaceutical product collection and disposal from the government to the industry itself. Now what is the role of the prescribers and the pharmacists here? So when we look at studies, awareness amongst the healthcare professionals on this topic is currently low. This is not to say that all of us are not aware, but generally it seems to be on the lower side. As prescribers, our role begins much before we start talking about how we can prevent and how we can treat the pharmaceuticals which are in our water, in our soil. It goes to the level of can we prevent the diseases and reduce the amount of pharmaceuticals that we are consuming. Taking care of polypharmacy, avoid it as much as possible wherever applicable. Using drugs in a more rational manner so that our utilization patterns become smaller. Then we go on to awareness about what we can do to minimize the impact on the environment. Okay? So that is something that needs to be ingrained into now our teaching programs, into the CMEs and continuous education programs that we organize so that we are all aware and mindful of this concern to the use of drugs. It is important to consider the consequences of inappropriate prescribing, and at the time of prescribing, if we could keep in mind the environmental impact of each medicine, then that would help to make decisions which are more environmentally conscious. Recycling policies are being proposed in some of the areas. So when you're looking at redispensing of unused pharmaceuticals, there are some studies which have tried this, and they have done it, for example, where the package is unopened, undamaged, and the period between the return and expiry date is about 6 months to a minimum. Now, this is something that has been done in a few centers, and in the Netherlands they have allowed the certified pharmacists to sell the undamaged pharmaceutical products before their expiration date to other pharmacies, often offering a discount. There are some US startups which are functioning in a similar manner, offering drugs to patients with low income. Now, it seems to be a promising approach, but it requires a thoughtful implementation, because we need a comprehensive communication between all the stakeholders who are going to be involved in this, paying particular attention to the product quality assurance, financial handling, and legal implications of this process. Now, green prescription is another newer concept which implies that the prescriber consider the characteristics and environmental behavior of pharmaceuticals when prescribing. For example, oxazepam is particularly preferred for the elderly because of its pharmacokinetic properties. But then it goes unmetabolized into the environment and stays there for several years. So from that kind of a perspective, when we use drugs which are metabolized in the body and are excreted as inactive metabolites, then those are the ones which are preferred. Collection schemes and take-back systems is something that happens in most of the Western countries. In very small pockets of India, this is something which is beginning to get started, where we have our pharmacies which take back the unused drugs instead of those being flushed down or being thrown away into the dustbins. So pharmacies and the pharmacists here will have a very active role. So when they dispense, ideally they should also tell them what is the take back mechanism, how these drugs need to be disposed of. So there are some countries which offer incentives for take back schemes, and in Sweden there are pharmacy chains which offer some credit points when they are returned. So different countries are using different systems for these take back programs that they offer. Okay. Now looking back at how we manufacture our drugs. Can we manufacture them being more mindful of the environment? So yes, there are researchers who are also working towards this area to minimize the impact of the production and the release of pharmaceutical products into the environment. So they are using computerized drug designing systems to see how they can modify the drug structures so that they are more environmentally friendly. And these greener drugs, once they come in, they will also be contributing towards the sustainable development goals of the United Nations. So there are people who are working on better drug delivery systems. For example, when we dispose of transdermal patches or the meter dose inhalers with some amount of drug still working, those are also leading to environmental pollution. Education is extremely important. So education of the healthcare workers, the consumers. So what we need is a change in the mindset, both of prescribers, the pharmacists, as well as the consumers. So there are several campaigns which are being run in different countries to educate the prescribers as well as the consumers, so that we are more aware of the problem. So to wrap up, environmental pollution by drugs is a global problem, and it requires collective efforts by all the stakeholders involved, the governments, manufacturers, healthcare professionals, as well as the patients. Thank you.
Thank you, Dr. Quatra. Very nice talk. I think the magnitude of the problem is much, much larger than what we are even foreseeing it.
Yes, that's true.
I mean, that's what I can see it, you know. But as a few countries have, I mean, everybody should be sort of taught all the expiry drugs or unused drugs should not be sort of flushed or sort of to be soiled, you see. There should be a mechanism, as you have in few countries, that some center should be there where we can collect and send all those drugs there, so they can proceed it further safely according to the environment and the system.
Yes, sir.
Probably
That
I
is
think that
certainly needed. We don't have that system fully functional now, but we need that so that at least we have a single collective system.
The other problem is, I think, is the population. Probably because as the population is increasing, so is the number of all these environment factors and this disposal and all those things, which were not there 20, 30 years ago. See what we are facing it today.
Yes, sir.
I mean, even every day the van comes, you see, to collect your garbage, all those things, you see, which were not there before. And we are all facing the same problem. Only we have to have some mechanism where we can improve all the situation.
Yes.
Even, madam, in government hospital also, they just throw tons of expired tablet in just in environment, dustbin, or out they just throw it without any.
Ma'am, because we do not really have good systems in place to say what needs to be done. So we need to raise our voice, create systems so that it is all collected. Otherwise, yes, in hospitals, in every place, we are just throwing them. We are just throwing them. That is the problem with our system.
Any other question, please? Thank you, ma'am.
Thank you, sir.
Friends, next speaker is again from AIMS Bathinda, is Dr. Suresh Goyal. So he is going to talk about serum PSA levels, myths and facts. I think PSA, you see, even I remember when as a student, at that time that everybody beyond the age of 50 and have to have a PSA level every year. I think over the years, I think the concept about PSA has changed a lot, and Dr. Suresh Goyal is going to talk about the PSA and myths and the facts. Dr. Suresh Goyal.
And very appropriate topic, because in our practice, patient report लेके आ जाता है जी मेरा PSA बढ़ा हुआ है या इतना हो गया है इतना हो गया, serial PSAs. And once it is increased, they are getting it done almost every 3 months without any treatment or some consultation कि PSA बढ़ गया और थोड़ा हो गया. So I think this is very appropriate topic, facts and myths. So, yes. So let us hear about the facts and myths. Thank you.
Very good afternoon to all of you. A very good afternoon to all of you. At the outset, I would like to thank MAPICON organizing team to give me this opportunity to speak on this platform. First of all, why this topic was chosen? Because PSA is one of the most common self-prescribed lab tests, especially because of these labs. They are proposing packages. In that, PSA is part and parcel, be it a 30-year male, be it a 80-year male. The package is same. That's why one is the reason. Another, but also it is one of the most misinterpreted tests. That's why we thought that this test needs more awareness about indications and interpretation of this common lab test. Now, I will start my presentation with few index cases. This is case 1, 70-year-old male, asymptomatic, very healthy lifestyle. He got PSA screening done because he heard on social media about PSA. So his serum PSA came out to be 6.5 nanograms per ml. And in the lab, cutoff value is 4 nanogram per ml. Now he and his family is worried. Now what to do next? Either transrectal ultrasound, prostatic biopsy, MRI prostate or a PSMA PET scan. Now another index case. This is a 84-year-old male who was being evaluated for abdominal pain. He gets serum PSA as a part of, again, investigational package. PSA is 24 nanograms per ml. What to do? This is one of the prescription I got on my WhatsApp from my uncle. 78-year male, everything is fine, just got PSA during COVID phase. PSA was 8.1. I will tell you what we did next. Otherwise, his symptoms were, urinary symptoms were well on alpha blockers. Now what to do in this case? Next. Now this is a very interesting case. A 52-year male who had acute urinary retention with acute prostatitis got serum PSA done. PSA came out to be 14 nanograms. Again, what to do? This is the WhatsApp communication with this patient. You can see in August 2022, they sent me the reports and I asked him why this PSA was done. See what he has written. Somebody told me. Not doctor. Now next, see. I told him that get PSA after 3 months. He said, sir, any precautions for PSA? He's still worried what will happen. Then for 3 years, he was all right. In this July again, 2025, he got acute prostatitis and again he got PSA done. It is 19. I will tell you what happened with this case. This is another interesting case. A 36-year-old male who had recently, his grandfather died of certain cardiac disease, but was having prostate cancer. So out of fear, he got PSA done. His PSA is 4.5. 36-year male. What to do now? Now, briefly, I will tell you what is PSA. PSA is a glycoprotein that is produced by normal prostatic intraepithelial cells, and it is widely used in prostate cancer detection and monitoring. Although its role in screening it's very controversial. Guidelines differ with regard to use of PSA in screening for prostate cancer. Now I will come to various facts and myths associated with PSA. PSA, as the name says, it is a prostate-specific antigen, not prostate cancer-specific. So first myth is PSA is specific only to prostate cancer. The answer fact is it is prostate-specific, not cancer-specific. So it also increases in benign conditions like benign prostatic hyperplasia, prostatitis, retention of urine, any transurethral procedures like catheterization or PRP or prostatic biopsy. Another myth is if one is having a normal PSA, does it rule out prostate cancer? Again, fact is no. Even patients of prostate cancer could have normal PSA, like neuroendocrine tumors of prostate or highly undifferentiated prostate cancers could have normal PSA levels. So there is no direct correlation between the serum PSA or prostate cancer. Another myth is screening PSA testing is suitable for all men. Again, fact is routine PSA screening is not universally recommended for all the patients, rather persons. Decision to screen a person for prostate cancer using PSA should be individualized based on age, family history of prostate cancer, his race, overall health and life expectancy of the person. Another myth is if universal PSA screening can prevent all prostate cancer related deaths. No, fact is one is ERSPC trial that says that even if go for universal PSA screening, it will reduce the mortality due to prostate cancer by only 20%. Rather, it leads to overdiagnosis, overtreatment, and apart from that, anxiety in patient and family. Another myth is PSA level is the only test needed to diagnose prostate cancer. Answer is big no. It is just a screening tool. We need digital rectal examination, prostatic biopsy, imaging in the form of either MRI or PSA PET scan, and also additional parameters like PSA velocity and PSA density. Another myth is PSA level in an individual are always stable over time. Fact is no. PSA levels vary depending upon the prostatic condition like prostatic inflammation, physical activity of the person, and certain medications like we are prescribing finasteride, dutasteride to the patient, they also affects the level of PSA in a particular person or patient. That's why rather than a single report, it is a trend of PSA that matters, not a single report. Another myth is high PSA level means more aggressive disease. Fact is no. Even very high PSA level can be seen in advanced disease, but that doesn't mean it is aggressive disease. Even low-grade tumors could have high PSA if disease is bulky at the presentation. Another myth is a single cutoff, as we see in lab reports, cutoff value written is 4 nanograms per ml for all the age groups. But this is not the case. Factually, in the 4th decade of life, cutoff value is 2.5 nanograms per ml, and in the 7th decade, it is 6.5 nanograms per ml cutoff value. Now, if another myth is PSA is useless once one is diagnosed with cancer. No, it is essential tool for following the patient following treatment of prostate cancer, for monitoring the progress, for monitoring the response to treatment, and to diagnose the biochemical recurrence following treatment. Another myth, if PSA is obsolete, no, still it is a important biomarker along with adjuncts like newer modalities, free and total PSA ratio, prostatic health index, 4K score, and PCA3 marker. Now we come to the indications and contraindications of PSA screening. When to do PSA testing? So in men aged between 50 to 70 years, PSA can be offered after informing the person about risks and benefits of screening. Also, as sir has told that if PSA level is less than 1.1 nanogram per ml at the beginning, it should be done every 2 years, not 3 monthly. And if PSA is more than 1 nanogram per ml, it should be done annually, not 3 monthly or 6 monthly. This cutoff value of PSA screening can be decreased to 45 years of age of a person if there is a family history of prostate cancer. Either one of the first degree relative had prostate cancer before the age of 65 years. Then screening can be started at the age of 45 years in a particular person. This age can further be decreased to 40 years of age if family history is very strong, like presence of BRCA1 or 2 mutations in family. Then screening in a person can be started at 40 years of age. This is the most common indication we are facing. Every patient of Lutz is getting PSA done, but here PSA may be considered but not recommended for patients with lower urinary tract symptoms. Now next is when not to do PSA testing. Men less than 40 years of age should not be done. Between 40 to 50 years should be avoided until unless there is family history. After 70 or 70, some guidelines say 75 years, others say 70 years of age, or if life expectancy of the person is less than 10 to 15 years, it should be avoided. And also PSA testing should be avoided at least 6 weeks after prostatitis, prostatic biopsy, urinary catheterization, and urinary tract infections. Now coming on to index cases again. As we saw in index case 1, patient was 70-year male, asymptomatic, healthy, PSA was 6.5, what to do? We have to look into his age, life expectancy, and we have to discuss with the patient, right, like what are the possible risks and benefits, and what are the outcomes if he gets prostate cancer, with or without treatment. Then we have to plan accordingly. In the index case 2, here age is 84 years, and at the outset there was no indication of PSA. It was not needed, but he has got it done. We have to discuss with the patient and family about the risks and benefits about the diagnosis and treatment to proceed further. Now, third case that was very interesting. In this case, he was having acute prostatitis with UTI, and earlier in 2022 it was 14. In between 3 years he was all right. Now in 2025 he had again a prostatitis, and PSA was 19. In this case, there was no indication. This was rather a true contraindication of the PSA. In this case, we have to operate upon this patient. We did TRP because patient failed catheter-free trial twice. And we can see the biopsy report here. Here is the benign prostatic hyperplasia. We can see here. So in another case, this fourth index case, this was young 36-year-old male, family history of prostate cancer, but that was diagnosed after 65 years of age in his grandfather. So this is not a typical case. In this case also, there was no role of screening PSA to be done in this case. Rather, we can offer genetic testing to this guy rather than going for PSA. So clinical pearls are PSA must be interpreted in a clinical context of the index patient. Testing should be avoided during infections, catheterization, and post-ejaculation and post-biopsy. PSA screening only as a shared decision making after knowing all the risks and benefits associated with it. And we should combine PSA with the DRE with or without imaging to further diagnose the prostate cancer. So this presentation was based on the guidelines from NCCN, US PSTF, American Urology, and European Urology Association guidelines. And take-home message is PSA is a valuable but imperfect test. Myth, there are actually unrealistic expectations from the PSA, and decisions should be actually informed between the patient and physician before prescribing PSA, and goal should be individualized patient management. Thank you so much.
Thank you, Dr. Suresh. Unless you made me very happy because I've crossed 70, so I need not to worry about my prostate now. That is one thing.
Sir, in the index case 2, I forgot to tell you, 78-year male. In that case, that was COVID time. They called me that PSA is 8.4. He was my relative. I told them, forget about PSA, just stay at home. But he was actually pediatrician. And they went to Mohali, Tri-City in a private setup, and they got biopsy. That came out to be CA, but low grades, Gleason 6. But he got COVID. He died within 3 months. Oh. Not because of PSA. What I wanted to say, patient dies of...
He got COVID from the hospital.
Yes, that's what I'm saying. And many more cases in this age, you get, they die of CAD or other things, but not prostate cancer.
So carry home message is that if it is less than 1, you see probably after 2 years, and if it is more than 1, probably after every 1 year, you see. Apart from that, we need not to worry about it. The only thing is must exclude prostatitis, UTI, and any catheterization. I think even if somebody having diarrhea or chronic constipation, probably those people
they
also
could, sir,
they
India
have a high level of PSA.
In India, chronic prostatitis is very common, sir.
Yeah, very
That's
common.
why we get high PSA levels.
That's right.
Very frequently, sir.
So I've seen with diarrhea and constipation also people having high, because they get a routine checkup.
Yes, sir.
Without any sort of, and then
Yes.
suddenly we find that something 6.5 and he's worried about it.
Yes. Daily, say 10 to 15 patients in OPD, we get just reports.
Yeah, that's the report.
You mentioned just prostate health index. What is actually?
This is a parameter of 4 PSA types. They are further kallikrein. This is kallikrein actually. They are types of PSA. There are tests available. All the, like we read isoforms. There are 4 isoforms of PSA. And measuring their levels in the blood, we can come to an index that is into actually more of research that is coming to after PSA. That will be the next marker to guide us in further investigation of prostate cancer.
At what PSA level you advise biopsy?
Again, ma'am, this is actually very controversial. we discuss with the patient.
Okay.
If
Okay.
suppose PS is 10, we get biopsy. Either it will be positive or negative. Positive, if patient will get the treatment, either radiotherapy or surgery or in the form of hormone therapy.
Right.
We have to see that these are the options, and it is written that most of the patients will not die of prostate cancer. So we tell there are another two treatment options: active surveillance and watchful waiting. Before these, so we discuss with the patient, and if he is asymptomatic, before going for biopsy, another if PS is 10, biopsy comes out to be negative, then what? Further stress. Yes. Also, today we have MPMRI and further MRI guided biopsy we can do, but still it is a very, in urology it is very controversial topic, prostate.
What is this prostatic velocity?
Sir, we measure PSA, yes, we have told every year. Then suppose in last year it was 1, this year it is 2. PSA velocity is 1. It is rising by 1 nanogram per year.
How you measure it?
Annually we measure PSA, sir. If PSA velocity is more than 0.75, we take it as a high velocity.
So thank you very much for excellent talk. I think patient should go to a temple and pray that he gets a doctor like you. Otherwise, biopsy, everything we see daily, nobody is making them understand. So that is the take-home message. That if patient is lucky, he will come to you. Otherwise, tarabhi rakha hai ji. Yes. Thank you so much.
I think again next is a very, very important topic, that as the life expectancy has increased, probably so is the incidence of cancer has increased. So Dr. Navdeep Singh is going to talk about tips and tricks in suspecting malignancy, a very, very important topic. Dr. Navdeep, please. Thank you.
So thank you so much for a nice introduction. And I would like to thank Vitul because I think Vitul is an extremely Shah Rukh Khan of Bathinda, who is always so active. And I appreciate his efforts in bringing out a book. I've not read it, the book. I've read about 20% of the book on environmental, and it's really fantastically written. And I think Sir's daughter is in that book also. But बहुत ही अच्छा लगा मेरे को, बहुत ही मतलब the book was actually very good. And I've read one of his articles on the real time assessment of which antidiabetic drugs is being used by physicians. I don't know how much you have read it. It was also very eye-opener. Very good, sir. Thank you so much. The topic of today's tips and tricks, so welcome my colleagues. The reason for coming today is to create an awareness for an early detection of cancer at a very early stage, rather than diagnosing it at a stage, advanced stage, incurable stage. So we all know that Punjab is burning in the grip of cancer. And there has been a lot of progress in cancer treatment, in survivals since about 40 years. And why there have been a survival difference is because of the teamwork. Because in oncology, there's nothing called one-man show. I'm sorry to say, in oncology, there's nothing called one-man show. I'm a hardcore chemotherapist. I'm always sitting at the behind. The first person is a pathologist. I bow my head, I bow my everything to the pathologist across the globe, who sign out the report, yes, this is cancer. This is very tough to do it. And second person who is important is a radiologist. सब कुछ radiologist के हाथ में है. How good the planes are, whether the surgeons can really resect that area, whether we can go further, whether it's a curative surgery. Hats off to all radiologists. So it's a teamwork. Actually, it's a teamwork. And with team, you can aim anything. with best teams, you can aim anything, and you can make things possible, which at the outset looks to be impossible. The only thing is you need to have faith on each other. एक दूसरे को respect करो, regard करो, दूसरी branch को understand करो. ये मत सोचो कि ये basic branch है. Now, I had just listened to Dr. Gagandeep. She was from the Department of Biochemistry. About 10% of the drugs in the present times, they have been discovered by Biochemistry department. So every person, every niche is important. Every niche in cancer is important. You never know from where the curative option is going to take place. So please be united despite all odds. And once you are cured, you can just rest and relax. So everyone cannot afford an RDA6, everybody can't afford a MAPICON, everybody can't afford high-end DNA testing, everybody cannot afford NGS. ये तो दूर की बातें हैं. I think 100 में से 5 patients ही afford कर पाएंगे. 95% can't afford high-end DNA testing. For those patients, how to suspect cancer in simple ways. My talk is always very simple, to the point, and I try to cover it as compactly as possible. This is a cohort of patients which I think my dear physicians see every day. An average physician sees about 50 patients per day. Maybe a hypertension patient, next आता है diabetic आता है, तीसरा गले खराब वाला आता है, फोर्थ पेशेंट मलेरिया का आता है, फिफ्थ पेशेंट टाइफाइड का आता है. तो इतनी भीड़ में ना आपको पता नहीं लगता कि ये ओपीडी की भीड़ है, इसमें कैंसर कौन सा है. उस 50 पेशेंट्स में से जो आप देखोगे, 1-2 कैंसर के बैठे होंगे. तो we just need to have how to identify those patients. उनको ढूंढना कैसे है, वो 50 पेशेंट में से ढूंढना कैसे है. Like watchdogs, we need to be very, very cautious. We need to be very, very cautious with very strong tips and tricks in our mind कि इनको ढूंढना कैसे है. And if you detect cancer at an early stage, then obviously it's cured, you can relax, because cancer means you can survive. You can survive. I don't meet my cancer survivors in any conference or in any group or in any mall or in any shop where I go. I never meet anyone. One of my good cancer survivors is sitting in this hall also, but I had never met him or her because I don't feel like giving him or her a story that yes, I had a cancer. जीने दो यार, ख़त्म हो गया, कैंसर ठीक हो गया, उसको खुशी से आगे चलो. क्या याद कराना, अच्छा आप कैसे हो, कैसे थी. So rule of unilaterality is very, very important at an MBBS level, जो कि बहुत हमें समझाना चाहिए during colleges. B for bilateral, B for benign. Very clear. Bilateral pleural effusion, no. Malignancy is unlikely. Bilateral pedal edema, unlikely. Right? So rule of unilaterality is very, very important in picking up a cancer patient at the very outset. It's very, very important. Patient आपके पास बार-बार आता है unilateral headache के साथ. Unilateral headache. Maybe a GBM. Don't miss it out. Don't think it's a migraine. It may be a migraine, but don't miss it out. It may be a brain tumor. Unilateral meiosis. Unilateral ptosis. Any symptom. I'm a very hardcore fan of a book called Hutchison, जो हम सब ने पढ़ी है, सब पढ़ते हैं, MD के टाइम पे पढ़ते हैं, MBBS के टाइम पे पढ़ते हैं, बस उसी की रिफ्रेशिंग है. Unilaterality is almost 99.99% cancer. This is a clinical sign which we don't need hardcore investigations or costly investigations like NGS or something like that. So Horner syndrome, I think, is a bronchogenic carcinoma everyone knows. Unilateral cord, vocal cord palsy. It can be vocal cord tumor, it can be bronchogenic carcinoma. Again, unilaterality is the key. Unilateral exophthalmos. I'm not talking of bilateral. B for bilateral, B for benign. Just forget bilateral things, they are mostly benign. But unilateral exophthalmos in a child maybe an acute myeloid leukemia, maybe a retinoblastoma, maybe a rhabdomyosarcoma. I won't go into that details, but it may be something, some mass behind the orb, behind the eye, which is pushing the ball forward. So it might be a cancer. Unilateral deafness, very important. एक तरफ की deafness can again be a tumor. Acoustic neuroma, very important. A curable tumor. Unilateral ENT problems. ENT problems बहुत daily आती हैं, bilateral होती हैं, bilateral rhinorrhea होता है, bilateral sinusitis होते हैं, जहाँ पे भी persistent, recurrent, unilateral problems आती हैं, please think malignancy as a baseline clinical in the differential diagnosis. Unilateral epistaxis, very important in young boys, maybe an angiofibroma sitting in the nasopharynx, maybe an angiofibroma sitting in the nasopharynx, which is 100% curable. So unilateral headache, unilateral meiosis, unilateral ptosis, vocal cord palsy, anything which is unilateral, unilateral neck nodes. I've written the last, unilateral neck nodes, not bilateral, maybe lymphoma, maybe a secondaries from testicular tumor, right? So please keep in point, unilateral pleural effusion, एक side की pleural effusion, not bilateral. It can be a bronchogenic carcinoma. Unilateral red hot breast, not bilateral. Unilateral red hot breast may be an inflammatory breast cancer, right? So don't miss it out. Unilateral consolidation of a lung, a single lung consolidation. Bronchopneumonia is bilateral, right? So unilateral consolidation in Indian female Asian patients might be a bronchogenic carcinoma. There's a very small subset of Indian females who don't smoke still have a bronchogenic carcinoma. Unilateral raised hemidiaphragm can be Horner syndrome, can be bronchogenic carcinoma. It indicates a tumor. Unilateral testicular mass, which is non-traumatic, which is painless, I'll take it as a testicular tumor. Please don't do an FNAC, because by doing a FNAC of a testicular mass, you will open out a separate lymphatic channels to superficial inguinal lymph nodes. So no need of an FNAC of a testicular tumor, of a unilateral testicular mass. Unilateral left-sided varicocele, very common. Patients मैंने बहुत देखे हैं, सर ये मेरी swelling हो गई, जब देखा गया तो he had a left-sided RCC, renal cell carcinoma, just presenting as a left-sided varicocele. Unilateral leg edema can be DVT, deep vein thrombosis. अब deep vein thrombosis चलते फिरते बंदे को तो होने वाला नहीं है, क्योंकि DVT can never happen if the patient is ambulatory. So it can happen if the patient is having underlying procoagulated, hypercoagulable state like in cancer. Unilateral leg edema can be a CA cervix, can be a CA anal canal. So anything which is unilateral can point out to a cancer. Unilateral leg pain, sciatica, very important symptom. Please don't take it as a PIVD. Obviously might be a PIVD, but if it is recurrent, relapsing, again and again coming, the patient is again coming to you in the clinics, can be a CA cervix. So this was a rule of unilaterality in normal routine clinics in patients who are coming to us. So the house is open to question. Thank you so much.
Basically, it is sensitization to have the attitude to pick up the cancer.
Yes.
So that is early detection. If you know what are the signs of early detection, only then you will pick up. So you should be creating suspicion or be suspicious about the disease. Thank you very much for, excellent and brief, to the point, as you have already said, कि इधर उधर की बातें नहीं करता, मैं focus करता हूँ सिर्फ.
Thank you, sir.
Thank you. So any questions? Comments?
Right, sir. Thank you, Ji.
Thank you very much. Excellent talk.
Friends, we have come to the last lecture of today's session, and that is the asthma COPD overlap syndrome. Again, you see, asthma and COPD is always very confusing for the patient. Any patient, if we label it bronchitis or COPD, वो पहले क्वेश्चन पूछता है कि डॉक्टर साहब मुझे अस्थमा हो गया, मुझे सांस की बीमारी हो गई. Actually, asthma, probably everybody with a dyspnea or related to respiratory problem thinks that he's got asthma. Actually, it is not asthma. Most of the patients are having COPD, which are being confused with asthma. And Dr. Rakesh Goyal, Senior Professor and Head, Department of Medicine, Maharaja Agarsen Medical College, Agroha, he is going to deliver the talk on this COPD with asthma. Thank you.
Thank you very much, sir. I am Dr. R.K. Goyal, Senior Professor and Consultant, Maharaja Agarsen Medical College, Agroha. Today we will be discussing asthma, chronic obstructive pulmonary disease overlap. What is new? First of all, coming to the basic definition of asthma and COPD. Asthma is defined as chronic inflammatory condition characterized by shortness of breath with cough and wheezing. Then chronic obstructive lung disease is having two parts, chronic bronchitis and emphysema. Chronic bronchitis, as all of you know, chronic bronchitis is defined as cough for 3 months in a year for 2 successive years. Then emphysema is defined as permanent dilatation of tracheobronchial tree, distal to tracheobronchial tree, distal to bronchioles. So the total is chronic obstructive lung disease. Now coming to introduction. ACOS is a heterogeneous condition describing patient with persistent airflow limitation and clinical and inflammatory features of both asthma and COPD. ACOS means asthma, CO means chronic obstructive lung disease. Asthma and chronic obstructive lung disease have unique clinical features. Nevertheless, these clinical features can coexist, making it difficult to distinguish between the two conditions in a clinical setting. As a result, the term asthma COPD overlap was introduced. However, despite the increased research interest in ACO, there is still much controversy about its existence as a distinct entity. And from 2020, the Global Initiative for Chronic Obstructive Lung Disease, GOLD, stopped referring to ACOs, emphasizing the absence of a universally accepted definition due to the lack of substantial evidence. साफ नहीं आ रहे? Yes. In 2017, the American Thoracic Society and the National Heart and Lung Blood Institute collaborated on ACOs workshop report. The panel concluded that the ACOs, like asthma and COPD, does not represent a singular unique disease entity. So there is much confusion whether asthma and COPD are combined or they are separate. There is still confusion and they are overlapping. So instead, ACOs should be utilized to describe patients with a prolonged history of asthma, a modest smoking history. Smoking is very important for causing asthma and COPD, and fixed airflow obstruction. Concurrently, those who exhibit asthma-like symptoms such as peripheral eosinophilia, this eosinophilia is also very important, and bronchodilator responsiveness may have ACOs. While both patient groups are clinically and likely pathologically unique, they are both within the purview of ACOs. However, in 2021, GOLD report that term ACOs no longer exist, and the authors state that COPD and asthma are two distinct entities which can coexist in a single individual. It means some people say asthma and COPD are combined same. Many people say asthma and COPD are different. Some says there is a overlapping of asthma and chronic obstructive lung disease. Despite the removal of echoes from the most important reports on the management of asthma and COPD, Gina and Gold, this entity still continues to be an important and burning topic in the science. Definition: a number of authors and different consensus guidelines have proposed various definitions of echoes during the last decade, usually using several major and minor criteria. Most of them emphasize the heterogeneity of clinical features and function and lab findings that should be considered as diagnostic criteria that could apply for the identification of individuals with possible diagnosis of echo. According to Dutch hypothesis, obstructive airway disease share a common genetic pathway. This is very important. Dutch hypothesis, genetic pathway is very important, which says bronchial hyper-responsiveness being important in both asthma and COPD, while environmental factors determine whether one would have asthma or COPD. This could be differentiated from British hypothesis provided in 1965 by Charles Fletcher, who proposed that an individual with certain genetic predisposition may present the clinical phenotypes of COPD and asthma after exposure to smoking and antigen sensitization. So 2 points are important. One is smoking, second is hypereosinophilia. The most accepted echoes definition is now one of 2015 Gina and Gold documents. In this report, the patient should have a chronic airway disease, means a medical history of cough with sputum production with wheezing or repeated lower respiratory tract infection. So the 4 points are very important. There should be history of cough, there should be history of sputum production, there should be history of wheeze and lower respiratory tract infection. Then wheeze means asthma, cough with expectoration means COPD. If these 4 features are there, then we can say, label it as echoes. Epidemiology: the prevalence of echoes in overall population is only 2 to 3%, whereas the prevalence of asthma and COPD ranges from 5 to 17%, means asthma is 5 to 7% and chronic bronchitis is 2 to 12%, much higher than the 2 to 3% of echoes. However, in COPD patient, the prevalence of echoes may be as high as 25%. And in asthma patient, the estimated prevalence of echoes ranges from 10 to 31%. Means in asthma, it is much higher as compared to this COPD. In 2023, the lower airway infections were very common, and there was very much respiratory infection, mainly the Provitella and Streptococcus, Haemophilus, Pseudomonas and Moxella. These bacteria were causing lower respiratory tract infection in echoes. Then clinical presentation and diagnosis, field criteria and comments. Demographic data, age should be more than 40 years. So what happens, I must say, what happens in Indian, where the population is in developing country, mostly people are labor class. Labor class person generally earn 1,000 rupees a day, and in which they spend about 200 to 250 rupees in alcohol, and 50 rupees, that is not mentioned here, and 50 rupees in smoking. Alcohol means BD or cigarette. And I must tell you, cigarette is more harmful than BD. So what happens when a laborer or who earns 1,000 rupees per day, he spends 250 or 300 rupees in the evening before going to home, and he goes to home in a drunken condition, and he don't give money to his wife or children, and he beats, and that is usual process. And I must say, this smoking and alcohol is very common in higher class and lower class. And in middle class, usually the students of say college or say the say executives of multinational companies who goes in who work late in the evening and late in the night, they do smoke, do take alcohol, and their lifestyle is bad. So they suffer from asthma and chronic bronchitis and emphysema or echoes, and they also have cardiac condition. Recently, say 10 days back, my intern student got this fainting attack in hostel. This is real fact in Maharaja Agrawal Medical College hostel. An intern student who was in NRI, he fainted in the hostel, and on examination he was found to be suffering from a coronary artery disease, and he developed thromboembolism, and the embolus went into the upper story, and he was paralyzed left-sided, and he was shifted from our college to a private nursing home in Hisar, and from Hisar to Delhi, and it was not controlled. From Hisar he was put on ventilator, and he was operated in Medanta Hospital, craniotomy, and I don't know what is his fate now. He is still unconscious. So anyhow, that was by the way. So demographic data is 40 years, medical history, a documented asthmatic history before the age of 40, prior symptom of asthma or allergic rhinitis, history of atopy or allergies, more than 10 packs of tobacco smoke. So I must say smoking and alcohol, these are the two, and thirdly this drugs in Punjab, chitta. These three, and fourth of course the lifestyle and other things, these are the things which cause most of the lung and heart diseases. Then the symptoms, the frequency, intensity and duration of respiratory system symptoms, then exercise limitation. We don't have say exercise limit, all things are controlled by remote. Even fans and lights are controlled by remote. People don't move from the bed. So respiratory symptoms like dyspnea, including exertional dyspnea, cough, sputum are persistent, but variability in symptoms may be prominent. And then spirometry, of course, we do for obstructive and restrictive lung disease. Then clinical presentation and diagnosis, field criteria comments. So lab test we do, lab test may we do serum IgE level. If it is more than 100 international units, it goes in favor of asthma or COPD. Then secondly, eosinophil level. It should be usually, it is usually less than 300 cells per liter, per microliter. If it is more than 300, it means there is atopy or allergy. And we have seen many cases in which the absolute eosinophil count is in thousands, say to the tune of 2000 or more. Then third is alpha-1 antitrypsin deficiency. Then imaging, usually in X-ray chest, usually is helpful in diagnosis a case of asthma or chronic bronchitis or emphysema. Otherwise, further we can go for axial tomography. If there is diagnostic uncertainty, we can go for computerized tomography. Then coming to the non-pharmacological treatment. Non-pharmacological treatment, the first and more foremost is smoking cessation. So in the morning session we were seeing the obese person, then Manjaro injection, that causes smoking and alcohol, uski ichha hi nahi karti. So that is very important. Then vaccination. Besides the vaccinations of children, say infant or say under the age of 5 years, we can go for adult immunization also, say annual influenza vaccine or pneumococcal vaccine. Then allergen avoidance. It is very difficult to go for allergen avoidance in a developed country. In developing countries. In developed countries there is good atmosphere, but here it is where say there is air pollution by vehicles, and in rural area there is ladies working in chula, so they get smokes. Of course, now the cylinder have come by this government. Then inhaler technique. Inhaler technique, I would like to say, inhalation is much better than giving oral drugs and injection, because by inhalation, by inhaler, there is less side effect of drugs. Then pulmonary rehabilitation is given by physiotherapist. Then pharmacological treatment can be divided into 4 group echoes: A, B, C and D. They are shown in the diagram, although the letters are not clear here. So in echoes A, there is stage 1, there can be low medium dose of ICS. ICS means inhaled corticosteroids. Then stage 2 is LABA, and stage 3 is triple therapy, means inhaled corticosteroids, LABA, LAMA and LABA, LAMA and inhaled corticosteroid, ICS. Then again group echoes B, this is more say serious type of asthma. Here low medium dose of inhaled corticosteroids plus LABA, or stage 2 triple therapy. In group echoes C, directly we have to go for triple therapy. Say this is a ascending type of treatment. In group echoes D, stage 1 LABA and LABA, and stage 2 triple therapy. This all depends upon the severity of symptoms, whether we have to go for echoes A, echoes B, echoes C or echoes D. This all we have already discussed. Then there are some biological agents which are helpful, new drugs which can be given in case of asthma or chronic obstructive lung disease or combined echoes. These are omalizumab, is difficult to pronounce, benralizumab, meprolizumab, rezulizumab, dopilumab and tazepilumab, different types. So there is a need of future resource in future research in echoes, asthma, chronic obstructive lung disease, to better understand echoes and its treatment. Further investigation is needed. This is burning topic and scientists are trying, and this further investigation is needed to identify the types of biomarkers and phenotypes that can identify patients who are most sensitive to particular therapies. Current research on echo traits has not utilized all possible classification methods. Longitudinal studies are required to enable a deeper understanding of these phenotypes and how these influence management decision. In addition, performing detailed research including respiratory microbes could considerably improve phenotyping. So conclusion is, asthma and COPD have characteristic symptoms. As I defined earlier, asthma, chronic bronchitis and emphysema separately, yet patients with both are prevalent in the society. However, there is no globally accepted definition of echoes, and it may not be considered as a distinct disease or clinical entity. Some people say echoes, some people say no. So debate is still going. Besides the age and the smoking history of patient, recurrent pulmonary infection, as I told you, bacterial infection like streptococcus and other, inflammation have been considered as provoking factors contributing to the worsening of pulmonary function in elders. No single biomarkers can be used to identify and classify echoes phenotypes. Then non-pharmacological treatment option for the echoes patients include smoking cessation, number 1. Then number 2, annual influenza vaccination. Number 3, pneumococcus vaccination. Number 4, inhalation techniques. So many, say inhaler coming, budamate, say budamate and glycohale and so many, duolin. So they can be given in morning, evening dose or combined dose depending upon the severity of infection. Then you have to avoid the provoking allergy factor. And lastly, pulmonary rehabilitation. The treatment of echoes tend to be escalated to counteract the clinical manifestation and prevent further worsening. We have to control it and stop it there. This may involve increasing inhaled corticosteroids using dose of LABA and LAMA. Thank you very much.
Dr. Rakesh Goyal, a very sort of a complex problem being simplified very well by Dr. Rakesh. The only thing I'm worried is getting pulmonary function test to help in diagnosing ACO?
See, pulmonary function test helps in whether the disease is obstructive or restrictive.
Yeah, if it says both mixed,
then it is of course very difficult. That's why it is a combined echoes.
Yeah,
usually it is a restrictive type of disease, and restrictive type of disease is more say dangerous as compared to obstructive type.
So basically what is happening is echoes, like our teachers used to write asthmatic bronchitis. So
Yes.
it is not a recent concept, but it is an old
Modified.
concept with a different nomenclature. Now also there is no recognized definition. If, yeah, predominantly if it is inflammatory, it is considered to be more of COPD. If it is allergic, eosinophilic, then it is considered to be more of asthma. And if it is in between, so it is overlap. Basically, treatment depends upon the predominant feature. If it is predominantly inflammatory as well as the respiratory test is restrictive, it is more of like COPD treatment. So that is ipravent, the otherwise, and steroids will be in asthma treatment. So that is how it is being demarcated now, and still it is a very confused picture. Yes. So if it is predominantly asthma, you go with inhaled steroids. It is predominantly COPD, you go by anti-inflammatory inhalers.
No.
Very, very important.
And it is very difficult. Usually what happens, I saw, say, in the year, say, I got admission in, say, 78 batch. So in our batch, there were 100 students. And, say, 95 were non-smokers. And when we entered, say, internship, they become 90 smoker. And they also alcoholic also in internship. And so also in post-graduation. So things reverse. Not stress. They say, so I must congratulate and thank Dr. Vitul Gupta. I have a good association with him for the last 16 or 17 years.
Yes,
perhaps.
sir. Yes, sir. Definitely.
And he is organizing single man organization doing this MAPICON, and I usually try to come every year. And I must thank Dr. Vitul
Thank
Gupta.
you, sir. Thank you very much. Thank you. Now we are going to start the poster presentation session, and Dr. Noria and Dr. Seema will be the judges. Please proceed with the poster presentations.
And the first poster presentation is by Dr. Aditya Gupta. Dr. Aditya Gupta, please. And this poster is a rare case of acute spinal infarct presented with hemiparesis and progress to quadriparesis.
Good evening everyone. I'm going to present a poster. It's a rare case of acute spinal cord infarct presented with hemiparesis and progress to quadriparesis without sensory involvement. Introduction. Spinal cord infarction is a rare but severe neurological event resulting from disrupted blood flow to the spinal cord akin to a stroke of the spine. Its occurrence is significantly less frequent than cerebral stroke, yet carries a high risk of lasting disability. A case report. A 77-year-old man with uncontrolled type 2 diabetes presented with acute right-sided hemiparesis of 4 hours duration without any facial deviation. Neurological examination showed intact higher mental function and intact cranial nerves. Motor strength of 4 by 5 in the left limbs and 2 by 5 on the right side, with an extensor response on the right side and flexor response on the left, and normal sensory system examination including cortical sensation. Initial non-contrast brain CT was unremarkable. And he was managed presumptively for ischemic stroke involving subcortical lacunar infarct, as patient had no facial involvement. Within 24 hours, his condition progressed to quadriparesis with preserved sensation, diminished deep tendon reflexes, bilateral extensor plantar responses, and bladder and bowel and bladder involvement in form of overflow incontinence. Brain MRI brain with spine was done. Brain MRI remained normal. With prompt to MRI of the spine, which revealed a spinal cord infarction involving C3 to D2 accompanied by diffuse disc bulge compressing bilaterally transversing nerve roots. During recovery, the left-sided motor functions improved to 4 by 5, whereas the right-sided limbs showed limited improvement with upper limb 2 by 5 and lower limb 4 by 5. Patient was started on antiplatelets and statins. Discussion. Spinal cord infarction is a rare but critical cause of acute myelopathy, accounting for only 0.3 to 1% of all strokes. It often mimics cerebral ischemic events, particularly when presenting with hemiparesis. So maintaining a high index of suspicion is essential when initial brain imaging is unrevealing. The spinal cord's vascular architecture, especially the anterior spinal artery, ASA, predisposes to its ischemia. The ASA supplies the anterior 2/3 of the cord and has limited collateral circulation. Accordingly, anterior spinal artery syndrome is the most frequently observed infarct pattern. Typical features include sudden motor weakness with loss of pain and temperature sensation, while dorsal column functions and cranial nerve integrity may be preserved. But in our case, all sensations were preserved. MRI remains the gold standard for diagnosis, but may appear normal in up to 50% of the cases within the first 24 hours. Characteristics imaging findings later include T2 hyperintensity, the owl's eye appearance on axial sections, and cord swellings, which are evident in our case. In our patient, the evolution from isolated hemiparesis to quadriparesis alongside normal brain imaging and eventual spinal MRI confirmation illustrates the diagnostic challenge. This case underscores the importance of early spinal MRI, particularly in patients with acute motor deficit and intact cranial imaging. In conclusion, spinal cord infarction, though rare, demands early recognition, especially when abrupt onset quadriparesis presents even without sensory involvement and initial brain imaging is normal. MRI remains the gold standard diagnostic tool for confirming spinal ischemia and guiding timely intervention. Prompt spinal imaging is crucial to avoid delay in diagnosis and improve patient outcomes. Thank you.
So your patient had initially hemiparesis.
Yes, ma'am.
So at that time, what was your clinical diagnosis?
And at the time, we were suspecting ischemic stroke in the form of a lacunar stroke, ma'am. So we were managing initially on the lines of stroke management, ma'am.
Okay. Then how many time after the patient develop quadriparesis?
Ma'am, within next 24 hours, ma'am, patient develop weakness on the contralateral side also, ma'am.
Okay. What are the causes of spinal artery thrombosis?
Ma'am, spinal, any trauma or any tumor if there is any involvement on, and ma'am, mainly these two.
No, there are other causes of the spinal artery thrombosis. These are the hyperviscosity syndrome. So tell me a few hyperviscosity condition.
Ma'am, protein C is a deficiency and
Polycythemia.
Polycythemia, right?
Yes. All hematological malignancies.
Yes, ma'am.
Right?
Malignancies can lead to.
What is artery of Adam-Kivis?
Sorry, ma'am.
You are presenting a case of spinal artery thrombosis. You must know what is artery of Adam-Kivis. Okay. What is the treatment of that? What you prescribe
Ma'am,
to treat that particular patient?
ma'am, antiplatelets and statin. therapy.
Antiplatelet and
Statin therapy.
statin. Is there any role of anticoagulant? Usually Novec, new anticoagulant. No idea?
No idea.
Sir, आप कुछ पूछेंगे?
I think the lesson from your case is that anybody presenting with unilateral weakness, and if it progresses to quadri sort of involving all the four limbs, I think the first and foremost investigation is to rule out spinal cord sort of ischemia.
Yes.
The cause may be any, you see, as Dr. has mentioned. I mean, you said maybe hypercoagulability, patient was diabetic. I think you told
Yes,
the patient is diabetic.
yes.
So still, you see, maybe his diabetes is not under control. So that means there is some sort of obstruction, spinal artery or something like that, you see. And maybe you have to rule out underlying any vasculitis type of disease also to make sure that the patient doesn't have any sort of vasculitis sort of disease.
Yes. Yes. Yes.
Very important cause for spinal artery thrombosis.
Yes.
Thank you.
Thank you.
Next is Dr. Nisha Chibad, an unusual case of TB meningitis with brain tuberculoma during pregnancy. Dr. Nisha Chibad. Okay, so she is not there. Next is Dr. Arpit Kumar, and the case is
Good evening, everyone present here. Today I am presenting a poster on topic hypokalemic paralysis involving respiratory muscles as a result of distal RTA secondary to primary Sjogren syndrome, which is complicated by pregnancy. Introduction: hypokalemic paralysis is caused by a number of underlying etiologies, namely genetic, endocrine, gastrointestinal, and renal. Renal tubular acidosis and thyrotoxicosis constitute the major cause of acquired hypokalemic paralysis. Distal RTA is one of the common pathway for potassium loss in a variety of diseases, including connective tissue diseases such as Sjogren syndrome, systemic lupus erythematosus, that is SLE, and rheumatoid arthritis. Pregnancy can worsen any type of RTA, adding on to the hypokalemia secondary to RTA. Case history: a 29-year-old female patient, P1L1, presented to emergency with complaints of amenorrhea since 8 weeks, weakness of all 4 limbs in 7 days, starting from bilateral lower limb and progressing to involve bilateral upper limbs. Bleeding per vaginum since 4 days, breathing difficulty since 1 day. On examination, blood pressure of patient was 110 by 70 mmHg, heart rate was 104 beats per minute, respiratory rate was 22 cycles per minute, and temperature was 100 degree Fahrenheit. On general examination, pallor was present, icterus clubbing, cyanosis, lymphadenopathy, and edema was absent. Power was 1 by 5 in all limbs. All reflexes were preserved, cranial nerves were intact. Per abdomen was soft, and tenderness was present in hypogastrium. Based on the history and clinical findings, we make it appear to be a case of acute flaccid paralysis. which was due to bilateral lower motor neuron pathology. We ruled out anterior horn cell involvement because there was no fasciculations, asymmetry or atrophy. We ruled out pathology in neuron, nerve, roots and ganglion, as there was no sensory involvement. Ultimately, we were left with muscle pathology, and possibility of hypokalemic paralysis was kept, and urgent ABG was sent along with routine investigations, including RFT, which were suggestive of normal and iron gap metabolic acidosis along with severe hypokalemia. ECG was done that showed QTC prolongation, ST depression, sagging of ST segment, T wave inversion, and presence of U waves. On presentation, patient potassium was 1.16, creatinine was 1.09, TLC count was 16.2, HP was 8.8, pH was 7.18, and bicarb was 10.1. Potassium replacement was started, and workup of hypokalemia was sent, keeping major possibilities of for etiology of hypokalemic paralysis as renal tubular acidosis versus thyrotoxicosis paralysis, as the anion gap was normal and there was no history of diarrhea. If there was history of diarrhea, we would have also think about VIPoma as the case. Urgent ultrasound of abdomen was done as there was hypogastric tenderness. Ultrasound was suggestive of retained product of conception along with bilateral nephrolithiasis. As all the investigations were being collected, patient developed respiratory distress and sensorium worsened, and patient has to be intubated as severe respiratory acidosis was present, likely due to respiratory muscle involvement secondary to hypokalemia. Dilatation and curettage was done by the on-call obs and gynae team, and potassium replacement was continued. Gradually, patient after potassium supplementation, patient potassium started to improve. Potassium ultimately came on 14th of July. It was 3.16, creatinine was 1.23, TLC count was 34.7, HP was 10.2, pH was 7.31, and bicarb was 14.9. We also sent workup for rheumatological condition, keeping in the mind of Sjogren's syndrome and SLE. Anion gap was normal, that is 13. Sodium was 155, chloride was 131, urine pH was 6.8, TSH was 2.2, PTINR was 14.5 and 1.23. Anti-DS-DNA was negative and Smith was negative. SSA row 60 was positive, and SSA row 52 was positive. SCL 70 was negative. Based on the clinical history of dryness of eyes and mouth prior to the admission along with positive Schirmer's test with all the lab result, diagnosis of distal RTA secondary to Sjogren's syndrome was made and sodium bicarbonate was added. Patient started improving and was extubated and later was discharged with precautionary advice during the next pregnancy. Discussion: our patient has acute flaccid quadriplegia with respiratory involvement secondary to severe hypokalemia due to distal RTA. Diagnosis of distal RTA was suspected on the basis of hyperchloremic metabolic acidosis, normal anion gap, and high urinary pH. If the urine pH was low, we could have also think of type 2 RTA, that is type 1 RTA, that is proximal RTA. Type 1 RTA, that is proximal RTA. Confirmatory diagnosis of distal RTA was made by positive urine anion gap. Diagnosis of Sjogren's syndrome was made by finding of oral and ocular symptoms, positive Schirmer's test, and higher antibodies, anti-SSA, anti-SSB titers. RTA has been subdivided into type 1 and type 2, distal and proximal, and mixed. Secondary to aldosterone deficiency or resistance, that is type 4. Among these, distal RTA is most common. Distal RTA has multiple underlying etiologies, which include primary and idiopathic forms, and more commonly secondary to autoimmune disorders such as Sjogren's syndrome or rheumatoid arthritis. Hypo or hypercalcemia or drug toxin exposure. Although distal RTA occurs in 25 to 40% of patients with Sjogren's syndrome, it is rarely clinically apparent. Hypokalemia is a presenting manifestation of Sjogren's syndrome in around 2% cases. Pregnancy is reported to worsen either type of RTA. In pregnancy, there is mild physiological respiratory alkalosis and hyperfiltration of kidneys, secondary to increased blood volume. This hyperfiltration results in increased loss of some electrolytes, leading to higher requirement of potassium and bicarbonate. Potassium and alkali supplements are indicated in all these cases of distal RTA and Sjogren's syndrome. There is no role of immunosuppressive therapy for RTA. Case reports are available for treatment with intravenous cyclophosphamide and steroids, but with no benefits. Conclusion: suspicion of hypokalemic paralysis should always be kept in the case of acute flaccid paralysis, an aspect that is frequently overlooked, especially in peripheral healthcare centers, and should be evaluated and managed earliest to prevent any life-threatening complications like respiratory failure, cardiac arrhythmias, or neurological complication. and improving the outcomes of pregnancy. If patient in current case desires to pursue future pregnancy, early antenatal care and electrolyte monitoring should be considered. High index of suspicion is crucial for early diagnosis and timely treatment, which can significantly influence the clinical course of disease and improvement of patient outcomes. Thank you.
Thank you. Very nice case presentation, very nice case, and good outcome, a young pregnant lady. Have you ruled out periodic?
Yes, sir. Hypokalemic periodic paralysis. Yes, sir. Sir, we sent a urine potassium, which was low, which was high. And in hypokalemic periodic paralysis is the calcium channelopathy. Their urine potassium is low.
So that means on the basis of RTA, you suspected it.
Yes, sir.
And the Sjogren was diagnosed, you diagnosed or it was already diagnosed?
We only diagnosed Sjogren's.
That was also diagnosed at the time of the presentation. So she never knew about this Sjogren?
No,
she never had any symptoms?
No, sir. Sir, once patient was extubated, she complained, yes, sir, we only asked her about this, are you having any ocular sicca complaints? So she said, yes, I do feel like that. So, sir, we went onto that path.
I think again the lesson is any young patient with quadriparesis and having normal reflexes or absent reflexes should always think about hypokalemia. So that is.
Your patient have the normal reflexes.
Reflexes were cranial all were intact. Reflexes were normal. Sphincters were intact.
Sphincter were intact.
Yes, ma'am.
Okay. Why not? It is a GBS.
Ma'am, in GBS, ma'am, it was. Ma'am, GBS could be a DD.
I think with the pregnancy.
Axonal motor.
No, because this is your first episode.
Yes, ma'am.
Right. So GBS should be the first possibility.
Ma'am,
hypokalemia is when the recurrence is there, then only we can. Okay, you got the serum potassium level; it was low.
Ma'am,
so
and the patient was presenting with acidosis, so I never thought of.
Okay, your patient have prothrombin time 14.
14.
Why?
Ma'am, maybe she was.
You did dilatation and curatize. What was the indication?
Ma'am, patient was already pregnant since 8 weeks, and there was hypogastric tenderness. So, ma'am, we called up gynae PGs. They told us that the fetus is not moving, is not alive. Ma'am, they just said
8-week fetus. How we assess not moving?
Ma'am, they just ask us to do. They want to do dilatation curettage. It is the only thing because my patient condition was deteriorating and she was getting intubated at that time.
With the pregnancy, if the prothrombin time is high, what do you suspect?
APS. APS.
Why not? This is a Appler syndrome.
APS, ma'am, antiphospholipid syndrome.
Okay. उसके लिए कोई investigation नहीं कराया?
Ma'am, her platelet counts were normal, so ma'am, in APS there is thrombocytopenia always there.
Okay. prothrombin time इतना बड़ा हुआ था, उसके लिए कोई treatment?
No, ma'am.
No treatment.
Sir, INR was 1.23. Yes.
Okay. One more question. Sjogren आपने diagnose कैसे किया?
Ma'am, NDSSA was positive.
Okay, only the investigation, no clinical.
Ma'am, patient was complaining of ocular and oral Zika symptoms.
अच्छा, ये आपने Schirmer test?
Schirmer's test was positive.
What is this?
Ma'am, Schirmer test, we take paper and we put in the eyelash and we check for the tear film. More than 0.5, more than 5 mm.
More than 5 mm, that means?
Is negative. Less than 5 mm is positive.
Yes. Xerophthalmia less than 5 millimeter. Okay. Sir, kuch aur?
Thank you.
Thank you so much,
sir. Next is Dr. Harish Gupta. The paradoxical worsening in tubercular meningitis, a case report.
Good evening to you all. Paradoxical worsening in tubercular meningitis. Introduction. Tubercular meningitis is the most severe form of the extrapulmonary TB. Despite adequate anti-tubercular therapy, paradoxical reaction may occur in the 30% of the CNS TB patients. Recognizing paradoxical worsening is critical to avoid the misdiagnosis as a treatment failure of a drug resistance or drug resistance. Case presentation. A 22-year-old male presented with the headache, vomiting since 3 weeks and altered sensorium since 2 days. On admission, he was drowsy, disoriented and not following commands. Vital was stable and signs of meningeal irritation were positive. Baseline MRI was normal. CSF analysis was advised but was refused. Based on the history and the clinical presentation, a provisional diagnosis of tubercular meningitis was made and he was started on ATT along with the corticosteroids, leading to the improvement in the symptoms. Patient gained complete sensorium by the 5th day of the treatment and was discharged in the stable condition by day 12. Steroids were tapered and stopped at the end of second month of the treatment. After third month of the ATT, he developed a new onset of headache, irritability and the gait difficulty. Examination showed left-sided clonus with extensors plantar response. Repeat MRI revealed tubercular exudate with tuberculomas, suggestive of iris or paradoxical worsening. Corticosteroids were reintroduced in the ongoing treatment regime, along with the supportive management, including hydration, optimum nutrition, and physiotherapy for the gait difficulty. Over the course of the treatment, the patient showed the gradual clinical improvement with the reduction in the headache and the improvement in the ambulation. He was discharged in the stable condition with advice with strict follow-up and the continuation of ATT. Before starting ATT, 2 months before, MRI was normal. At clinical sign and symptom, we had started with ATT and made a diagnosis of TB meningitis. And after starting of 3 months of ATT, patient came with complaints of headache and gait difficulty, and we repeat the MRI, which is suggestive of multiple tuberculomas, ring enhancing lesions. Discussion. Paradoxical reaction, appearance or worsening of the lesion in the TB during therapy despite microbiological control. Mechanism, exaggerated immune response to mycobacterium antigen. Differential can be drug resistance, non-compliance or the secondary infection. Management, continue ATT, steroid help reduce inflammation, rarely surgical intervention if hydrocephalus or the mass effect develop. Conclusion is that paradoxical reaction is not a treatment failure. Awareness prevent unnecessary change in the regime, and imaging comparison should be done in vital for diagnosis. Thank you.
I thought steroid is probably always a part and parcel of treating tubercular meningitis.
Sorry, sir.
Steroids are always part and parcel of the treatment of tubercular meningitis.
Yes, sir. We had given the steroid for 2 months. Patient
To start with.
In starting with ATT.
You started with ATT and
corticosteroids.
In spite of that, there was a worsening of the symptoms.
We had stopped the corticosteroid at second month.
Okay.
After when he was in following up at 3 months of ATT, he came with headache and gait difficulty. At that time, we had repeated MRI, and at that time MRI was suggestive of ring enhancing lesions and multiple tuberculomas. 3 months before, there is no any ring enhancing lesion, only MRI was normal. Prodromal symptoms were present at that time. ESR was raised, fever, malaise, and headache.
And according to the literature, how common is this paradoxical reaction?
Sir, different study was reported. Approximately, they say ki 5% of reaction. 5%. In this 5% of study, they are saying ki we are. Abhi sir guidelines mein nahi aaya that according to physician, they are continuing 4 months or 5 months corticosteroids. Longer corticosteroid they are giving to reduce the tuberculosis reaction.
And the thought came of MDR into your mind also?
Yes, sir, but MDR is both probability can be there in differential diagnosis, MDR or paradoxical reaction. So first we have add DEXA on the 3rd and patient improved. ATT is in continuation phase only. We didn't change the ATT. Patient is ongoing follow-up, he was improved, sir.
So in first time, how you made the diagnosis of tuberculosis?
Ma'am, at that time the patient came with the symptom of 2-week fever with the altered sensorium, generalized malaise, and ESR was 100. We had advice for...
Was there any cranial nerve involvement?
No, no cranial nerve involvement. We think that it's a prodromal phase of TB meningitis.
Okay.
And we think for to done a CSF analysis.
You did CSF analysis?
Patient refuse, ma'am. On working diagnosis, we start the ATT. And on the second,
So
with DEXA.
you start ATT on the base of?
Strong suspicion of the TB meningitis, ma'am, and ESR is on symptoms.
Usually tubercular meningitis we diagnosed by the CSF examination. Clinical as well as the CSF examination. CSF examination is mandatory for the TBM.
Yes, ma'am.
Okay. So in the first MRI, was that tuberculoma there?
No, ma'am. No
there
tuberculoma.
Was no tuberculoma.
No tuberculoma.
Okay. So the second time after ATT, your patient have big tuberculoma.
Yes, ma'am.
Okay. Okay, they appear after.
And in between, we have completed 2 months treatment of corticosteroid also.
Okay.
After we had tapered, after 1 month, patient deteriorate within 1 month.
That means after stopping steroids,
Yes.
patient started deteriorating.
Yes.
That
And we
means-
restart the steroids.
That means we can have to continue with it.
There are different trials ongoing, which said कि we have to continue 4 to 5 months corticosteroid in TB meningitis. And we have to, मतलब हमें आगे follow up के लिए MRI कराना पड़ेगा, जिससे ही हमें पता लगे कि कैसे clinical variation है या patient deteriorate हो रहा है या सही. अभी guidelines में नहीं आया, but there are different articles.
But tubercular meningitis, CSF must be there.
Yes, ma'am.
Right? And okay. Now in second time, what was the clinical presentation? Your patient come with hemiparesis.
Gait abnormality, ataxia and headache.
Gait abnormality and?
Headache and persistent vomiting.
And altered sensorium.
No, second time not in altered sensorium. First time he came in altered sensorium.
Okay. Second time only the gait abnormality was
Yes.
there. Okay.
And ma'am, in first time, मतलब he giving the history of 2 weeks.
Okay.
मतलब 2 probability might be viral or 3 weeks probability. Viral can be ruled out because of so much long history.
Okay.
So viral encephalitis. So we made a diagnosis as TB meningitis, and partially we give the DEXA, patient improved.
Was your patient have immunodeficiency?
No.
HIV was negative?
Negative.
Okay. Usually such type of reaction more
Yes,
common in
yeah,
immunocompromised,
HIV, yes, ma'am.
in
Yes.
immunocompromised patient.
Thank you. Next is Dr. Yogesh Garg, and his case is immune-mediated necrotizing myopathy.
Good evening all. Today I am presenting a case report on immune-mediated necrotizing myopathy. Introduction. Immune-mediated necrotizing myopathy is a subtype of idiopathic inflammatory myopathies characterized by subacute symmetrical proximal muscle weakness, markedly elevated creatine kinase, and histological findings of muscle necrosis with minimal inflammation. Unlike polymyositis and dermatomyositis, immune-mediated necrotizing myopathy lacks skin involvement and responds variably to immunosuppressants. Diagnosis involves clinical features and creatine kinase elevation, EMG, MRI, and serology that are anti-SRP and anti-HMG coreductase antibody, and biopsy confirmation. Case presentation: a 37-year-old female presented with progressive bilateral upper and lower limb weakness over 1 month. Symptoms started after an episode of food poisoning and included difficulty climbing stairs, rising from a seated position, and raising arms above the head. There was no facial, ocular, and or bulbar involvement present. No bladder or bowel incontinence was reported. The patient required assistance in daily activities like dressing and eating. On examinations, vitals were stable and muscle power was reduced symmetrically in both upper and lower limbs. 3/5 in proximal groups. Reflexes were preserved, sensory system and cranial nerves were intact. Intervention: on initial investigations, hemoglobin was 10.2 and creatine kinase on 27th November 24 was 7844. And after treatment, creatine kinase on 27th December was 236. Anti-HMG coreductase antibody was negative, C3, C4 normal, ESR was elevated, ENA panel and myositis panel both were all negative. Additional workup was done: ECG normal rhythm, normal sinus rhythm, chest X-ray was normal, ophthalmologic evaluation, no retinopathies or papilledema noted, GI endoscopy and colonoscopy normal. MRI thigh was done, suggestive of diffuse muscle edema with query necrosis. Muscle biopsy confirmed necrotizing myopathy. Management initially was started on IV steroids. Pulse therapy was given by tapering oral steroids. IV methylpred 500 mg for 5 days was given, followed by oral steroids. Immunosuppressants, methotrexate started. Supportive physiotherapy and nutrition was given. Monitoring of creatine kinase levels and functional improvement. Patient showed clinical improvement by day 7 and was discharged with advice for follow-up in medicine OPD. In this picture, a distinctive violet color rash with possible swelling suggestive of heliotrope rash is seen. And on MRI picture of right thigh, intramuscular planes with fluid collections and diffuse edema is seen. Discussion: immune-mediated necrotizing myopathy is frequently underdiagnosed due to its overlap with other myopathies. It is not always associated with anti-HMG-CR or anti-SRP antibodies as in this case. Creatine kinase levels may be extremely high and correlate with disease severity. Biopsy remains the gold standard for confirmation, and prompt steroid initiation is the key to halting muscle necrosis. Negative myositis panel do not exclude immune-mediated necrotizing myopathy, especially in seronegative subtypes. So conclusion: immune-mediated necrotizing myopathy should be considered in any patient with unexplained progressive symmetrical proximal muscle weakness and high creatine kinase levels. Early recognition and aggressive immunosuppressions are essential for recovery and functional independence. Thank you.
Actually, what made you think that it is a immune sort of related to immune?
So patient was giving initial history of loose stools 3 days back. While after 3-4 days, the weakness and lower limb weakness started. Patient was having loose stools and by eating raw vegetables. After the 3-4 days, she started having difficulty in getting from toilet seat. And initially that progressed to upper limbs, proximal arm. And sir, we ruled out GBS, no distal involvement was there as history of loose stool was present. So we thought.
Why not botulism?
We have to exclude the other causes of. You said there was a rash on the face, na?
Yes, sir.
And it does show that, na? I mean, a young patient, particularly female, myositis. Again, you see, I think with things like SLE and all those things.
Yes, sir. Sir, we suspected that also and sent ENA panel. It was all negative, and myositis panel was also all negative. And we ruled out polymyositis and.
Because since skin is involved, you see, then you say polymyositis, dermatomyositis still come in the differential diagnosis of this myositis.
Yes, sir. Sir, we initially thought, but on muscle biopsy, though no perifascicular atrophy was seen, only necrotizing with regenerative fibers was seen, and MRI was also done early, and diffuse edema was seen in thigh muscles.
I feel you still keep the patient under your observation. You see, probably you might get something more than what we are thinking.
Yes, sir. Sir.
Thank you.
Thank you, sir.
Last one.
The next is Dr. Menika from Freeport. I can't pronounce the syndrome because I've never heard of it. It's a Rousseau-Dorfman disease. That is something new to me.
So good evening everyone. Today my poster presentation is on topic Rosai-Dorfman disease. That is beyond the lymph node, the spectrum of Rosai-Dorfman disease. So first of all, regarding its name, Rosai-Dorfman disease is based on the name of two pathologists, that is Joan Rosai and Ronald Dorfman, which were two pathologists working in USA, and they designed the name for this disease. So first of all, introduction. Rosai-Dorfman disease is a rare, usually self-limiting disease caused by histiocytic proliferation of unknown etiology in lymph node sinuses and extranodal tissues. It was previously described as sinus histiocytosis with massive lymph adenopathy. You know, the disease is derived from the overproduction of monocytes, macrophages, which leads to accumulation in the affected tissues. It usually presents with massive lymphadenopathy but can also involve extranodal tissues such as skin, liver, spleen and CNS, and can also mimic a lymphoproliferative disorder. Although in its classical form, it usually presents as massive bilateral cervical lymphadenopathy. It is frequently multifocal and evaluation of other areas must be considered. The involved gastrointestinal tract in RDD is the least common extranodal involvements. So case report, an 18-year-old female presented to the medicine department of GGS-MCH Faridkot with a 6-month history of fever, cough, lymphadenopathy, abdominal distension and generalized body ache with no past history of tuberculosis. Past medical history and drug history, they were insignificant. General physical examination revealed average billet, mild pallor along with generalized lymphadenopathy and cutaneous hyperpigmented plaques. All lymph nodes were non-tender and they were firm inconsistency. On abdominal palpation, there is massive splenomegaly along with there is a hepatomegaly present. A provisional diagnosis of generalized lymphadenopathy, query lymph proliferative disorder was kept and patient was admitted for further evaluation. So in a routine investigations, pancytopenia was there, peripheral smear show anemia and raised ESR was there. Chest X-ray was done and it showed clear lung fields and ultrasound was also done, which revealed hepatosplenomegaly with lymphadenopathy. And then the FNAC was done. With FNAC was taken from cervical lymph nodes and it showed lymphoid cells with scattered histiocytes with focal and peripoiesis suggestive of Rosai-Dorfman disease. Patient was put on steroids and the lymph node size started decreasing and the patient improved. Next is discussion. So Rosai-Dorfman disease is a rare, self-limiting disease with unknown etiology. It has two forms, classical form in which cervical lymph nodes are involved and extranodal form in which any other body organ can be involved. Most common extranodal site is skin and other organs like our brain, our other lymph nodes of axillary area, inguinal area, it can also be involved. And although any age group can be involved, but 80% cases manifest within the first 2 decades of life, because in young patients there are more viral triggers, there are more autoimmune diseases, so that's why it is more common in the first 2 decades of life. Classically, it presents with bilateral, painless, massive lymph nodes. Extranodal manifestation can be seen in 40 to 45% patients as involvement of skin, subcutaneous tissue, orbit, breast, bone marrow and abdomen. FNAC has important role in diagnosis of RDD. Differential diagnosis can be any lymphomas, disseminated TB, Langerhans cell histiocytosis, malignant histiocytosis, or any viral infection like HIV, Epstein-Barr virus, etc. So conclusion, it must be considered as differential diagnosis in patient who presents with bilateral or generalized lymphadenopathy with multi-system complaints, as the disease can present with various characteristics and it is a close mimicker of lymphoproliferative diseases. Thank you.
First of all, big thank you for adding to my knowledge at least something new in last 50 years of my practice. And I think it is basically a pathological diagnosis than a clinical diagnosis. Okay? And still we don't know the etiology, basic what is the etiology. I mean that can be anybody's guess. So in future that anybody coming with the lymphadenopathy, it must come under the differential diagnosis of lymphadenopathy. The treatment you say is only steroids.
So it can be steroids, it can be surgery if you know there is a mass which is if the steroids patient nahi respond kar steroids ko, we can get help of surgery. Radiotherapy.
But surgery, how many lymph nodes you can take out?
Like any focal mass we can take.
Very good.
What was the CBC of that patient? Ma'am, in CBC there was anemia, Pancytopenia was there. HB was nearly 8.9, WBC was 4.19, and platelets 135.
That means it is affecting the bone marrow also.
Ma'am, but FNSC showed emperipolysis, so that's why we kept diagnosis. And patient has skin lesion, so that is also. बट उसमें मैम लिम्फोसाइट्स का नंबर इतना ज़्यादा नहीं था malignancy में जैसे बहुत ज़्यादा होता है समझ
It's depend on that stage of disease. Okay, why your patient have liver and spleen palpable?
Because there may be ma'am extranodal involvement.
Extranodal involvement. In this syndrome, whether the liver and spleen palpable?
On ultrasound it was there, but on palpation it was not.
What is the characteristic of your this rare disease? The liver and spleen get involved or not?
Clinically it was not, ma'am. But on examination, on scan it was there.
Okay.
Yes, in this disease it is a feature. Yeah.
So how many cases in the literature have been reported of this sort of a disease?
1 in 2 lakh patients in like prevalence. Yeah.
So you must sort of report it into the journal or somewhere, you say. I mean, something rare like this. Okay, thank you.
Characteristic of this disease?
Ma'am, bilateral cervical lymphadenopathy.
Maybe in so many conditions. What is the diagnostic of this disease?
The histopathology. She is asking what is.
So in histopathology, what you get?
Emperipolysis is the term we use, that there is a engulfment of the cells, but they are not attacked by the cell which engulfed it. For example, in Langerhans cell histiocytosis, the cells which are get engulfed, they are destroyed by the enzymes. But in this, they are not destroyed by the enzymes. The cytoplasm, the nuclei all remains, when they are not attacked by the enzymes. That's why.
Thank you. Thank you very much.
Thank you, sir.
So we have come to the last sort of poster presentation, case presentation by Dr. Bahadur Varun Kumar from Faridkot. And the case is bilateral renal artery stenting in a young patient with bilateral renal artery stenosis. Dr. Bahadur Varun Kumar.
Good evening, everyone. Good evening to all the faculty members. Today I am presenting the poster presentation on bilateral renal artery stenting in a young male with bilateral renal artery stenosis. Renovascular introduction. It is a renovascular hypertension accounts for almost half of the hypertension in the general population, but plays a major role in treatable cases for the hypertension in the young. The entity consists of renal vascular atherosclerosis, commonly seen in the elderly population, and renal fibromuscular dysplasia, 10% predominantly seen in the young. We here presenting a case of a young patient with bilateral renal artery stenosis with uncontrolled hypertension, which was not controlled even after taking 3 antihypertensives at a maximum tolerated doses. Patient also presented with the features of congestive cardiac failure. Patient improved with bilateral renal artery stenting, now on medical management with the general condition. Thus, the renal artery stenting can be a good option to consider in a young patients with renal artery stenosis. I am presenting a case report of a 22-year-old female presented to us with the chief complaints of breathlessness since 1 month, which was associated with orthopnea and PND. There is no history of chest pain, syncope, decreased urine output, pain in abdomen, or any focal neurological deficit or the similar episode in the past. Among the past history, patient gave the history of hypertension since last 2 years, which was poorly controlled after taking 2 to 3 hypertensive medications at a maximum doses. There is no history of diabetes mellitus, tuberculosis, bronchial asthma, or epilepsy. No history of any addiction. Patient was vegetarian and died with normal bladder and bowel habits. On examination, patient was conscious, oriented to time, place, and person. BP was 180 by 100 at the time of presentation. Pulse was 104 per minute regular. SpO2 94% on room air. Temperature was 97.6 degree Fahrenheit. Pallor and pedal edema were present. No icterus, clubbing or cyanosis were seen. JVP was raised. On CVS examination, we got a systolic murmur heard radiating to the axilla. On the respiratory examination, bilateral fine crepitations were heard. PA and CNS were within the normal limits. Special investigations. We started off with the routine investigations of the CBC, where HB, TLC and platelets were within normal limits. RFT serum creat was 2.2, blood urea was 63. LFTs were within normal limits. Electrolytes, serum sodium were 126, potassium 3.6 and chloride were 89. Viral markers were non-reactive. Urine routine was also normal, suggesting of 1 to 2 pus cells, epithelial cells around 6 to 7. ANA was also planned to rule out the differentials, which shows a positive titer of 1:80 with the intensity of 1 plus with speckled pattern. ECG was of normal sinus rhythm. 2D echo was also planned, which suggestive of global hypokinesia of the left ventricle, but there were normal chambers with severe LV systolic dysfunction. Ejection fraction was 25% with moderate MR and TR. USG whole abdomen suggestive of liver of the normal size and shape with homogeneous echo texture. Spleen was normal. Pancreas were normal. Both the kidneys normal in shape with the right kidney measuring around 8.8 into 3.5 centimeter and left kidney of 8.9 into 4.6 centimeter. Renal artery Doppler was also planned because it was a young hypertensive female with suggestive of bilateral generalized renal artery narrowing with thick wall and high velocity renal artery flow with bilateral renal perfusion of the parenchyma. CAGs was not significant of any coronary artery disease. Renal angiography was also planned with suggestive of ostial occlusion of the right kidney, which was 100% occlusion. Left kidney was 90% stenosed. Stenting was done in bilateral renal artery. TIMI 3 flow was achieved. Procedure went uneventful. On the discussion part, renal artery stenosis is one of the important causes of renovascular hypertension in young patients. These patients may present with hypertension and flash pulmonary edema. Sudden worsening of hypertension or kidney function may occur. Acute kidney injury or decreased kidney function may occur after the initiation of the antihypertensive therapy, especially with ACE inhibitors or ARBs. An increase in serum creatinine level of more than 15% in this setting is strongly suggestive of renovascular disease. Congestive heart failure may occur with poorly control of the hypertension and renal insufficiency in the absence of a significant disease in the ejection fraction, so-called flash pulmonary edema. Although the flash pulmonary edema has been reported in patients with unilateral renal stenosis, it occurs more commonly in patients with bilateral renal artery stenosis. Patient may also present with transient ischemic attack, stroke, cardiovascular disease or peripheral vascular disease. Patient may get benefit from surgical revascularization or by the angiography or stenting both. But stenting shows superior results in young patients with bilateral renal artery stenosis in terms of clinical benefit, control of hypertension, with lower requirement of antihypertensive medication. In the conclusion part, renal artery stenosis should be suspected in young patients with uncontrolled hypertension and congestive cardiac failure. And renal angiography followed by stenting is always a better choice to achieve immediate clinical improvement and control of hypertension with strong long-term effects. Thank you, sir.
Thank you. I think very nice case presentation. And I mean, the standard teaching is that any young patient, hypertensive, and being not controlled on drug, you see, there must be some reason somewhere. Yes. And probably renovascular is the most important cause of the uncontrolled hypertension in young patient, you see. As you say, probably stenting is the only treatment, you see, part of the treatment. Yes, sir. You say it's an option, it's not an option, you say. If you have a renal artery stenosis, you have to open it. Yes, sir. There's no second thought about it. You have to open it.
Your patient have high blood pressure, yes, your patient have MR, your patient have less ejection fraction, but still the ECG is normal?
Ma'am, ECG was normal. At the patient presented 2 months before also, and we put the antihypertensive medications. First we started her on the antihypertensive medication at the start. There was an increase in, at that time RFTs were absolutely normal when we started on 3 antihypertensives. Sir, we started her on ARBs and AS plus hydrochlorothiazide.
Here, creatinine
yes,
is
sir.
So much high. ARBs?
No, sir, that time we were not, that time we were not suspecting. Yes, sir. No, sir. That time the CRAD worsened. Then only we were suspect that it is a young female, it should be a renovascular cause, and that is why we got.
No.
Ma'am, at the, I was not discussing this case. I was discussing 2 months prior when she presented us at the first visit. At that time, the RFTs were absolutely normal. Then her CRAD was 0.9, and then we started her on ARBs. Okay. Then we suspected her for the renovascular disease.
Because of renal arteriostosis, when you started ARB, that made things worse.
Yes, sir. At that time also, ma'am, ECG was normal. At this time also, there was a ST depressions, but that was not much more significant. It was a flank pulmonary edema when the patient presented.
I think so.
Sir, a young hypertensive female should always be first screened for the
The only thing, maybe the bilateral part is maybe
yes,
a little unusual.
Yes, sir.
Usually we normally see the unilateral renal artery stenosis.
Yes. Yes.
Anyway, good, nice, thank you.
Thank you.
So we come to the end of today's session, and probably all of you must be exhausted, tired by the scientific sort of information.